Yes. Hi. Hi, John.
How are you doing?
I'm fine.
I see. You got your jacket because it's cold out, right?
Hi. It's great to see you again. How is it with that lounge? You will send me the link during the lecture, or how is that?
Oh, I show you after you talk.
Let me put down the volume of the TV, which is behind me.
Okay.
All right, tell me.
Okay, at the end of your chat, okay, I'm gonna send you a link in the chat of another Zoom room to go to. Okay, in other words, after you finish your talk, you get off this Zoom and go to another Zoom.
All right. Do I need to leave this one or not?
Yes, you do need to leave because everybody's computer can only do one Zoom at a time. You know, so you can't
so
do
if you
both.
will send me on chat the link, I first hit the link and then leave the meeting.
Right. Well, we'll tell you on camera. Sam will say, okay, Vlad is going to the lounge and here's the link. Yeah, because people in the panel may want to go with you to that Zoom to
All
talk
right,
to
so
you.
I shall hit the link and then I shall leave this seminar. Am I right?
Right, right.
And then I can return
then you open the other Zoom
the
room.
other lounge and
Yeah.
then again join this one.
Right, right. Just and
All
then
right.
take the original link to come back here.
Very good. John, I'm
It's-
going to switch myself off since I'm having lunch now.
Oh, okay, okay. I gotta do
Okay.
some. I'll see you soon.
See you soon.
Yep. Oh my God.
Hey, John, good morning.
Hey, good morning. How are you?
Good to see you. Good, doing well. What about you?
Good. Where are you at?
I'm in Virginia, Charlottesville.
Oh, okay. And you're speaking today, right?
Yes, sir. My
Okay.
talk is the second talk.
Oh, okay. Very good. How are things in Virginia?
It's going well. The weather, not too cold yet.
Where are you
And
at? I was in Roanoke for a while.
Charlottesville.
Oh yeah, beautiful. I love the western part of Virginia.
Yeah, this beautiful nature. Absolutely.
Yeah. It's a gorgeous part of the country.
Absolutely.
When because I live up north, I grew up New England and lived in Florida. I used to drive through that part of Virginia on Route 81.
Oh, okay.
It's a beautiful road to drive on.
Yeah, I spent 2 years in Gainesville, Florida, John.
No, I'm not.
No, me.
Oh, you're
I
from Gainesville.
No, I spent 2 years in Gainesville, Florida with Dr. Rotan. Dr.
Oh,
Rotan.
wow. That's great.
Yeah, I love Florida too. It's a beautiful state.
Well, it's funny that Gainesville is different from the rest of Florida. I don't
Yeah,
know
I
if
know.
you spent some time in Florida, but it's pretty flat, nondescript palm tree, but Gainesville's nice.
Yeah. Sameh, good morning. How we doing? Sameh? Dr. Sameh, how we
morning.
doing?
Good morning, dear brother.
Good to see
How
you.
are you,
Good to
Kat?
see you, brother. Thank
Good to
you.
see you too. Thank you. Is Professor Musa available? I don't see him.
I just talked to him like 20 minutes ago. It should be available. So should be here. So I can text him. Let's see.
Okay. John, please make me a co-host.
Hello there.
I know
Hello.
her.
Hello there.
I don't see your face, but I recognize your voice.
Oh, really? No. I'm not, not in the panelist list. That's why you can just hear my voice and can see
There
my
you
details.
are. Okay, let me try to promote you there.
Okay, thank you.
Yeah. There you go. You're in now. Oh, Sam, let me make you administrator.
Hi. How is doing, sir?
I am fine. Good to see you, Mo. How are you?
Thank you. I'm doing amazing, and many congrats on such a wonderful educational activity. This is amazing. I've been busy yesterday at my own presentation as well on 2 other webinars, but I went into your as well. So amazing. I'm just, you have outdone yourself. So, mashallah. Many congrats to you.
Thank you.
Okay, Sam, you're co-host. You should be able to do everything. Oh, great. The lounge
I hope
is
so.
open. The lounge is open, Sam.
It's okay.
So let's tell the first speaker about it before we start.
Okay, 1 minute to start. He is here now.
Is the first speaker here?
Yes.
I know. I'm just talking with him. So I just sent the link to him right now.
Yeah. Okay. No, that's okay. No hurry. We got time.
I found him and attendees and upgraded him just now. Professor Musa. It's okay now.
Yeah. Noor, good morning, by the way.
I see him.
Hi, good morning, Dr. Khan. How are you doing lately?
Thank you. I'm doing well. Thank you. Thank you so much. What about you?
Thank you so much. Have a wonderful day, and I'm a huge fan of all of your lectures. You've been doing so great, so good, so amazing.
Noor, do you know how to operate Zoom?
Zoom?
No,
sorry.
Yeah, because I can make you co-host. So
if you say so, I will be pleased to do it.
Okay, I don't know. Do you know how to work it or no?
No, I'm free today. I've got a free day today. We have off
Oh,
on.
okay, I'll make you
Friday.
co-host.
Okay,
And
if you say so.
you can admit people, and you can mute people that sometimes forget to turn their microphone off. Do you know what I mean?
Oh, yeah, okay, sure. I will be happy to. I'd love to.
Yeah, you kind of mute everyone that is has an
That
open
is
mic.
interrupting. Okay, that's it. Whoever is interrupting. So, do you want everyone to be on the panel, or do you want everyone to be to take part as a
Oh,
participant?
yeah, that's fine. That's fine. Trung, how you doing? You got in. You got in today. Trung, can you hear me?
John, we will start now.
Yes, I can hear you.
Oh, okay. You want to start now? You got the first speaker
Yep.
here, bro.
Yes, Professor Musa. Welcome, Professor Musa. How are you?
Okay. You're gonna start, right, Sam?
Okay.
Okay, and I'll go 10, 9, 8, 7, and then when I get to after I get to 1, you start. Hi, I'm Sam. You okay?
Okay, just announce about launch. If you
okay.
want to
Yeah,
say.
okay. Before we start, televising, I want to tell you guys about the Zoom Lounge. It's another Zoom that you can jump into. In other words, you leave this Zoom and you go to another Zoom. We call it the lounge. We hope to have students there and residents that can meet the speaker and talk to them and put a human side to this. So after who's the first speaker? Hello.
Professor Musa.
Yeah. Do you understand, Doc?
Thank you.
Do you understand what I'm saying? Like after you talk, I'm going to put a link in the chat.
Okay.
And you go to that Zoom. It's like with students there and residents. It's going to be private for you to interact or maybe answer questions. Okay. So at the end of this Zoom, we're going to say, okay, the doc's going to the lounge, maybe to answer questions. And then you leave this, take the link and go to the lounge. Is that confusing enough to you?
It's another Zoom room for questions and more discussion. So after finishing lectures, you will find the link in chat box. Please come and go there to more discussion and questions.
Dr. Sami, can't you make a breakout room instead? It will be, I guess, easier for everyone to follow if you just create a breakout room.
Okay, no, we're ready to start. Excuse me. Okay, Sam, you ready?
Yep.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi, dear friends, brothers, and colleagues. It's a start of new day and start of second day of Skull-Base Congress of EWNC Academy. And we will start our first lecture with Professor Musa. Please, Professor Musa, start sharing your screen. Thank you for joining us.
Do you hear me? Do you hear me?
Yes, loud and clear.
Good afternoon from Istanbul. And I want to say good morning or good evening, other parts of the everyone. And first of all, I would like to thank to you for kind invitation and for this wonderful organization. Let's talk about the skull base anatomy. And skull base anatomy is a complex and intricate structures. And this complexity poses the challenge neurosurgeons. And skull is can be divided neurocranium and viscerocranium. And neurocranium also can be divided calvaria and skull base. Skull base is a part of the inferior of the skull, and calvaria is the top of the skull base. And several bones comes together and makes skull base. And let's general aspect of the skull. We see the frontal bone. Frontal bone is houses frontal sinus and contributes the orbital part of the skull. And you see the nasal bone. Nasal bone is makes a bridge of the nose. Maxillary bones you see here and makes the part of the face, and mandible and zygomatic bone. Zygomatic bone is contributes the lateral wall of the orbit and also the makes together arcus zygomaticus. And sphenoid bone. Sphenoid bone is important structure of the skull base. You see the here greater wing of the sphenoid and lesser wing of the sphenoid. Between ovas, superior orbital fissure is seen, and the lesser wings and the body of the sphenoid, you see the optic canal. And laterally, you see the lacrimal bone is not part of neurocranium, but is part of viscerocranium and ethmoid bone. Ethmoid bone also is important part of the neurocranium. And laterally, we see the paired parietal bone and part of the calvaria. And if you see the frontal bone and maxillary bone, zygomatic bone, and sphenoid greater wing, you see here. And we see also the temporal bone and occipital bone. We see all parts of the bone and mandible and pterion. Pterion is an important landmark. We use many surgical approaches, and pterion comes together many sutures and like a H shape, and together makes pterion. Sphenoparietal suture, frontosphenoid suture, parietosphenoid suture, and temporosphenoid suture makes pterion. And pterion, meningeal branch of the arteries cross the pterion, and during the trauma, we seen epidural hematome. And last, posteriorly, we seen the occipital bone, sigmoid suture, and lambdoid suture. And let's go to the skull base. Skull base is have a two phase, endocranial phase and exocranial phase. Endocranial phase is seen, can be divided anterior fossa, middle fossa, and posterior fossa. And the anterior fossa you see here, and middle fossa you see the here each part, and also the posterior fossa. Exocranial part of the surface, many muscles attached to here and complicates the skull base. And also, as I told before, the endocranial surface of the skull base can be subdivided three parts. These are anterior fossa, middle fossa, and posterior fossa. Anterior fossa is composed of frontal bone, ethmoid bone, and lesser wing of the sphenoid bone. And anterior fossa's boundaries starts anteriorly the frontal bone, and anterolaterally also the frontal bone. Posterior border is bounded posterior margin of the lesser sphenoid wing, and medially is anterior border of chiasmatic sulcus, also the bordered anterior fossa. And anterior fossa contains the olfactory bulb and cerebral hemisphere of the frontal lobes. And let's go to the anterior fossa, zoom in. You see here the cribriform plate of ethmoid bone. Ethmoid bone has many holes, and olfactory bundle seats the cribriform plate, and bundle goes this hole to the nose. And another part of the crista galli is also the ethmoid bone part, and extending superiorly to the cerebral hemisphere and attached to the falx cerebri. And we see the anterior of the crista galli, we see the frontal crest. And ethmoid bone is contributes many structures, also medial wall of the orbit, and you see the anterior and posterior ethmoidal foramina, optic foramen, also optic canal, and superior orbital fissure we see the here. And when we look at the ethmoid bone superiorly, we see the crista galli and cribriform plate and labyrinth. Labyrinth has a ethmoid air cell and also lateral wall of the ethmoid as part of the medial wall of the orbit. You see the ethmoid bone also articulates many bones. And here is the articulates with sphenoid. You see this sphenoid bone, greater wing, lesser wing, and crista galli, and perpendicular plate of the ethmoid bone divides the nasal septum, and also the pterygoid process of sphenoid bone. And let's zoom in the anterior fossa. We see the planum sphenoidale. Planum sphenoidale is connects between two lesser wings, and below this structure we see the sphenoid sinus. And let's go to the other part of the anterior cranial fossa. We see the anterior clinoid process. Anterior clinoid process is important landmark of our surgical applications. And the lesser wing of sphenoid goes down and forms the anterior clinoid at each side of the anterior fossa. And the medial part of the anterior fossa, we see this edge is limbus of the sphenoid, sphenoidale, and also the anterior margin of chiasmatic sulcus. And let's totally, when we look to anterior fossa, we see the frontal sinus, and frontal sinus, posterior wall of the frontal sinus is an anterior border of the anterior fossa. When we go to the down, we see the frontal crest, and we see the foramen secum. There are many openings from the anterior fossa to other structures. Firstly, we see the foramen secum. The foramen secum opens to the nose and superior sagittal sinus in emissary veins. Sometimes it ends blindly. And you see the crista galli ends attached to the falx cerebri. And there are cribriform plate and many holes, and the olfactory nerve bundles goes to the nasal cavity. And as I told before, also anterior and posterior ethmoidal foramen, and it goes the arterial and vein. Let's go to the middle cranial fossa. Middle cranial fossa is wider than the anterior fossa and deeper than the anterior fossa, mainly formed by sphenoid bone, sphenoid greater wing, body of sphenoid, and also the squamous part of the parietemporal bone, and petrous part of the posterior aspect of petrous part of the temporal bone. And the medially is the limit is dorsum sella. And as I told you, in middle fossa consists of two bones, sphenoid bones and temporal bones. Sphenoid bones is symmetrically and resembles a butterfly. And temporal bones is also important structure house and housing the inner and middle ear also. And when we look at the this picture, we see the limits of the middle fossa. And let's zoom in middle fossa. The limits of the middle fossa begins also the posterior margin of the lesser sphenoid wing. Medially is anterior margin of the chiasmatic sulcus, and the posteriorly is dorsum sella, and laterally is going to the temporal squamous temporal and some part of the parietal bone, and posterolaterally is delimited the petrous part of the temporal bone. As you see, in this area is petrous ridge, divides the petrous bone two face. This face is anterior surface, part of the middle fossa. Posterior surface is the part of the posterior fossa. And when we look at the middle fossa, this some important structures. Firstly, we have to say tuberculum sella. We see here tuberculum sella. And here is the middle clinoid process. And you see also anterior clinoid process and posterior clinoid process. And between the anterior and between the tuberculum sella and posterior clinoid and dorsum sella, there is a depression. The pituitary gland sits here. And also the lateral of the pituitary gland and carotid groove also here. Each side in carotid groove is here. And this part is optic canal. Optic canal is composed of the lesser wing of the sphenoid and the body of the sphenoid. And the other part, we cannot see here, but superior orbital fissure and inside, and we will see later. And here is the foramen rotundum. Foramen rotundum connects the middle fossa to the pterygopalatine fossa and transmits this foramen V2. V2 transmits this foramen. V1 goes to the superior orbital fissure. And then going to the below, when we go to the below, we see the foramen ovale. Foramen ovale is a big hole in the middle fossa. And foramen ovale transmits V3 to the inferior temporal fossa, infratemporal fossa, sorry. And we see another foramen spinosum. Foramen spinosum in middle meningeal artery branch is passed through inside. And we see another foramen, irregular foramen, is foramen lacerum. Lacerum foramen is not a real foramen because the fibrocartilage tissue filled them, but foramen lacerum transmits the great superficial petrosal nerve and deep petrosal nerve. It comes together and forms the Vidian nerve, and Vidian nerve is going to the Vidian, by the Vidian canal to the pterygopalatine fossa. And let's see lastly the superior surface of the petrous bone. We see the trigeminal, impressio trigeminalis, and as you know, the Gasserian ganglion sits here. And after the impressio trigeminalis, we see the elevation trigeminal prominence. We see the trigeminal prominence. In the posterior, the trigeminal prominence, we see the here and meatal depression, and we posterolateral to the meatal depression is arcuate eminence. Arcuate eminence indicates the superior semicircular channels, and lastly, the tegmen is a tiny part of the this part is very thin and connects, separates the brain from the middle fossa. And I want to show here the superior orbital fissure lastly, and superior orbital fissure between the greater wing and lesser wing. And as you know, V1, trigeminal V1 ophthalmic, and 3, 4, and 6 nerves, and superior ophthalmic when transmits the orbital to the orbital cavities. And let's go to the posterior cranial fossa. Posterior cranial fossa between the foramen magnum and tentorium cerebelli, and mainly composed of the occipital bone and petrous part of the temporal bone, posterior face of the temporal bone, and also mastoid angle. Mastoid part of the temporal bone contributes to the forming the posterior fossa. Anterior limit is dorsum sella, and posterior limit is inner crest of the occipital to the transverse sinus. And let's go to the another, seeing the zoom. And posterior fossa starts dorsum sella and forming the sphenoid part of the clivus and occipital part of the clivus. We see in here, this part is the sphenoid part, and upper to dorsum sella and posterior clinoid process. And we see the upper clivus, and then middle clivus. Middle clivus is a part of the occipital bone, and also the lower clivus, lower third of the clivus, you see here and near the jugular foramen, and is the foramen magnum. You see the lower clivus, and lower clivus and middle clivus together called basio-occiput. And we see the petroclival fissure is an important part of the posterior fossa. In this fissure, inferior petrosal sinus extending to the jugular foramen to the sigmoid sinus. And let's go to the other part of the posterior fossa, and internal auditory canal. We see the internal auditory canal and posterior face of the petrous part of the temporal bone. And let's zoom in internal auditory canal. You see the internal auditory canal is here, and jugular foramen is here, and we see the impressio trigeminalis also, and here is the carotid canal ends here, and we see the meatal depression, and we see the arcuate eminence, and we see the tegmen is here. This part of the posterior fossa, internal acoustic meatus, and 7 and 8 and nervus intermedius transmits this internal acoustic meatus. And internal acoustic meatus, posteriorly, we see here the vestibular canalicule is also. And then we see the groove is here, as this groove is sigmoid sulcus. And sigmoid sinus is runs along this groove to the pars venosa to the sigmoid sinus. And let's go to the other part of the posterior fossa. We see the jugular foramen. Jugular foramen transmits many nerves, and also the sigmoid sinus and inferior petrosal sinus. And we see, let's zoom in jugular foramen. You see the whole part of the jugular foramen, and jugular foramen is posterolaterally and posterolaterally to foramen magnum, and you see the jugular tubercle and its important landmark. And we see the petrosal part of the jugular foramen, and here in this part only the inferior petrosal sinus and cranial nerves 9 goes here, and middle part of the jugular foramen and 10 or 11 nerves, and this part is pars venosa sigmoid sinus is going to the here. And this is the sigmoid part of the jugular foramen. Sigmoid sinus and jugular bulb is inside here. And the other part of the jugular foramen, occipital process, and temporal process and occipital process dividing the jugular foramen. And we see the hypoglossal canal. Hypoglossal canal is anterolateral of the jugular foramen, and the hypoglossal canal, the 12 nerves is going to inside. And the largest foramen of the posterior fossa is foramen magnum. Foramen magnum housing the medulla oblongata and anterior and posterior spinal artery and vertebral arteries, and also the accessory nerve spinal parts housing. And lastly, we see the totally the posterior fossa, jugular foramen you see here, and here is the occipital squamous part of the occipital bone, and you see the each side foramen magnum, and here is the condylar part. And I want to consider again the sigmoid sinus is this groove, and you see, and the here is the transverse sinus. Each side transverse sinus continuously and as a at this angle continuously as a sigmoid sinus and goes to the jugular foramen. And here we see the also the occipital crest and internal protuberance of the interna. And let me look skull base exocranial surface. Most part of the occiput you see here, and the other part of the exocranial surface we see the occipital part and condyles and mandibular fossa, also styloid process you see, and you see the carotid canal and foramen ovale and and other parts of the exocranial surface and vomer and sphenoid bone and pterygoid process. We see this part is important. Here is the infratemporal fossa. Infratemporal fossa, many surgical approach making this fossa. And you see the temporal bone is a big part of the exocranial surface. You see the petrous apex, each side, and mandibular fossa, styloid process, and carotid canal we see, and little part of the parietal bone, and also the condylar process. And we see the palatine bone. Palatine bone is not part of the neurocranium, is part of the viscerocranium, and sphenoid. And I want to show again here is the infratemporal fossa here. This limitation is infratemporal fossa. And you see the vomer and maxillary part and petroclival fissure, the exocranial surface you see the here, petrous apex and clivus, and this is the jugular foramen, occipital condyle, And here is the foramen lacerum, ovale, you see. And here is the Vidian canal. We can see here the temporal part of the exocranial surface. I wish everyone many successful surgeries in the light of anatomy. Thanks for your attention.
Thanks, Professor Musa, for this informative, nice lecture. Is there any question from panelists? Okay, sir, please shift to lounge Zoom room for more question and discussion. And now we will shift to next speaker, Professor Ken Yagmulo. My dearest friend, please start sharing your screen. Thank you.
Thank you for my dear friend, Sami. Thanks for having me here. It was an excellent talk by Dr. Truck, and let's see. Can you confirm that you can see the full screen? You see the full
Yes,
screen, or?
Yes, it's okay, and sound is loud and good.
Okay, it's a full screen, right?
Yes, full screen.
All right, thank you. Thank you. Well, thanks again for this opportunity. And I would like to talk about the microsurgical and endoscopic anatomy of the skull base. So the outlines of my talk is I'm going to talk about the navigating the anterior, middle, and posterior cranial base. And then I would like to mention about the midline skull base structures through the nose. As we know, the cranial base has an endocranial surface. Let's see, okay. Can you see my scribble, by the way?
Yeah.
Okay.
Yes, yes.
Thank you. The cranial base has an endocranial surface which faces the brain, and exocranial surface which faces the nasal cavity and orbits, etc. The both surfaces are divided into three parts. See here, anterior, middle, and posterior parts. The border between anterior and middle fossa is a sphenoid ridge, joining medially chiasmatic sulcus and the anterior gluteate. And the border between the middle and posterior fossa is a petrous ridge, as we saw the previous at the talk. So the both surfaces are interconnected with the foramina fissures. And so underneath the anterior fossa, which is the exocranial surface of the anterior fossa, we see the orbits and the maxillary sinus. When we remove the maxillary sinus, the posterior wall of the maxillary sinus, here we see the pterygopalatine fossa, which is a part of the middle fossa, exocranial surface of the middle fossa. What's the other part of the exocranial surface of the middle fossa? So again, we are inferior to the middle fossa, and we see the pterygopalatine fossa. Here's the infratemporal fossa. And the temporal fossa is surrounded by the zygoma, and is going to be this part. Temporal fossa, infratemporal fossa, and pterygopalatine fossa are located exocranial surface of the middle fossa. This is, here we see the cranial nerves. The trigeminal nerve, which is the thickest nerve, is the key for the navigating of this, the fossa. If you follow the V1, we can get to the orbit in the anterior cranial base. If you follow the V2, we can get to the pterygopalatine fossa underneath the middle fossa. And if you follow the V3, we can get to the infratemporal fossa. The trigeminal nerve is the key to find all these fossa. Now we are looking from outside. This is a supraorbital nerve. A branch of the V1 is orbit. We see the V2 here. This is the pterygopalatine fossa. And here's the V3 within the infratemporal fossa. Just briefly, already Dr. Musa, the track mentions about it. Now we are looking into the posterior fossa and endocrinal surface. We see the petrous ridge here. This is the clivus of the occipital bone, and here's a squamous part of the occipital bone. Here we see the petroclival fissure. This is the petrous, and here's the petroclival fissure. Jugular foramen, and this is the jugular tubercle. Underneath the jugular tubercle is the hypoglossal canal, and here we see the foramen magnum. And of course, here's the sigmoid sulcus here. Now we are looking extracranial surface of the posterior fossa. This is front, and here is the back. And if we see the foramen magnum, and anterior half of the foramen magnum, we see the condylar parts, the condyles, occipital condyles. This is the hypoglossal canal. That hypoglossal nerve passes through the condyle. Behind the condyle, here's a condylar fossa, and here's a posterior condylar canal. So for the posterior fossa lesions, when we come from behind, so we use a craniotomy. It's called far lateral approach that has a couple of different variations. Sometimes we can move some part of the condyle, or sometimes we can go through the condylar fossa, or sometimes, depends on the location of the lesions, we also can drill the jugular tubercle, which is located just superior to the hypoglossal canal. Now, as we talk, there is the anterior, middle, and the posterior fossa. So what is the midline skull base borders? So anterior, posterior, in other words, so the axis through the nose. Let's talk about anterior, middle, and the posterior fossa. The midline structures access through the nose. The anterior midline skull base starts from the foramen cecum. In other words, here's the frontal sinus, just behind the frontal sinus, till to the tuberculum sella here. So what we see here, this is crista galli, which is attachment of the falx. Just next to midline, we see the curviform plates. And here's a planum, this flat area is a planum sphenoidale. This is the midline anterior skull base structures. So here's the middle skull base structures. We see the sella turcica. What else we see here? We see the anterior clinoid, tuberculum sella, middle clinoid can be exist 20–40% of the cases. And here is the middle skull base area. For the posterior skull base, the border is start from the dorsum sella all the way down till the craniocervical junction. So anterior posterior borders of the midline skull base structures. So also, I would like to say the most extension into the endocranial surface are become the recess on the exocranial surface. In other words, when we look through the nose, we can see mostly all these structures as a recess. This is the tuberculum sella, here's a tuberculum here. That is extension into the endocranial surface, and we will see it as a recess. So this is the anterior clinoid. We can also see it as lateral optical carotid recess. I will mention about it. We saw the anterior posterior borders of the midline skull base structures. Another question, what is the most lateral border of the midline skull base? In other words, what is the most lateral border of the axis through the nose and the nasal approach? For the anterior fossa, the imaginary line drawn from the lateral edge of the optic nerve to the mid-pupillary line. So I can reach this part coming from below through the nose. In other words, if tumor is located between these two lines, I can remove this tumor totally through the nose. But if the part of the tumor passes beyond that line, so I also need to do a transcranial approach. Only transcranial approach or combined. So what's the lateral border for the middle skull base? Here we see the cavernous sinus. For the posterior skull base, again, sorry, let's do it again. is the cavernous sinus. For the posterior skull base, the landmarks for the most lateral border is the foramen lacerum, petroclival fissure, which the abducens nerve runs at the same sagittal level of the petroclival fissure, and all the way down we see the hypoglossal canal. Here we see. So lateral to these borders, the transcranial approach would be more suitable. In other words, through the nose, the endonasal approach, we can reach to the anterior skull base, middle skull base, and the posterior skull base again. So this is the endoscopic standpoint, and we are looking at the ventral surface of the skull base and midline skull base structures. So what is the, again, what is the most lateral border of the midline skull base structures and lateral edge of the optic nerve to the mid-pupillary size? What was the anterior border? Was the frontal sinus till to the tuberculum sella here. I can reach to this part by coming through the below, by coming from below or through the nose. For the midline, I can reach the cellular fossa and the cavernous sinus. For the posterior skull base, here we see this is the ICS sock and foramen lacerum. This is the petrous bone, clivus, petroclival fissure was another landmark, and here's the hypoglossal canal. So I can reach this part too till to the odontoid process of the CT all the way down. So obviously, main obstacle for the endoscopic approach is the internal carotid artery. There are different classifications. There are different classifications for the carotid arteries, but endoscopic standpoint again, here we see this is the pharynx, right, and this is the petrous bone, and here's the foramen lacerum again. We see the clivus, and here's the sella. The endoscopic classification of the carotid arteries. This is pharynx, and this is parapharyngeal ICA. Carotid canal. After entering through the carotid canal, this is the petrous ICA, and here's the clivus, and this is the paraclival ICA. Sella just next to the sella is going to be paracellular ICA. Let's take a closer look again. So this is the petrous ICA, from foramen lacerum to the inferior border of the sella. It is paraclival. From the inferior border of the sella to the proximal dural ring is paracellular. Between the proximal and the dural ring is the paraclinate, and finally is the intracranial ICA. This is the basic classification. So what we see here, again, this is the inferior border of the sella. This is paracellular ICA from this level till to the proximal dural ring and the distal dural ring. If you see the proximal dural ring is incompetent, and usually, you know, the I can say like fuse not tightly, lose the fuse with the vessel here. So, but in presence of the middle clinate, we see the more robust the proximal dural ring. Between the proximal and the dural ring, the part of the IC is a paraclinate. Again. So the nasal mucosa covers all the inside the nose. So we have to know the bony anatomy to to work through it for removal of the tumors. So this is a sphenoid bone, and this is from Rotman collection. The rest of the slides my dissections. So let's take a look at the sphenoid bone. Here we see the lesser wing and the greater wing here. Temporal fossa, and here's the infratemporal fossa. We see the pterygoid process, right? And here's the Vidian canal, which runs the floor of the sphenoid sinus. In the center, we see the sphenoid sinus, and here's the crest, and here's the rostrum. The sphenoid crest articulates with the ethmoid bone superiorly and the vomer inferiorly. Vidian canal, and here's the foramen rotundum. Those are important landmarks for navigating sphenoid, the bone. This L-shaped bone is a palatine bone. This is the pterygoid process of the sphenoid bone, and this is the palatine bone. And between the space, between these bones called pterygopalatine fossa. And if we will see the foramen, the Vidian canal also is behind it. So also what we see here, there's a two crest here of the lacrimal bone. One is the conchal crest that inferior turbinate articulates. And here's the ethmoid crest, middle turbinate articulates. We also see here the sphenopalatine fossa, which is the parts between the parts of the lacrimal bone. Sphenopalatine fossa, middle turbinate, and inferior turbinate. In the midline, the inferior part of the sphenoid crest articulates with the vomer. Here we see. So what we see here, this is the palatine bone. Of course, some part of the palatine bone is removed, but here we see the inferior turbinate, we see the middle turbinate. Here's the sphenopalatine fossa. And what artery is that here? This is the maxillary artery, passes through infratemporal fossa and pterygopalatine fossa, and finally it becomes the sphenopalatine artery, that passes through the sphenopalatine fossa to supply the turbinates and the nasal septum. So if you look at this here, the middle turbinate and the sphenopalatine artery has a close relationship, anatomically close relationship. So we usually want to find the sphenopalatine artery either to kill it or to save it. So for this reason, I can use the middle turbinate to find the sphenopalatine artery. If I follow the lower surface of the middle turbinate, I can reach the sphenopalatine artery. What else we see here? This is the sphenoid sinus, and this is the vomer. The septal deviation is a common finding, and septal suture also, may form adhesions to the adjacent turbinates. We just wanna, we need to be aware of that kind of complication, variations before the surgery. So what we see here again, inferior turbinate, middle turbinate, and this is sphenopalatine artery that supplies the inferior part of the nasal septum. What about superior part? This is the anterior ethmoidal artery that supplies the superior part of the nasal septum, and the sphenopalatine artery supplies the inferior part of the nasal septum. Sphenopalatine artery is a part of the a branch, terminal branch of the maxillary artery. We are taking a closer look here. So this is the sphenoid ostium, and here's the choana. This space called sphenoid recess, and the sphenopalatine artery runs, travels to the places. This the sphenoid recess area. For the nasal septal flap, we usually cut 1 centimeter inferior to the cruciform plate, and here, and the pedicle of this flap is that area, the sphenoid recess, which contains the sphenopalatine artery. So we saw the sphenoid bone, and the bone sits in front of the sphenoid bone is the ethmoid bone. Ethmoid bone has a lot of plates. This is the crista galli. Next to it is the cribriform plates, perpendicular plates that articulate with the sphenoid sinus. Orbital plate, also called as lamina propria, and we see the ethmoid air cells. And of course, the middle turbinate is a part of the ethmoid bone. So now looking from above, crista galli, next to the midline, we see the cribriform plate, this narrow area, and lateral to the cribriform plate is the fovea ethmoidalis. So if you want to reach the most lateral border of the midline, anterior midline skull base, we need to work through this bone. And here we see the ethmoid bone again. This is the crista galli, and here's the orbital plate. This is the middle turbinate attachment. What is important? So the mid portion of the middle turbinate attachment is called as basal lamella, which is important. The structures. This is the attachment of the middle turbinate to the anterior skull base. In front of this line, the basal lamella is called anterior ethmoidal ear cells. Also, you can hear the ethmoid bulla, and behind is the posterior ethmoid ear cells. Let's see. Now we are looking through the nose right now, and here is the postpendicular plate that articulates with the sphenoid crest. Here's the middle turbinate, corresponds to here. And here's the ethmoid bulla, which is anterior ethmoidal ear cells. The basal lamella is more important for the ENT doctors and usually during the paranasal, the sinus surgery. So now we are looking at the, inside the nose again. We see the inferior turbinate, middle and superior turbinate. So after remove the mucosa, here we see again inferior turbinate. Inferior to the inferior turbinate is the inferior meatus. Inferior to the middle turbinate is the middle meatus, and inferior, just below to the superior turbinate is the superior meatus. Okay. When we place the ethmoid bone is here, let's see. So again, this is the middle, inferior, middle, and superior turbinates. We see the sphenoid sinus here. Here is the attachment. All these, the turbinates has an attachment to the anterior skull base here. Okay. Like this is sphenoid sinus attachment, and here is this part is the superior turbinate attachment, and this is the middle turbinate attachment, which is called as basal lamella. We see the uncinate process here and the maxillary sinus here. So in front of that basal lamella it is anterior ethmoidal ear cells, which is also called as ethmoid bulla, and behind is the posterior ethmoidal ear cells. It's important to know because depends on the location of the lesion. Sometimes we work only through the anterior ethmoidal ear cells or ethmoid bulla. Here's what we see, and we see the inferior turbinate, middle turbinate, ethmoid bulla is here. This is the uncinate process and the mastoid ostium. Sometimes here is also lamina propria, which is orbital plate of the ethmoid bone. Sometimes the orbit can bulge into the ethmoid bulla here. So we also want to be aware of that kind of variations in order to avoid the orbital penetration. The hint, the trick for this, we usually, this is sagittal CT, and this is the mastoid ostium, and the orbital plate of the ethmoid are usually aligned at the same sagittal level. If we see the orbital plate medial to the level of the mastoid ostium in the sagittal plane, we can see, the bulging of the orbit into the ethmoid bulla. We are on the right nostril. Middle turbinate is pulled medially. Here we see the uncinate process, and this is the ethmoid bulla. And again, some orbital, the tissue can be inside, can bulge inside this ethmoid bulla. Here we see. When we just pull the middle turbinate laterally, here we see the superior turbinate. Sometimes we also can see the supreme turbinate. And medial to this turbinate is going to be the sphenoid ostium. So here is again, so what we see, just looking for the cellular region, and the last part of my talk, we see the sella, clavus here, and carotid prominence. This part, this is the carotid artery. What we see, the optic nerves, both sides, and here is a tubercular recess, which corresponds to tuberculum sella. And the most lateral edge of the tubercular recess is the medial opticocarotid recess. And lateral here, this is lateral opticocarotid recess that corresponds to the optic strut, sometimes anterior clinoid. If the middle clinoid exists, we usually see the middle clinoid just 5 millimeter inferior to the medial opticocarotid recess. Another specimen, optic nerves, carotid artery. This is lateral opticocarotid recess. Medially, we see the tubercular recesses here, and here's a medial opticocarotid recess. And this is planus sphenoidale here. After removal the bone, we see cell leg and this carotid. We see here we see the lateral opticocarotid recess, which stands for the optic strut, sometimes anterior clinoid. Here's after removal the clear the dissections. The cavernous sinus laterally, and we see the internal cavernous sinus around the pituitary gland. So also, what else we see here? If we extend our bone removal laterally, we can also enter the cavernous sinus, lateral to the ICA here. What we see here, this is V1, excuse me, this is V2. Here's the foramen rotundum. V2 usually comes towards us, like the parallel to the floor. What else we see here? This is the V3, and here's the cavernous sinus. When we open this membrane, we can get into the cavernous sinus. And thank you so much.
Thanks a lot, dear friend, for your excellent presentation. And thanks, dear brother, for your help and great efforts to put this Congress with me together. Is there any question from panelists?
Then I'm leaving right now.
We can you can shift to the lunch for more questions and discussion if you have just 5 or 10 minutes.
Thank you.
Okay, thank you. And now we will shift to next speaker. Professor Goto, please start sharing your screen.
Okay. Okay, can you see my slide?
Yes, it's okay. And it's
Okay,
full screen.
Today, I feel very honored to have the opportunity to present my work in front of the many audience. Today, I will talk about the endoscopic skull-base approach to complicated skull-base tumors. At first, I would like to introduce my institute and myself. Department of Neurosurgery, Osaka City University is one of the largest skull-base centers in Japan. So our old mentor, Professor Hakuba, started the transcranial skull-base approach and rejected most skull-base tumor. And also my mentor, Professor Ohata, and I also use a transcranial skull-base approach to the skull-base tumor. But recently, endoscope can offer the wide, panoramic, wide, and clear view in the deep-seated area, and which largely contribute to the less invasive tumor removal of skull-base tumor. So recently, I applied the endoscope to many skull-base tumors. So today, I will talk about the endoscopic enonasal approach and endoscopic keyhole transcranial approach. At first, I will talk about the endoscopic endonasal approach. We already know that many skull-based tumors can be rejected by the classical transcranial skull-based approach like this. But actually, if the tumor located pure central skull base within this circle, which connecting the all cranial nerve, surgical resection seems to be very difficult. But recently, endoscopic endonasal approach dramatically changed this situation. If we access the central skull base by the endoscopic endonasal approach, the only obstacle to access this area is a bony structure, such as clivus, pterygoid bone, and petrous bone. So if we adequately drill out the all bony structure, we can directly access the central skull base without crossing over the cranial nerves. So I will show the several cases. This is the retrochiasmatic craniopharyngioma referred to as a tumor protruded to the posterior fossa. But if we choose the endoscopic endonasal approach, we can directly access within the circle of Wills. Of course, in some situations, it's very difficult to access the lateral margin of the tumor. In such situation, if we drill out the bilateral posterior crinoid process, we can completely access the lateral side of the tumor. I will show the surgical video. At first, I widely drill out the bony structure and then cut the dura mater. This is a pituitary stalk and a pituitary gland, and this is a posterior crinoid process. I carefully drill out the posterior crinoid and then remove it. This is a pituitary gland. I dissect the pituitary gland from the medial wall of cavernous sinus and then mobilize to the left side. Then I cut the dura mater and go into the subdural space. This is a basilar artery, this is a tumor, and this is a oblique pituitary stalk. Using this approach, I can safely reach the border between the tumor and neural structure, and then carefully dissect the capsule of the critical structure. Now, in this case, we could preserve the pituitary stalk and gland. This is a pituitary stalk. I carefully resected out and totally tumor removal was achieved. Postoperatively, all tumor was successfully resected out. Of course, we need some replacement, includes a corticosteroid, but we can prevent the DI and deficit of thyroid hormone. This is another case of the large diaphragmocellular meningioma compressing the hypothalamus. But if we access the endoscopic endonasal approach, we can directly access the attachment of the tumor. In the skull-based surgery, directly access the attachment or origin of the tumor is very important surgical strategy. I mobilize the pituitary gland to the right side and reach the diaphragmocella. This is the attachment of the tumor. So I already devascularize and detach the tumor of the diaphragmocella and then carefully dissect the tumor of the PCOM or critical structure. In this approach, we can directly observe the border between tumor and critical structure. So careful dissection was relatively easy. I expose the oblique chiasma and remove the tumor safely. Postoperatively, we made the large dural defect So we have to watertightly seal the dural defect. At first, I insert the fat tissue to the subdural space and put some suture to the dura mater. Of course, no need to watertightly suture, but put some stitch was very important to fix the fat tissue, and then covers a large mucosal flap. Postoperatively, all tumor was successfully resected out with preservation, his memory and vision, and we could preserve the prevent the CSF leakage. This is another case of the posterior crinoid meningioma. This meningioma purely located within the circle of Willis, so transcranial approach seems to be very risky to injure the perforator. But if we access through the endoscope, we can directly reach the posterior crinoid. I will show this video. This is a pituitary gland, and I elevate the pituitary gland and expose the right posterior crinoid process. This is a carotid artery. I mobilize the carotid artery to the lateral side and drill out the posterior crinoid process. Now, this is the attachment of the tumor. So I coagulate and cut the attachment of the tumor like this. This is a pituitary gland. Now already we detach and devascularize the tumor. So now tumor changes the bloodless. So we could safely dissect the tumor of the pituitary gland and the stalk and oculomotor nerve. Finally, all tumor was safely resected out. This is oculomotor nerve and PCA and PCOM, pituitary stalk and pituitary gland. In this case, we could preserve the completely pituitary function, and the tumor was successfully resected out without any deterioration of symptoms. This is another case of the lower clival meningioma compressing the brainstem, causing the right facial spasm. If we choose a transcondylar approach, we have some risk to damage the lower cranial nerve, or if we choose the transpetrosal approach, we have some risk to damage the abducens nerve. But if we choose the endoscopic transcribal approach, we can directly access the attachment of the tumor without damage of the sixth nerve or lower cranial nerve. So I choose the endoscopic endonasal approach. Now I drill out the lower clivus completely and also drill out the jugular tubercle, and then cut the dura mater. After bone work, tumor already devascularized, so we could safely perform the internal decompression without encounter the large bleeding. So surgical field was very bloodless and clear, so it's relatively easy to identify the border between tumor and the critical structure. This is a hypoglossal nerve. I resected the tumor very carefully from the hypoglossal nerve and the basilar artery. And this is a PCOM. And this is the tumor ventral side of the lower cranial nerves. I carefully resected out, then moved to the lateral margin of the tumor. This is the abducens nerve, and I resected out and reached the ventral side of the 7th and 8th nerve. And then now we confirmed most part of the tumor was successfully resected out and decompressed. Postoperatively, almost all tumor was successfully resected out, and her facial mask disappears. and we could not cause any deterioration of the cranial nerves. This is another case of the recurrent lower clivus meningioma. This case also attachment is here. So if we choose endoscopic endonasal approach, we can directly access the attachment of the tumor. This is a surgical video. At first, I widely drilled out the lower clivus and then reached the lower clivus. Now, I already coagulate the attachment of the tumor. So when we cut the dura mater, tumor already changed the vascular tumor. So I could carefully resect it out. This is the abducens nerve. Tumor at first compressed the abducens nerve upward, but dissection of the tumor from the abducens nerve was relatively easy. Tumor was decompressed, and also abducens nerve is relieved. I gently mobilize the tumor and find out the ichor and dissect the basilar artery and lower cranial nerves. I dissect the tumor piece by piece. And this is the final remnant of the tumor around the pont-medullary junction. This is a facial nerve and dissect the remnant of the tumor. Fortunately, this tumor was very soft, so I could totally resect out the tumor without any deterioration of the cranial nerves like this. Postoperatively, all tumor was successfully resected out without any deterioration of symptoms. Then I will explain the endoscopic keyhole approach. In some tumor, of course, we need the transcranial approach, but if we use the endoscope, we could resect the tumor with minimum invasive procedure. At first, I will show the anatomy of the endoscopic keyhole subfrontal approach. Usually, I put the skin incision over the eyebrow and then make the craniotomy with the size of 3 centimeters. And then gently insert the endoscope to the frontal base. I know we could observe the olfactory tract and the proximal sylvian fissure, and then ICA, third nerve, and then I move the endoscope more medial side. We could expose the optic chiasma, tuberculum sella, and then we could open the optic canal using the diamond drill. After this anatomical procedure and training, I applied this technique to the tuberculum sella meningioma. At first, I put the small craniotomy with the size of 3 centimeters, and then gently insert the endoscope to the subfrontal space. This is the attachment of the tumor. Frontal lobe was not retracted, but we could identify the attachment of the tumor at the early stage of the surgery. And then I completely drilled out the superior wall of the left optic canal, and then cut the dura mater to decompress the left optic nerve. Using the unilateral subfrontal approach, we could observe the medial surface of the optic nerve on the ipsilateral side. And then I drilled out the hyperostotic tuberculum sella, and this is a contralateral optic nerve. I dissected carefully and removed the all attachment of the tumor. And then I confirmed the total tumor removal was accomplished. Postoperatively, all tumor was successfully resected out. This is another case of olfactory groove meningioma. I think this is a good candidate for the endoscopic keyhole subfrontal approach. Skin incision and craniotomy was same. I put the skin craniotomy with the size of 3 centimeters, and then gently insert the endoscope to the frontal base. This is the attachment of the tumor. I carefully drill out the hyperostotic frontal bone, frontal base, and then completely expose the attachment of the tumor and decompress along the frontal base. I did not severely retract the frontal lobe, but we could relatively very wide surgical corridor and then perform the internal decompression and mobilize and dissect the tumor of the frontal base. And finally, all tumor was detached of the frontal base and remove the tumor like this. Now the both optic nerve was exposed, and then I resect the final piece of the tumor. This is a right olfactory nerve. I carefully dissect the tumor of the olfactory nerve and confirm that all tumor was successfully resected out. Tumor was successfully resected out without any deterioration of symptoms. Then I will show the endoscopic keyhole subtemporal approach. If we cut the skin around the temporal area and put the craniotomy with a size of 3 centimeters, and then gently insert the endoscope to the tentorial edge, we can observe the tentorium and third nerve and expose V1, V2, V3, and Gasserian ganglion. And then we could open the Meckel cave. After this study, I applied this technique to the trigeminal schwannoma. Like this. At first, I cut the skin, temporal skin, and put the craniotomy with a size of 3 centimeters. And then gently insert the endoscope to the temporal base. This is a dramata over the trigeminal nerve, and then cut the dramata along the V3. This is a superior petrosal sinus over the Meckel cave. I coagulate and cut the SPS, and then cut the tentorium completely to completely open the Meckel cave. This is a trigeminal nerve and trochlear nerve. After retraction of the trigeminal nerve to the lateral side, we can expose the tumor, medial side of the trigeminal nerve. And I perform the careful dissection of the tumor. Now I reach the posterior fossa. This is a Meckel cave, and I carefully dissected out all tumors. Postoperatively, all tumor was successfully resected out, and we cannot cause temporal damage. This is another case of the chondrosarcoma associated with osteogenesis imperfecta. For her bone disease, the angle of the tentorial edge and petrous bone was very steep. So to see the top of the tumor, I plan the endoscopic subtemporal approach. This is a surgical video. I gently retract the temporal lobe upwards and then insert the endoscope to the tentorial edge. This is a trochlear nerve and this is a trigeminal nerve. Under the endoscope, we can clearly identify the tumor and the brainstem. So we could carefully dissect the tumor of the brainstem. This is a trigeminal nerve, and this is a trochlear nerve. Tumor was very hard, but we could remove the tumor piece by piece. This is a trigeminal nerve, and this is a tumor medial side of the trigeminal nerve. Using or under the endoscope, we can clearly expose the surface of the brainstem, so we could safely perform the dissection of the tumor. And the tumor was safely resected out like this. Postoperatively, all tumor was successfully resected out without any deterioration of symptoms. And this is another case of the falcotentorial meningioma, but patient age is 72, so I plan the less invasive tumor removal. If we choose endoscopic posterior interhemispheric approach, where we can directly cut the tentorium and falcus, and we could safely remove out the tumor. So we place the patient to the left side down lateral position and then put the craniotomy. This is a midline, and I put the craniotomy with a size of 3 centimeters. Like
2
this.
minutes, sir. 2
And
minutes.
then I insert the endoscope to the interhemispheric fissure. This is a falcus. I coagulate the attachment of the tumor very carefully and start the internal decompression. Using the endoscope, we can clearly identify the attachment of the tumor and effectively coagulate the feeder and perform the detachment of the tumor. Then I continue the internal decompression and then cut the bilateral tentorium. So now almost the tumor was detached and decompressed. So we could easily perform the internal decompression. This is the venous structure lining the right side of the tumor. I carefully preserve this venous structure, and finally I confirm that all tumor was resected out. Craniotomy was small, but we could get the relatively wide and clear view around the falcotentorial area. This is the collateral venous channel. I preserve this venous flow and confirms all tumor was successfully resected out. Postoperatively, the craniotomy was very small and skin lesion small, so it was very less invasive procedure to have. Postoperatively, all tumor was resected out, and the patient did not show any complications. So, as I present today, endoscopic approach, endoscopic enonasal, and endoscopic keyhole approach can be very effective procedure for removing complicated skull-based tumors. Thank you for attention.
Thanks a lot, dear Professor, for this informative, excellent presentation. Is there any questions from panelists? There was a question about CSF leak.
Yeah, Harshad had
Okay.
a question. Do you have a question, Harzad?
Yeah, Sam.
Okay.
Hello,
Okay.
Professor Goto.
Start.
Yes,
Hi.
Professor Goto.
Hi.
Can you hear me? I am Dr. Harshad Parekh from Mumbai.
Yeah.
How are you?
How are
Excellent
you?
presentation you have shown. I have
Thank
heard
you.
you few times earlier also, the similar kind of approaches. And I must admire your techniques of removing this tumor through the endoscopy completely. There are 2-3 things which were going through my mind when you were doing it. One, when you were doing a transplyval approach for the meningioma removal, anteriorly placed, and when you open the dura and subarachnoid space and nicely dissected out the tumor. Now, suppose the tumor is adherent to the perforators sometimes or to the major vessel. How do you manage with the endoscope? And post-operatively, CSF leak, do you find any in this kind of cases? What do you do to prevent that? Because the defect is quite large.
Thank you, Professor. At first, in case of the clival meningioma, preserve the perforator is very important to prevent the complication. So at first, complete devascularization and detachment is very important. After the complete detachment of the tumor, we could perform the internal decompression with bloodless surgical field. So I think the dissection of the perforator is relatively easy compared to the transcranial approach. So in my series, we could preserve the perforator in all cases. But if the tumor, some part of the tumor attached to the petrous bone, I mean the petroclival meningioma, in such situation, a bit difficult to reach the lateral side of the tumor. So in such situation, we have to behind some tumor to prevent the complication. This is some tip to prevent the postoperative complication. Second question is, of course, you said complete dural seal is very important to prevent the CSF leakage. So I prefer to use fat tissue. At first, I put fat tissue to the subdural layer and then put some stitch to fix the fat tissue and sustain the CSF pressure, and then cover the large mucosal flap. Anyway, the multiple layer closure is very important to prevent the CSF leakage, especially in case of the clival meningioma, as you say. Thank you, Professor.
Thank you. Now, one more thing I would like to know. This is an excellent approach. You are doing craniotomy also in most of the cases to insert the endoscope. What is an added advantage over the microsurgery, which all of us are doing conventionally, even through a small craniotomy many times? What is an added advantage? What do you get an added advantage?
I prefer to use endoscopic procedure alone in keyhole surgery because endoscope can offer a wide panoramic view. So craniotomy, when the craniotomy size is small, but if you operate the surgery under the endoscope, you can get the clear and wider view compared to the microscope. So I prefer to use endoscopic surgery alone in case of the keyhole surgery. Of course, if you're familiar with the microscope, of course, microscope is another option to perform the keyhole surgery.
Thank you, Sir. Thank you for your
Thank you, Professor.
Presentation and question. If there is more question, please shift to lounge. It's another room that Zoom room that
Yes, I can explain it.
Okay.
Hi, Dr. Goto. I'm Dr. Bennett of Neurosurgical TV, and this is addressed to Lewis and the other presenters. We're starting an option of having a Zoom lounge after the speaker finishes, they can go there and answer more questions.
Okay.
And they can interact with students and residents, which is a plus, the interactivity. So Dr. Goto, I sent the information to your chat. Just go into,
Okay.
leave this Zoom, go into another Zoom. And when
Okay.
Louis has finished his Zoom, he goes into another Zoom.
Okay.
And, okay, so
Okay.
we'll continue on with Sam and Dr. Goto. Just take that link and we'll see you in the Zoom room. Thank you.
Okay. Thank you.
Okay, now
Thank you,
we will
Professor.
shift to next speaker, my dear brother, Professor Louis Boba. Please start sharing your screen. It's over to you.
Okay. Good morning, good evening, good night. A great pleasure to be again here with our friend Sam and the great John Bennett, the man that's changing the education in the world. Thank you, John, for all the work you are doing. To all neurosurgeons, medical students, and residents around the world. The education of neurosurgery never will be the same as you did now. Thank you. Thank you. And I start to share my screen. Let's see if I can. Can you see my screen?
Yes.
Okay.
Do you want to make it full size, Louis?
Yeah, I don't know what's going on here. I put the presenter here, but not going to the present mode. Okay, now it's coming.
It's okay now.
Okay. Okay. Yesterday, I was watching several presentations. Wonderful presentations. Great people. Great professors. Great surgeons. Everybody talking about the beautiful is the approach that he does. The beautiful is the surgery that he does. How good he is. But education is not this. Education is to understand not only the surgical approach, that's just one piece of the treatment, but understand the disease. Understand what's the best for the patient. Don't not show beautiful approach, beautiful picture, beautiful videos. And to understand that you are treating people. We are not in the Disney World in Hollywood to do a nice video presentations. Everybody has his idea. Everybody is the way to treat. Everybody is wanna say that he's the best in the world. But it's not education. Let's talk about one area. I will just discuss. I'm not talking about approach itself. Talk about the discussion of the area. This is the dissection of the temporal bone, what you have inside. If you give a lecture to ENT, the ENT always asks you, where is the ICA? If you give a lecture to the neurosurgeons, they will ask you, what is the facial nerve? If you talk with vascular surgeon, they ask about the vertebral artery, the ICA in the neck, how high, how down is going the tumor. But to understand that the surgery, the jugular foramen in this area around the temporal bone, we need to understand all the anatomy. To know that the jugular vein is coming up to the jugular bulb, that the sigmoid sign will be occluded in the majority of the patients with paraganglioma, that the tumor can extend superiorly and go inside the internal the auditory meatus and the tympanic cavity, can go anterior and embrace the ICA, can open the dura and go inside following the tumor, can have supply from the vascular and the vertebral artery. We need to understand all the area. But it's not the same way to treat every case. I remember when I started to study skull base in the 90s, there was an ENT otology, neurotology. I think the best neurotology ever was the Yashagil of otology, Professor Hugo Fish. Professor Hugo Fish was seeing the whole world through the ear. He was doing angiofibroma that is in the nose through the ear. Now we start a new era that everybody's seeing the world through the nose. See, tumor is lateral. You know it, you cannot remove, but I have a nice endoscope, I have a nice video I can do. In the picture it would be nice, I can show for many, many people. That's not the way to do medicine. It's not the way to do neurosurgery. We need to choose the best approach for each case. But you need to know the anatomy, you need to know the skull-based approach around the head. And for paraganglioma, also is not the same way. As Professor Hugo Fish described a long time ago, that you need make the transposition of a facial nerve in every case. Now you know that you don't need. Some cases you need, some cases you don't need. But now there is a new player that's coming to the game. The new player is to treat tumor like this, very small tympanic tumor, with radiosurgery. Why radiosurgery? If you can do a very directly anatomical and elegant surgery and cure the patient. But to study anatomy of the temporal lobe, the temporal bone, to study the tumor, 10, 5, 3-hour surgery, maybe easier for the surgeon to burn the tumor than really cure the patient. We know during many, many, many years, radiation therapy works for paraganglioma, but work in the vascularity doesn't work in the real cell that you call chief cell. The cell is still alive. If you gain time, it's a vascularized tumor, loses vascularization, but it's a matter of time. You're not talking about a total removal, not talk about cure, or talk about control. If you are talking about control, it's okay. But you have we need to have on mind that you are talking about control. We are not talking about cure. We know that you have many, many, many papers that's coming out. Now just everybody saying, oh, systematic review, meta-analysis review, all the reviews. It's very difficult to talk about systematic review in surgical series. But there is one factor, it's the surgeon. We know that you are different. One is better than the other one. One have more training than the other one. One is more dedicated to the area to the other one. This is life. See, how you can do a meta-analysis or systematic review about treatment when you do different kind of treatment. And most interesting thing to do for radiosurgery, using the radiosurgery, here you see the paper, 1,144 tumors, glomus jugulare, glomus tympanic tumor, very small tumor, my friend. 20 carotid body tumor, glomus vagari. Glomus vagari is a difficult tumor, maybe more difficult than the other ones. Cannot be in the same box. You cannot do a paper when you know that 60% receive radiosurgery, but 6% we don't know what kind of treatment we did. We know that 40% is the right side, 40% in 20 side, and 20% we don't know which side is the tumor. But we just know one thing. It works. Radiation or for glomus works. But 20%, I have no idea where was the tumor, but works. This is in the paper. It's not my mind. We know that you can treat here that the great majority of the tumor, the glomus jugulare tumor in this paper is 8.5 millimeters, like a small grapes. We know that they have a complication, as every treatment has complication. We know that we are treat a tumor like this, a small tumor inside of the ear. You can do a straightforward surgery. Oh, and come back. Not playing the, oh, it's not playing the video. See, here is the facial recess. The tumor will be here. You can easily remove it. See? I don't know why it's not playing the video. Oh my God. If you treat a tumor like this with radiation therapy, maybe you have a good result. But the great majority of the tumor that we see is not like this. It is like this one. It's a large tumor inside the temporal bone, going to the neck, sometimes go intradural. And now the tumor are coming like this, much larger than you imagine. You burn the whole head. If you are sending the small tumor to radiation therapy, what do you do with large tumor? The large tumor that I see in South America, that you see in Middle East, and you see in Asia, maybe US, they have a smaller tumor. Maybe Europe, they have smaller tumor. But the reality in the world is a large tumor. What to do for this case? Pray? Cry? You need to treat. Try to do the best treatment to the patient. The other option that is coming very often today as a treatment for radiosurgery, for paraganglioma, is embolization. The great majority of the paraganglioma receive the vascularization that's coming from the external carotid artery. The great majority. When you do an angiogram and you embolize, when finish the embolization, looks like the tumor disappear. No more tumor. But if you repeat this angiogram 24, 40, 48, 70 hours late, the tumor start to receive vascularization from the ICA, from the internal carotid artery. That's the most difficult tumor, when the vascularization is coming anterior from the ICA. You have a case like this, 22 years old female, horse, facial palsy, embolization, 3 embolization in 4 years, 23 years old. Now the tumors continue growing and embolize again, and embolize again, and the tumor is coming and embolize again. Now the vascularization is coming to you, to the tumor, is going to everywhere. It's coming from everywhere, from the ICA, the bilateral ICA, vertebral artery. See? The tumor that was difficult now is much more complex. And the removal that you can get, oh my God, it's not, I'm not playing the videos. Oh, oh my God. Summer, can you give me 1 second?
Okay, so
I can try to, I will try to change my, I will enter again with another computer, okay?
Okay.
30 seconds, okay? 30 seconds.
Okay.
Send me the link again. Send me the link again.
Okay. I'll put it in your chat, Louis. Oh, I can't send him the link because he's off the net. Anyway, you can send him the link, Louis. So you got his WhatsApp. I'll send it to him on his WhatsApp, maybe.
Please
Can you
unmute
hear me?
yourself.
Can you hear me?
Yes.
Well, I'm very sorry. You know, I tried to update my Mac to
We see you,
Monterey.
but we don't hear you. I think you have to change also your microphone.
You can hear me?
Yes.
You can hear me?
Yes.
Okay, good. You know what's happened? I tried to update my Mac to Monterey, the new one. You know what's happened? My camera, everything went out. Crazy, 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 crazy. Let me share again here. Okay. Can you see my presentation?
Yes.
Oh, sorry.
Yes, okay.
I'm very sorry. Okay. You see this case here that I show?
Yes, it's okay.
Let's see the video here. Look at this. It's a very simple tympanic tumor that you can go there in the facial recess and remove the tumor. And the history gone. The patient is completely cured. You can reconstruct the tympanic membrane. No necessity to any kind of treatment, additional treatment. No necessity of radiation therapy. The great majority of the people, the tumor they are treating with radiation is like this. The tumor that we see is like this. Or in our area, we see like this. We need to understand the anatomy and to understand the tumor by itself. The embolization, this is the lady that I just was talking about, 22 years old, 3 embolization in 4 years. And embolize. Now the vascularization is coming from everywhere. From external carotid artery, from internal carotid artery, bilateral now. From the vertebral artery, bilateral. And the surgery that was difficult now is more difficult. I did a petrosectomy. I removed maximum that I could, but a small piece remain inside of the sphenoid sinus. This small piece, I treat with radiation. It's okay. See, but to remove the large mass. The people talk about embolization, but never talk about complication. Almost 20% of the tumors, the jugular foramen paraganglioma, embolized, has cranial nerve deficit by the embolization. Facial nerve deficit by embolization. Do you know why? The vascularization of the tumor is the same vascularization of the nerve. Because I say, embolization is not a primary treatment. Embolization is an adjuvant treatment. And I want to say one more thing. When you have embolization, when you want to do embolization, you have to be aware about the lower cranial nerve deficit. Today, if I have a patient that tumor is not so large or giant, if the patient has no lower cranial nerve deficit in the pre-op, I prefer to do the surgery without embolization. It's safer for the patient, it's safer for the nerve, but we need to understand the tumor. We need to understand where the tumor goes, where the tumor comes. Now, new era. Now, look at this. Young adult, male horses. Patient had a paraganglioma of the glomus vagale, you call glomus vagale. What was the treatment here? They decide to do a stent in ICA and ECA and CyberKnife. It's a new machine that is in Brazil. They call CyberKnife. See, have just arrived in the country. CyberKnife is good for everything. See, what the results? Thrombose of the ICA, thrombose of the ECA, and tumor didn't change. But the results that they are saying, oh, it's very good, the tumor didn't change. But the tumor is there. Now the patient has no ICA, no ECA. Do you know what's the best treatment for glomus vagale if the patient is asymptomatic, completely asymptomatic? Wait and see. Wait, the tumor starts to grow slowly during some years, and there is a compensation from the other side that you can do the surgery and remove the tumor. This is other option. I don't like to talk about this. I know that many people like to talk about this, malignization after radiation. I don't like to talk about this because it's very rare. Very rare. It's not common. See? But happen. See? It sometimes happens very often. What's happened? It's like football game today, huh? Brazil is the only 5 times champion in the world. But today, the Brazilian team to be champion will be very rare. But maybe happen. Maybe happen. If you have a case like this, glomus jugulare and glomus carotideum, carotid body tumor, what do you do? Send home to die? Radiation neck and head? What do you do? In this case, you need to go there, remove the carotid body tumor, understand the anatomy. If you want to do in the same stage, on the second stage, the jugular foramen tumor, you can do. I prefer to do in the same stage. You go there, remove the carotid body. You go to the jugular foramen, remove the tumor jugular foramen, reconstruct the facial nerve. The patient has facial nerve palsy in the pre-op, and go. This case is published in the, have a video in the skull-based journal, and also in the chapter 37 of our book that just came out. Let's do some advertising. I know that Dr. Jean de Oliveira talked about the book yesterday. I want to make advertising of our book that is coming from TME. And the pre-op and the pro-op. The patient is cured? Probably. Maybe. But if this tumor comes back, small size, locating critical area, maybe you can send to radiosurgery. It's okay. Another tumor like this was sent to me after the indication of radiosurgery. Ladies and gentlemen, this lady has facial palsy, facial nerve palsy. There is a tumor in the jugular foramen. If you treat with radiation therapy, I don't know if radiation therapy is a good treatment for facial nerve palsy. We need to treat the facial nerve palsy. We need to go there to remove the tumor. This case I did without embolization. See? The patient had the lower cranial nerve deficit. You go around the tumor. You see, when you don't embolize the tumor, you just cut the vascularization, you understand where the tumor is going. We need to know. See, this bleeding here is venous. It's for the anterior part of the jugular bulb. And the nerve will be anterior to it. See, if you embolize, you lose this spleen. You see here the anterior wall of the jugular bulb start to bleeding. The inferior petrosal sinus, probably the inferior petrosal sinus or the condylar vein that's coming here. You just use a little bit of Sugiflow or Flosil. Here's the whole facial nerve invaded by the tumor. See, there is some tumor also in the middle ear. I go faster here. You identify all the facial nerve to see that the two facial nerve is not have any electric signal. It means that this facial nerve is damaged. You need to reconstruct the facial nerve. We expose all the facial nerve. See, you go faster here a little bit. Remove the tumor that was attaching to the facial nerve. Leave a small piece, normal facial nerve. Now you remove the tumor that is in the middle ear. Okay. Now our next step is to clean. Here's the incus. See, you can preserve the labyrinth. You can preserve the tympanic membrane. You just reconstruct tympanic membrane, and you use the graft from the greater auricular nerve that is in the neck, is in the field. See, and in the end, you do a tympanoplasty. See, the hole in the dura you can close with a small piece of muscle, like a plug. You use glue, you use Flosil, we rotate the muscles to close the cavity, and pray a lot, don't have CSF leak. And the post-op, this is the immediate post-op. The patient is still in the hospital, can eat. The patient with 8-9 months, here 1.5 years, the patient is coming. It's not perfect, but it's okay. See, maybe you can work a little bit more with some different kind of treatment to help in the recovery. But facial palsy, treat the facial palsy. You need surgery, not radiation. Another case like this, very similar to surgery, facial palsy, deafness, and large tumor. Let's try to reconstruct the facial also. This case had its surgery before. It was difficult to find the facial nerve. What I did, I just followed the ICA from the neck to the petrous area. I found the facial nerve in the parotid gland. See, I removed the part of the tumor here. See, it's a big mess after a petrosectomy. See, this case was difficult because it was reoperation. It was difficult to use the flaps, the regional flaps. Here's the ICA. Now I have the nerve in the parotid gland. I have the nerve in the posterior fossa. That's the trick to find the facial nerve, the posterior fossa. Find the choroid plexus. You see 9, you see the first one up will be 7. I like to give a stitch, take not only 7, 7 and 8, take everything together will be to be stronger. And using this situation, I use the sural nerve because I didn't have the nerve in the field because of the first surgery. It's the post-op, facial post-op here, almost 2 years. Now, after 9 years, this patient had a recurrence here in the petrous apex. What I decide to do? Radiation treatment for this small lesion that's there in the petrous apex. I don't want to say that there is no indication. We need just to know the clear indication for embolization, for radiation, and for surgery. It's very important to understand the pathology. You cannot be skull-based surgeon of approach, of instrument. We are surgeons of a man, to treat patients. When you do skull-based, when you do for jugular foramen tumor, when you do any kind of tumor, you need to believe that you can get. You need to understand the anatomy. You need to go to the lab. I spent 3 years of my life in the lab doing cadaver dissection. When I went back to Brazil, a friend of mine said to me, "Oh, Luis, how you do surgery now? You have 3 years without see blood." See, I went to the trauma center. I did a lot of trauma case. I become used to the blood. I knew the anatomy. I knew the theory, understand the tumor. Now I feel comfortable. Believe you can do this in every place in the world. Just training, just education, just understanding the pathology by itself. To end, the advertisement from our book that's coming out from the TMA. Don't ask me for the PDF. I don't have the PDF. I don't have the book already. They didn't send to me. Here you have every kind of approach, not only microsurgery. You have endoscopy, and you will decide. And I ask you to read the foreword by Professor Mefti. Professor Mefti say in few words, do the best approach for the patient. Don't do the best approach, but you want a good video or nice video to show in conference, to say that you are the new Superman. We are doctors to treat patients, not to be like a super guy in the Disney World or in Hollywood. I hope to see you in March in Brazil. Brazil today has 90% of the population totally vaccinated. Omicron in Brazil is just history. We don't have any problem with this. You know why? Our culture since newborn is to be vaccinated. We use our entire life to be vaccinated. We're not afraid of vaccination. Vaccination works, is good for you, will save your life, you save the other life. Thank you, Summer. Thank you. Sorry for the problem with the computer. Sorry for the long time I'm talking. Thank you, my friend. Thank you.
Thank you, dear brother, for your nice, excellent presentation. Congratulations for your book and your chairman for educational committee. And if there any question from panelists?
Oh, just say something.
Okay, 12. Okay.
Yeah, we are in January. We start our educational course from the Committee of Education and Training. I invite all the societies from the world. If you want to organize a course, please contact me, contact Professor Kuroda from Japan, contact all the members from the committee, Professor Manas from India, to do the educational course. We are trying to do presential in the country that you can go. But the online course, together with our friend John Bennett, will make a difference to us. Let's keep this environment of education. It's very important today. And thank you, Sami, for the invitation. Thank you.
Thank you.
Louis, we're trying to improve this. So now you can go to the Zoom room and interact with some students and other people that have questions for you. So
Okay.
you just leave this Zoom, Louis, and go to the Zoom room. I sent you the link. So
Thank
we'll
you.
We'll see you there.
Thank you. Thank you, Sami. I see Professor Vladimir is here. Professor Vladimir is here. And all the people. Okay. Bye-bye. Thank
Bye-bye.
you.
Thank you. And now we will shift to next speaker, Professor Gardner. Please start sharing your screen. Professor Gardner, are you ready? Okay, Professor Maria, are you ready?
Yes, I'm ready.
Okay, start sharing your screen during eye contact, Professor Gardner. Thank you.
Thank you. Can you see and hear okay?
Yes.
Okay. So good morning. Hello? Yes. So
Okay.
good morning and good
Go ahead.
evening, everyone. Thank you very much for the invitation. It's a great pleasure to be here. And today I'm going to talk about, in about 25 minutes, of an overview of the surgical anatomy of the skull base, especially in regarding to open approaches. I'm going to show some cases. And as Dr. Borba said, you know, the lab and the OR are really inseparables. And for me, surgery in a few words could be described as the pathology with distorted anatomy and hemostasis. So coming from Dr. Roten, I had the privilege to be a fellow for 2 years, he said that the best neuronavigation is the knowledge of the anatomy in the mind of a neurosurgeon. And we certainly work on tiny places where taking the wrong road can make great damage. And another important point is that we need to expose the necessary structures for the operation. And then going back to the Mayo family, there's a very good quote from Will Mayo saying that there's no excuse today for the surgeon to learn on the patient. And these, live courses are a proof of that. But we need to go also complement that with the surgical anatomy education. And it's we not only need anatomical knowledge from books and talks, but we also need hands-on dissection to make the surgery, as Dr. Roten said, more accurate, gentle, and safe. So going back to the skull base, the complexity of the structures, the different views that we can have, endoscopic versus open, is the same anatomy with different perspective in case of, the endoscopic approaches. And ENT and neurosurgery merge together to have the better outcomes for the patients, even in open or endoscopic approaches. So thanks to Dr. Roten, we know a lot more about surgical anatomy in neurosurgery and its importance of it. And this talk is based on some of the work that we did in the lab, taking Dr. Roten's lab as a model. And now we are at Mayo Clinic in Rochester with 2 laboratories, one for research and one for training, and also in my previous practice in Albany, New York. And right now we have not only residency training, but also research fellowships. I have 4 fellows right now with short training periods, CME courses, etc. So looking at the beauty and the complexity of the skull base from every single perspective and preparing the anatomical dissections the way Dr. Roten did, we're going to go through kind of like a 180 degrees around the skull base from the perspective of the open approaches. And we have been publishing some of these papers of step-by-step approaches for trainees, especially in the skull base journal. And starting with the frontotemporal anteriono orbitozygomatic approaches, we look at this anatomy, and what this anatomy is telling us is not only what we can access with the open approaches, but also the relationship we have with the endoscopic endonasal view. Just as an example, just looking at this area, the anterior clinoid and the middle clinoid, which is present in about 30% of the cases, that can lead us to, either a very small middle clinoid or the kissing clinoids, or even a corticoclinoid ring. So all these variables are important to recognize in the preoperative CT scan, because even if we do an anterior clinoidectomy in an open approach, we need to know that if there's a corticoclinoid ring, so we don't break and fracture the anterior clinoid and potentially damage the carotid. But we also need to know it if we are going to operate, for example, a tuberculum meningioma through the nose. We need to know if there's a breach of bone here, so we are more careful in drilling that area, and we have to leave a little bit of bone there and try not to fracture it in the middle clinoid. So this is the perspective from a microscopic or intracranial approach. And here we took out the anterior clinoid and we opened into the sphenoid sinus. And then this is the view when we drill the optic strut. So this anatomy that we see in the paracellular space, we looked in the lab and we compared the endoscopic approaches with the microscopic view. So to see exactly what corresponded to each approach. And we saw that the limbus of the sphenoid, which is here in the open approaches, corresponds to the upper part of the optic canal, whereas the tuberculum, which is the attachment of the diaphragm of the sella, corresponds also to the inferior part where the optic canals are. And in between them, the prechiasmatic sulcus, which is a very important axis for the supradiaphragmatic systems. If we have a middle clinoid, we're going to find it in the upper part of the C shape of the carotid artery. And as I said earlier, it can join the anterior clinoid in the corticoclinoid ring, something that we can see preoperatively. So looking at the skull base, this is the sphenoid bone, a temporal bone, and an occipital bone all together. This is the petroclival fissure where many of our very challenging tumors arise from. So in a view of the anterolateral approach, for instance, there can be a pterional approach, and this is a view of a three-piece OC where we already took out the zygoma. And we see this standard view that can be, when we need to look up in pathologies that are going upwards, we want to have the inferior view that the orbitozygomatic approach gives us. For instance, in a tumor like this, where there's a very high extension, when we perform, we have to look at all this anatomy. That's why, the dissection in the lab is something that I think is very important for neurosurgical education to understand exactly the relationships that we have. And we want a postoperative, this is an intraoperative picture with the carotid artery here. And during the resection of the last bits of the tumor, and this is the postoperative image with a little bit of the remaining tissue, tumor tissue here in the cavernous sinus that we followed over time. And also a similar case like this in which I think I considered the orbitozygomatic approach to be an important approach to safely look up and retract less brain parenchyma. So what do we do about tumors that are in midline, that are extremely or quite high? This patient is a 25-year-old who collapsed at work, and he had hydrocephalus. We cannot see very well here, but he had hydrocephalus, and we put an EVD and performed a sectostomy before removing the tumor. So this is ended up being a non-functioning pituitary adenoma with really severe chiasmatic compression and bitemporal hemianopsia. So here we can make an argument to grow transcranially. In this case, we elected to perform an endoscopic endonasal approach. And here you can see that we also exposed the prechiasmatic sulcus. We did not open this dura, but this is where the optic canals are. So really not just a transcellular approach, but that extension of the bone work really allowed us to not open the dura, but retract the dura so we could look up. This is working with 45-degree endoscopes, really around the corners, quite a fibrous tumor that came out piecemeal. And here removing some of the pieces of the tumor. And this is with our my partner, Dr. Pinheiro Neto from ENT, driving a 45-degree endoscope and really looking up. This is the remaining pituitary gland, and this is the arachnoid diaphragm that came down after tumor resection. And we closed with a free mucosal graft in this case. And the patient did very well. This is the postoperative image, and the EVD was eventually weaned and removed. So, but tumors like this with a lateral extension are not really suitable for at least to access this area, not as suitable to do a midline endoscopic endonasal approach. And also these patients was previously operated twice elsewhere through an endoscopic endonasal approach. So I considered to do, again, an orbitozygomatic approach, and I had to leave some tumor over the perforating arteries, but overall, quite an aggressive subtotal resection. Tumors like these were at midline are, debatable what to do, whether to do an endoscopic endonasal approach or an open approach. And in this case, this is a young lady with left-sided blindness and right-sided quite poor vision, who presented to the hospital. And in this case, I performed, again, an orbitozygomatic approach because of the encasement of the vascular structures. I thought I could do it safely that way. And she ended up doing very well after surgery with no new deficits. So tumors like this, we can really expand our approaches. Are either suitable for an endoscopic, transmaxillary approach, an endonasal, and also an open approach. So then going back to, laterally in the skull base, we studied also the middle fossa in a paper where not only, so this is one paper that is in press right now in the Journal of Skull Base, and we also published another paper about the key landmarks of the middle fossa surgery, which is certainly a very complex region. So this is for an anterior petrosectomy approach where we can really access not only the middle fossa regions, but also the regions that extend to the posterior fossa through the middle fossa. So drilling Kawasi's triangle here, this is the Gasserian ganglion, and this is outlining where the carotid is. This is GSPN, this is the cochlea, and the IAC is going to be here. So we can drill through this area, and we saw in the lab that we can start drilling safely, within 5 millimeters lateral to the trigeminal impression, because that is basically the anterior, the bone that really has no anatomical structures that we can damage. Once we expose the dura of the IAC here and we expose the dura of the posterior fossa, then we can open and we can have great access to the root of the trigeminal nerve that we can really enhance with the addition of the endoscope. Looking down, this is the facial vestibulocochlear nerve, this is the ciscranial nerve, and this is the root of the fifth nerve. This is SCA right there, and this is the fourth nerve. So really enhances our view, and this is the view of the 7th and 8th cranial nerves. So we can view and reach with angled endoscope, with angled instruments down after placing the endoscope. So this is the other side, this is a right side. And we saw in the lab that in order to access and open the internal acoustic canal, usually within, if we start lateral to the trigeminal depression here, and we start finding the IAC here in a projection from a point lateral to the trigeminal impression towards the root of the zygoma, we're going to find the IAC dura, and we have to make sure that we know that the dura is here, and we always find these this blue dura first of the medial aspect of the IAC, but when we open the dura, the nerve is really deep into the dura and we don't see it right away. We have to either put the endoscope or turn the microscope a little bit away so we see, because there's a really steep angle when the nerves get into the IAC that doesn't really follow the angle of the dura that we see. So this is opening the IAC dura, and this is how we see the nerve here into the IAC. And when we put the endoscope, things open up a little bit and we can see more anatomy. So then going back to, we have incorporated in our practice the 3D printing models, and I perform that very frequently before a case based off on the CTA. And these are approaches that we're studying with 3D printing and virtual reality. And we published the posterior petrosal approach, and really the key is the anatomy of the temporal bone that we see here laterally and medially. And this is the sigmoid sinus and the jugular bulb and the carotid artery getting into that, the petrous bone. And then looking medially, we see the superior and inferior petrosal sinus and the sigmoid sinus really around the petrous part of the temporal bone. So very complex anatomy. This is the labyrinth, a view from posteriorly, and a view of the jugular foramen that very nicely discussed Dr. Borba earlier with the lower cranial nerves, the 9, 10, and 11 cranial nerves. And we see here 12 in front and inferiorly, and then 7 and 8 going to the IAC. And this is really the view that we can have with a posterior petrosal approach, in which we combine not only that transtemporal approach, but also a supratentorial craniotomy. So we go from the view that we had in the anterolateral approaches to the middle fossa, approach through the middle fossa towards the posterior fossa with an anterior petrosectomy approach that is exactly this area. And then we're going to go to the lateral, pure lateral approaches. So for a tumor like this, is a tumor that I resected exactly this week. So I still don't have the MRI postoperatively, but I think it's a very good example is a petroclival meningioma, and we can see the tentorium here. So for tumors that go that in that extension cranially above the tentorium, I think the posterior petrosal approach gives us a very nice view once we divide the tentorium. So this is how we perform a posterior petrosal approach. This is the sigmoid and transverse sinus. And we perform a dissection this way of the muscles, and then perform, this is the sigmoid and this is the transverse sinus. So performing this craniotomy, usually one flap, but if the sinus is really attached to the bone, I don't hesitate in taking it in 2 and sometimes in 3 pieces. The key is not to damage the transverse or sigmoid sinus. So we performed that first, and then performed our ENT colleagues performed the mastoidectomy. And in this case, the patient had intact hearing, so we performed that retrolabyrinthine approach. And once we open the dura, we have access really. So this is the 5th cranial nerve. We really have access 7 and 8 lower cranial nerves. This is 6 here. And we can not only perform a retrolabyrinthine approach, but if the patient has no hearing, we can perform a translabyrinthine approach. And once we divide the tentorium, then we have really great access to the tentorial incisor as well as the posterior fossa. If we want to go further, and this is a view from above, this is anterior and this is posterior. This is the right side of the specimen. So we see facial nerve here and then cochlear nerve going towards the cochlea. And so if we want to perform a transcochlear approach to have more access in this area, then we have to divide ESPN, transpose the facial nerve, which at least gives a patient long-term a Haus-Brugmann 3 and paralysis after surgery. So we have to transpose the facial nerve, as I said, we have to divide the GSPN and transpose posteriorly. And this approach in my practice is extremely rare, but gives you this approach here. So this is 3 cranial nerve 3, 4, 5, and then we have 6 here, and this is the facial nerve transpose. This is a picture from Dr. Roton's lab. And then going back to our dissection, this is a dissection performed by Dr. Garafio at Mayo Clinic. And so when we expose the presigmoid dura, we expose the supratentorial dura, and then we divide the dura here, we divide the dura in the presigmoid area, we put a stitch of the endolymphatic sac, and then we have the superior petrosal sinus that we have to clip or coagulate, and then we divide. We look first at where the 4th nerve is, and having that direct visualization, sometimes it's involved in the tumor, we cannot see it very well, but most of the times we can still see a segment of it. We divide the tentorium, careful with the 4th nerve, and that gives us a beautiful view. So this is the 3rd, this is the 4th cranial nerve, 5 and 7 and 8 right here. So I still don't have the postoperative MRI, but you can see, you know, this was an aggressive subtotal resection because there was tumor that was going towards the cavernous sinus, and we left a little bit of tumor over the SCA that was completely attached to the tumor. So this is the early postoperative image of a tumor that I think is really indicated for a petrosal approach, at least in our practice. And then we also studied in the lab and published the step-by-step retrosigmoid approach, which is a very important and common approach for us. But the anatomy also not only open, but also assisted with endoscope is extremely important for trainees to know exactly where we are and what we can achieve with this approach. So tumors like this can be taken out with a retrosigmoid approach. And also what we studied in the lab was the differentiation, the anatomical variation of the subarachnoid artery. This is a retrosigmoid approach with an endoscope on the right side. So we see the subarachnoid artery, we see the labyrinthine artery. We published this in World Neurosurgery a year ago approximately, and the importance of knowing which artery we are dealing with is because the subarachnoid artery sacrifice doesn't usually have any consequences, whereas a labyrinthine artery damage or coagulation implies hearing loss. And knowing the variations of this is extremely important. We put some examples of it with tumors. This is a very rare non-enhancing, actually, meningioma. We also published this as a case report because of the radiological features, but was a meningioma. And we can see very well the subarachnoid artery here, the labyrinthine artery that were preserved. The patient had a preserved hearing after surgery. And this is how we see. Sometimes we don't see it, many times we don't see it in the acoustic neuroma surgery. And I think the failed attempted hearing preservation sometimes is because of damage or that the labyrinthine artery is really embedded within the tumor and we are not able to save it. Even though sometimes we save anatomically the cochlear nerve, maybe the vascularization of the labyrinthine arteries, the labyrinthine artery is disappears because it's embedded within the tumor. So very important discrimination of this. Here we see this is the subarachnoid artery in a very small vestibular schwannoma that we can see. And then going back also just to finalize our view of the approaches, this is a quite challenging hemangioblastoma ended up being of the CP angle in a patient with hydrocephalus who was sent to Mayo Clinic after having a BP shunt placed elsewhere. So we embolized the tumor, a small, one of the feeders that was able to be embolized. This is a 3D model out of the angiogram, where we can see the relationship with all the vessels and different feeders. And in the lab, we elected to perform a far lateral approach for this case. And in the lab, we can see, the differences where we take more. This is a far lateral on the right. We take, if we leave this piece of bone behind, we have this approach. We have to drill up to the condyle. In my practice, I rarely do a condylectomy for a far lateral approach. Go up here, up to here for most cases, because it really doesn't give you much more intradural exposure. And so here, just to show in a minute how we can really translate, this is an intraoperative video of that case, how we can really translate what we train in the lab to the OR. And this is dissecting the tumor. This is the vertebral artery on the right side, and really coagulated the tumor and dissecting it from pica, and coagulating the surface of the tumor to devascularize and remove all the vascular attachments that are feeding the tumor. And this is after very thorough coagulation and dissection and coagulation and division of the arterial feeders. This is dividing the tumor in two. So you can see the tumor here and just dissecting it from pica. And there the medulla is coming into view. So we can really see that this is a view that really resembles what we can see in the surgical anatomy laboratory.
2 minutes, Maria.
Thank you. And so I'm just going to show the final view. That we can see after surgery, where it's almost exactly the same as the view that we see in the OR, in the surgical anatomy lab. So this is the postoperative imaging. And I just want to acknowledge that so many fellows and residents that are working with us in the laboratory at Mayo Clinic, my colleagues in skull-based surgery. And this is just to show that we are going to have an open endoscopic techniques cranial-based surgery course with virtual reality and dissections. It's a presential course at Mayo Clinic. Thank you very much for the invitation. It has been an honor to be here with you today.
Thank you, Maria, for this excellent presentation. Is there any question from parents?
Hello. Hello, Professor Maria.
Hello.
This is Dr. Harshad Parekh from Mumbai, India. Excellent lecture, wonderful presentations of various approaches you have shown. Fantastic work you are doing. One question I wanted to know your technique and few tips when you are doing such a large clinoidal meningioma, and if you see on your MR that the artery is going through the tumor. In such cases, what do you do? Do you first expose the internal carotid artery and follow the artery, or you debulk the tumor? How do you manage that artery to preserve? And if the tumor is attached to the artery, what do you do? Do you leave the tumor behind or do some other procedure? Thank you.
Yes, thank you for the question. So what I do first is I do an extradural anterior clinoidectomy, and I expose extradurally the optic canal. So that gives me a really good understanding of at least one of, well, two of the structures that I need to see: the optic nerve, because it's going to be in the optic canal, and the carotid artery just behind the anterior clinoid. So what I do, and I open the dura down towards the, in kind of a bincodolic fashion, down to the optic canal. And then once I have the optic canal open, then I remove the tumor from the optic canal and I follow the optic nerve. And then I go laterally and I fall and I see the carotid artery. And then I follow the carotid artery back towards the bifurcation. And I kind of split the tumor in two. So then at least you have the two main structures that you have to follow to remove that big challenging tumor. Because I think if we open the dura right away, it's sometimes very difficult to find the structures, and is very risky for the carotid artery. And to the second question, if the tumor is attached to the adventitia of the carotid artery, I leave a little bit of tumor behind. I don't risk the carotid artery.
Thanks. We find difficulty when tumor starts bleeding, especially the meningiomas. When they start bleeding, it becomes difficult to split the tumor also in twice. Yes, we do the same as what you were describing. At times, it becomes difficult to remove the tumor completely in toto, or maybe in piecemeal to preserve the artery. We have to preserve that artery, otherwise we are having a mess there. Second thing, I would like to ask you, when you go to lab and come back to your surgery, do you bring the similar picture what you were showing on a fusion on a video, or just it is a video presentation that way?
Well, at the end of the resection, it ends up happening that you have a beautiful, if you have a good resection, you end up having a very similar view than what you have in the lab, because then the structures that are normal become in an almost anatomical position. And then is when you, but you have to know that obviously before you go into the operating room, because at the beginning you don't see anything. And the key is to know where things can be and where things can be distorted. So that's why I think that adapting the step to adapt the surgical anatomy to the pathology comes also with the 3D modeling, which I find extremely, extremely useful for the big cases.
It's wonderful, wonderful. All the approaches are superb, very nicely shown, and great technique of dissections. Super.
Thank you.
Thank you, Maria.
Thank you, Maria, for your excellent presentation. And now we will shift to next speaker, Professor Paul Gardner. Please start sharing your screen. Thank you.
Excuse me, Sam, let me just make an announcement to Maria. I don't know if are you still there, Maria?
Yes.
Oh, yes, I'd like to invite you to come to the Zoom lounge where there are some students and there are other people that you can interact with. I sent you the link in your chat. Just leave this Zoom and go to that Zoom, please, okay?
Thank you.
Thank you. Okay, Sam.
All right, thank you. So I'll be speaking about, thank you for the invitation and congratulations on the wonderful course. I'll be speaking about at least my perspective on the latest advances in endoscopic approaches to the skull base. These are my disclosures, which are not directly relevant, simply tools that were developed for this. The endoscopic endonasal approach, as you've heard from previous speakers, it really has become an accepted part of our armamentarium for skull-based tumors, but it does have a limited access for more lateral areas of the skull base and is ideally used in the midline. But we can extend it out to the coronal plane or beyond the midline through approaches such as the trans-pterygoid approach. And this can give us access all the way out to areas of the middle fossa, anything from the medial cavernous sinus even to the infratemporal fossa and the medial aspect of the condyle. Well, what are the reasons that we're kept limited to midline approaches? Well, it's really bony restrictions, the lateral nasal wall, the pterygoids. These are what limit our access laterally. And so the transmaxillary approach, or keeping in mind that the maxillary sinus is also a great pathway for access to the skull base, really allows us to get access more laterally. And understanding how do we access that, really have to understand what the maxilla is and the maxillary sinus. So this is the maxillary sinus. It's of course the sinus directly behind our cheek. This may seem like basic knowledge to this group, but it's important to understand its relationship to the areas of the face and also to the skull base. And so simply by doing a medial maxillectomy or maxillary antrostomy, we have really quite wide access all the way beyond the pterygoid, all the way out to the middle fossa and infratemporal fossa. So the pterygopalatine fossa and the pterygoid plates are some of the obvious areas that we're trying to, that we have to access through in order to gain further access, for example, to the petrous bone. And that can take us down even to the infratemporal fossa. So the pterygopalatine fossa is, of course, the area behind the posterior wall of the maxillary sinus, just below the orbit. And these are the various contents of the pterygopalatine fossa. And it's essentially nerves and maxillary artery branches of V2. So the steps for a transpterygoid approach is really exposure of the maxillary sinus, and then sacrifice the sphenopalatine, and then opening up the maxillary sinus and preservation of structures such as V2. The Vidian canal is a critical part of our access and has been a critical landmark that was identified very early on by our group as a key portion, a key landmark for access to the middle fossa or more laterally. And oftentimes there's this other palatosphenoidal artery or palatosphenoidal branch that can be used to track up to the Vidian. So here we see on the right side, you can see the pterygopalatine fossa or foramen. Here's a great example of a V3 lesion. You can see expansion here of V3 that you'll see coming up. And all we're trying to do in this case is simply biopsy. So here you can see the widening of V3. Here is opening up the pterygopalatine foramen, the sphenopalatine foramen rather, to open up the pterygopalatine fossa. And then coagulating the sphenopalatine artery and simply cutting that, and that then gives us access to dissect more laterally. And usually I'll dissect just on this bone posteriorly, and then we can drill all the way out to the Vidian, and here's drilling around the Vidian. Now, to gain access to V3, you really do have to sacrifice the Vidian nerve. Here we see foramen rotundum up above, and then cutting and sacrificing the Vidian nerve. But once the Vidian is cut, then we can have access all the way out through the base of the pterygoid, all the way out to V3. And then drilling here below, here you can see V2 above, and this of course is Meckel's cave posteriorly, and then drilling all the way back to V3. In that case, we can biopsy what turned out in this case to be a lymphoma. So here we can see opening up foramen ovale very widely. There's V3, and then simply biopsy of this. So, of course, there are lateral approaches to the petrous apex that are well known. We've certainly heard about some of them even today. There's a middle craniofossa approach, a transtemporal approach, and these are great for access to things such as, for example, a cholesterol granuloma or a tumor such as this. But here's a tumor that you might think about doing through a middle fossa approach, but it really does gain all the way down to the posterior fossa, even really quite low below what you could access through an anterior petrosectomy. So to do this particular tumor, we did a transclival and a middle fossa approach. So here's our left transpterygoid approach. You can see the Vidian here being sacrificed in order to gain access all the way to Meckel's cave. And you can see without sacrificing that Vidian, we really can't drill out the full aspect of the base of the pterygoid. Once that's drilled out, though, we can drill all the way up to V2 and V3 and have wide access to Meckel's cave. So there's Meckel's cave completely decompressed. And here's our final view after resecting the tumor in the posterior fossa. We can then enter into the middle fossa. Here's lateral to the paraclival carotid artery, working into Meckel's cave. We've taken the so-called front door to Meckel's cave and just internally debulking the tumor and dissecting it free from the trigeminal branches. And here's our final view where you can see all the way from the posterior fossa into the middle fossa, and in Meckel's cave, we've managed to preserve the trigeminal branch in the bottom of Meckel's cave. And here's our post-operative view. So the problem areas, though, in endonasal surgery really are these areas like the petrous apex and the middle fossa and the infratemporal space and the peripharyngeal space. Infratemporal fossa can be especially difficult to access because of limitations provided by the hard palate. But by directly accessing the maxillary sinus, rather than just through a medial maxillary antrostomy, we can do things such as a Danker's maxillectomy to gain access even more laterally or even lower. And this is simply a matter of removing that nasomaxillary buttress, but you can get alar depression. So you can get a slight cosmetic defect from this. And these are the different consequences. Instead, what's called a transalii sphenoid approach, or a direct transmaxillary approach, gives us access to the greater wing of the sphenoid. And here's an example of a woman who's 87 years old. I followed her for quite a long time. And here we can see growth of the tumor into the infratemporal fossa. And so we simply did a direct anterior transmaxillary approach through a sublabial Caldwell-Luck type incision. And here we're accessing inferiorly. And we can widely debulk this tumor all the way back to V3. And without having to perform a craniotomy. And of course, we didn't get a complete resection here, although we could have if necessary. But in this 87-year-old woman, the goal was only decompression. Here's a very extensive juvenile nasal angiofibroma in a 13-year-old. You can see its expansion all the way into the infratemporal fossa, middle fossa, and even laterally. And again, here we have the second step in the surgery is going directly through the transmaxillary approach. Now, the problem with doing this through endoscopic approaches is you do have to debulk the tumor. But I would argue that any approach to this tumor would require some debulking to gain access to the areas deep to it. So here, we're simply debulking or separating the nasal portion from the lateral portion of the tumor. This is all, again, through that anterior transmaxillary approach. And then we can gain access more laterally through transmaxillary. You can see that portion extending down into the infratemporal fossa. Now, it's important to realize that this angiofibroma originates from the pterygopalatine space and really from Vidian and at the base of the pterygoid. And as a result, this can be delivered up from the infratemporal fossa. So here, tumor is being lifted up. It does not have attachments in the infratemporal fossa. If you get deep to the periosteum of the pterygopalatine space, then the tumor can simply be delivered up out of that infratemporal fossa. Despite the fact that it has it's a large and quite vascular tumor, if we don't transgress the tumor, we can simply continue to elevate it. And here we see it being delivered now into the oropharynx. We can also continue to use that transmaxillary approach in that transmaxillary space to gain access all the way back to the inferior orbital fissure, which is how this tumor can even access the cavernous sinus or the superior orbital fissure. And here's that view as the tumor is being gently peeled out of the inferior and then superior orbital fissure. We can see working under V2, and then it can be sharply dissected. And this gives us, very direct and controlled access to perform microsurgical dissection of this tumor. And here's our post-operative view where we're able to get a true radical resection through a combined endoscopic endonasal and anterior transmaxillary approach. The petrous apex is another area endonasally that we can access, and you can certainly see by looking through the paraclival region and monitoring cranial nerves, we can have access all the way out to Dorello's canal. This is great for tumors like chordoma or chondrosarcoma, but an area we often see recurrence is in the petrous apex and the inferior or the inferior lateral regions. When we looked at our own learning curve with tumors like chordoma, we found that it was the lateral areas, of course, limited by the carotid artery, that limited our access and complete resection of these bony tumors. So as a result of this limitation by the carotid artery, we developed what's called a contralateral transmaxillary approach. So again, working through the maxillary sinus, this time not through a direct and transalveolar sphenoid, but working across the medial maxillary antrostomy through the sphenoid sinus, we can actually have a beautiful line through the maxillary sinus. This is from the right side across to the left side. Here, gaining access in the petrous apex, directly in line with the paraclival and petrous carotid artery, so that we don't have to manipulate it. And this gives us a great view of the medial petrous apex triangle. So just like we have triangles for access to the petrous apex from lateral approaches, there's also a medial triangle between the sixth nerve, the petroclival synchondrosis, and the paraclival carotid artery. And the beauty of this contralateral transmaxillary approach, as you can see in the second figure, is the angle of approach is almost directly in line with the petrous, horizontal petrous carotid artery, and this gives us really very beautiful access. I don't have to manipulate the carotid artery. Now, we do keep the nasoseptal flap on the same side as the contralateral transmaxillary approach. Here's an example of a chordoma. You can see how this is extending all the way out into the petrous bone or the petroclival region. And here we can see the intraoperative view. On the left is the transnasal corridor. On the right is the CTM. And so here, as after the CTM approach, you can see we've been able to access directly behind that horizontal petrous carotid artery for a complete resection. And we looked at our first 20 or 21 patients that we did with the CTM approach. We're able to get gross total resection of the entire petrous apex in 72% of these patients with their chondroid tumors. Here you can see the complications, but we did not have any vascular injuries, no injuries to the carotid artery. Here's a very interesting case, a cholesteatoma, very large cholesteatoma, presenting with headache, dizziness in a 59-year-old man. And here we see the imaging. And here's a wonderful model that was developed. This is by Wei-Shin Wang, who did this with us. We had an excellent talk yesterday on these type of approaches. And here, though, we're using this contralateral transmaxillary approach, working through the sinus, contralateral across the sphenoid sinus, behind the carotid artery. And it really shows you how we have that beautiful access directly in line with the horizontal petrous carotid. And here's the intraoperative view with our nasal septal flap on the same side as the CTM. And then working across, opening up the sphenoid sinus. And then doing a little bit of clival exposure, drilling away the clivus and the sphenoid bone. There's the vidian on the right side. And here we can see the combined, we're doing the Caldwell-Luck incision, the anterior transmaxillary incision. Opening up that area, and now we can all the way up to the infraorbital nerve, because that's what gives us the most lateral access, and then placing this, this protective sleeve. And now through this anterior maxillary, medial maxillary approach, I can bring my instruments across chord, essentially behind the petrous carotid artery. Here's opening up that maxillary sinus, carefully preserving our nasal septal flap. And then I can work directly into this cholesteatoma. Here we're carefully peeling it away from the posterior fossa dura. When it becomes adherent here, this does not need to be completely resected, but I can peel as much as possible of that cyst wall. And here you can see the direct access that CTM provides. It gives my instruments really a direct line of access into this without having to manipulate or displace the carotid artery. Again, peeling more of that cyst wall. And this has greatly expanded this medial petrous triangle the tumor itself has. Now we're working behind the sixth nerve, so we want to be careful not to strip that. And here's our view with an angled endoscope. And again, we're able to get all the way back in this case to the IAC, which we can see here because the tumor has completely expanded it. So here's the sixth nerve above, and then we simply place the nasoseptal flap on the posterior fossa dura to ensure there's no postoperative CSF leak, and also to provide an open access into this cavity for future treatment. So what are the limits? Well, you can obviously only go so high because the maxillary sinus opening limits you both superiorly and inferiorly. But this really greatly expands in nasal access to the petrous apex and has greatly improved our ability to access tumors such as chordomas and chondrosarcomas that extend laterally. We've been able to avoid any vascular injuries with this. Now, another approach, non-transsinus approach, is lateral orbitotomy. This is not necessarily a new approach, but using it for the middle fossa, I think, is not as well understood or well known. Lateral orbitotomy has been used for many, many years. How I typically do it is I do osteotomies in the lateral orbital rim. This is simply an incision in the crow's foot, the portion of the eye. And this gives us access through those osteotomies directly back onto the sphenoid wing. And you can see all the accessible structures all the way, the entire middle fossa, even down to the infratemporal fossa. Here's an example of a meningioma that was treated. Here's a 59-year-old woman who presented with optic nerve compression. And you can see this tumor involves both the cavernous sinus as well as temporal bone, as well as some bony involvement. And here, of course, I left the portion in the cavernous sinus, but able to completely decompress the optic nerve and resect the portion that was involving the temporal lobe. And here you can see almost no visible scar in this patient. Here's a 32-year-old woman who presented with this growing trigeminal schwannoma. You can see it hasn't doubled in size, but it's at least 50% bigger in about 4 months. And she does have some facial paresthesias. Whenever I do this, I like to map out the frontalis branch. It does, as long as you take about 2 centimeters from the lateral orbital crease, you should be able to avoid the frontalis. This is just orbicularis muscle. And there's frontalis muscle, but I do like to stimulate it just to ensure there's no aberrant course. And there you see our incision. We have a retractor on the orbit. You can also leave a thin rim of the bone here of the lateral orbit to help add as a retractor, so you don't have to place your retractor too deep. And here we're exposing the frontal dura and then drilling down to expose the temporal dura. And then carefully peeling the last bit of the bone off of the orbital apex. And here we can see temporal dura, and this can give me the same access to do a Doling type approach where I can sacrifice the meningo-orbital fold and then peel tumor all the way back to Meckel's cave. And here I have a beautiful exposure through Meckel's cave directly into the posterior fossa. Again, it's a corridor of approach, or the line of approach that I have, that gives me this access. Here I'm opening up now into Meckel's cave and then carefully debulking tumor. Tumor is being carefully peeled out of Meckel's cave. Now, to see back into the posterior fossa, then I start to introduce the endoscope. This is, of course, all done so far, or can be done with a microscope. Of course, you could use an endoscope throughout. And here we can see, leaning back all the way into the posterior fossa, I've essentially followed the tumor corridor into the posterior fossa. And looking now with first a 0 and then an angled endoscope, I can see all the way down back into the posterior fossa. I can see all the way down to V3. So I'm checking down along V3 to make sure we've completely resected tumor extending inferiorly. And sure enough, that's a complete resection. And then to close this, I simply place a fat plug. Of course, this is going to the posterior fossa, but that fat plug into the defect really provides a wonderful closure. You can, if you need to, so temporalis up to the lateral edge of the periorbita. And then my oculoplastic colleague always does the closure on this and gets really a beautiful result. Here's the post-operative image. You can simply see fat along our tract of exposure and a complete resection of this tumor. One other transorbital approach, which can actually give us access to the frontal lobe for subfrontal tumors. This is a 62-year-old man who presented with several weeks of progressive confusion and even some left-sided weakness, and found to have this tumor, which is coming right up along the frontal area. Now, we can't probably get quite lateral enough to do this purely endonasally, especially posteriorly. So I thought this would be a good case potentially for a combined approach, but we started transorbitally through the transcaruncular approach. Here we can see the tumor, and you can see our access directly through the back of the orbit. You might say, what's the caruncle? Well, this is that little pink part in the medial corner of your eye. And you can simply dissect along under the conjunctiva directly onto the medial wall of the orbit, as well as onto the ethmoid, as well as onto the superior wall of the orbit. This is just showing some of the technique here. Again, this is an incision directly through the conjunctiva. I always, again, do this with an oculoplastic surgeon. This is a very straightforward approach for them. But you can see this gives us access directly back onto the ethmoid. You usually don't have to even close this, although I would recommend CSF diversion to help aid in the closure. So here's a transcaruncular approach to the frontal lobe. I've used this for meningiomas as well. Here we can see the right orbit in that same patient, and there's the caruncle. Of course, this does mean you have to be able to look at the eye while you're working, which I always find a little bit disturbing. My usual goal is to avoid seeing the eye whenever possible. But here you can see just injecting that caruncle. And then they'll make the incision directly in the conjunctiva and then dissect. And the orbit itself can just be pulled over. You're not limited by the muscle because we're going transconjunctival, so we're technically outside the cone. And that dissects us then directly down onto the medial wall of the orbit. Here we see the medial wall of the orbit. There's a protective contact lens sewn in place to protect the cornea during a surgery. And then just placing, again, one of these protective sleeves to open up my corridor. And here I can see there's the medial wall of the orbit, and here's the superior orbital roof. And this takes me then directly onto the frontal dura. Here we can see just removing that orbital roof directly onto the frontal dura. A little wider exposure. Like any of these, you have to really do the widest exposure possible to have adequate room to work. And then opening up dura. Once that dura is open, bring in an endoscope so I have a better, ensure I have a good view here. And we're opening directly onto tumor and then internally debulking the tumor. And this turned out to be a metastasis. I thought this might be potentially a meningioma, but it did turn out to be a metastasis in this patient, which sort of fits well with his clinical history. And then the same technique we do with this typical open approach, where we do internal debulking and extracapsular dissection, and able to deliver this tumor away from any vasculature, carefully dissect it free. See lots of internal debulking, not just trying to pull this tumor directly out, but the same kind of technique we would do with an open approach. And here's our final view. And then I'll tuck in a piece of a collagen inlay and then also some fat graft. And the fat graft, again, is being dumbbelled into that dural opening and acts as the closure. And a lumbar drain here is needed to help for our final closure. And here we see our postoperative CT just to show the area of bone that we accessed. There you can see how we've been able to remove both medial as well as orbital roof. And there we see the postoperative MRI showing a complete resection. And here he is 10 days postoperatively. You can see some swelling still above the eye, but these really have a beautiful postoperative result. He heals up fantastic, and he had normal function over time. So I think there are a lot of different less invasive approaches that have been refined. These are typically used through multidisciplinary collaboration. So working with ENT surgeons or working with oculoplastic surgeons, I find that their knowledge and their understanding of these, of the anatomy of these areas, as well as different ways to access it, gives you a much wider range of what you can do, as well as an ability to avoid complications that are approach related. We don't have the same familiarity with the orbital anatomy or with even the sinus anatomy. But I think that this has allowed us to develop, rather than giant open approaches to gain access to the whole area of the skull, we can use corridor surgery to specifically tailor a less invasive approach to a specific area. And I think it's really becoming a paradigm for a lot of intracranial surgery and can be ideally applied to the skull base. Thank you again for the invitation. This is an upcoming book that's coming out in the very, very near future, currently in press. I always want to invite everyone to join a free educational website, Skull Base Congress. This is just designed as an online community for skull base surgery discussion and case presentation, as well as anatomy. And we are finally, hopefully, starting up the Pittsburgh course again, starting again in middle of 2022. Again, thank you for the invitation and congratulations on a fantastic course.
Thank you, Professor Gardner, for this excellent informative lecture. Is there any questions from panelists?
Well, I would like to invite Paul to come to the Zoom lounge to answer any questions and to interact with some students. Okay, Paul?
Sounds good. Thank you.
Okay, I put the link in your chat box.
Got it.
Okay, Sam, back to you.
Okay, just a small announcement. We have reached till now about 700 views on Neurosurgical TV YouTube channel for first day of Congress. This number is about from views and attendees on Zoom, Facebook, and applications of Neurosurgical TV and other Facebook and YouTube channels. Thank you for joining us. And now we will shift to next speaker, Professor Milik Moto. Please start sharing your screen. Thank you.
Good morning. Can you see me and hear me?
Yes. Yes, perfect.
Great. Good morning again, and thank you very much, Dr. Hassan, for this kind invitation. It's really a big honor and pleasure to be here among the esteemed masters of the skull-based surgery. So I will talk about lateral approaches for anterior skull-based lesions. Anterior skull base has complex anatomy with very delicate structures that we should preserve whatever we are doing for removing the skull base lesions, especially olfactory, optic, and ICA, and all branches and perforators, as well as there are many venous structures that we need to preserve, especially we have to pay attention to anterior cerebral vein and its tributaries. So what are the preoperative considerations? Where is the epicenter of the tumor? So we have to look at the epicenter of the tumor if it is from tuberculum cellae, anterior clinoid, or planum sphenoidale. So which essential structures are invaded, encased, or displaced? Optic, oculomotor, olfactory, or the arteries, veins. So we tailor our approach according to the tumor location and according to the delicate structures. But more importantly, we have to consider our handedness as surgeon and also our expertise in approach. So we usually prefer the site where the vision is worse, and we usually prefer where these frontal sinuses are smaller and not so extensive. The other things that we should consider is the positioning. Positioning is as much important as the selection of the approach. And gravity is our friend, and we really pull the frontal lobe down with the help of the gravity, and there is not much retraction is necessary after giving a lot of extension and tilting of the head. But in elderly people, cervical spondylosis may be a problem. Excuse me. It is not much of a surgeon's concern, but cosmetic outcome is very important to our patients also. So in essence, there are two approaches to the anterior skull base, transcranial and endoscopic approaches in a combination or alone. But I would like to talk about pterional and orbitozygomatic approach today. Yashar Gill, who is the mentor and master of the surgeons all throughout the world, he described pterional approach in 1960s, and it is really the workhorse for most of the cranial lesions. And we can really get a very good access to the circle of Willis and the optic apparatus. But if we need to expose a little midline and the other side of the anterior skull base, we need retraction, brain retraction, To prevent that, we can take the superior orbital rim and the zygoma, and with OZ, orbital zygomatic osteotomy, we can increase the angle of attack and working area at least 10 degrees. So it is not a middle fossa approach. We don't have to remove the zygoma for anterior skull-based lesions. Removing the orbital rim up to the supraorbital area, I mean nerve reach, and removing the zygoma at the frontozygomatic suture would suffice for many cases. And instead of standard orbitozygomatic, we can do a mini or modified OZ for most of the lesions involving the lateral and the midline anterior skull base. So I would like to continue with my cases. The first case is a 50-year-old female. She presented with visual loss progressively over the years. And as you may appreciate here, it is originating from the anterior clinoid, and it is encasing the internal carotid artery more than 270 degrees. You cannot even see the optic nerve around the lesion, and all the MCA and anterior cerebral artery branches perforators are within the capsule of the tumor, and you can see the bifurcation of ICA. It is embedded to the capsule of the tumor. So in this case, we decided to proceed with mini-OZ to gain multi-angle trajectory, wide exposure, and direct visualization of the optic apparatus and the main arteries. And here is the opening. I usually prefer interfacial dissection of the temporal muscle. So we retract the skull flap anteriorly, temporalis muscle inferiorly. So it really gives a nice exposure to the keyhole. And we are cutting the zygoma here at the superior orbital, just lateral to the superior orbital nerve, supraorbital nerve, and that is the frontotemporal craniotomy. And in mini-OZ, we are doing just one piece craniotomy plus osteotomy. And in this case, we did OZ and we removed the anterior clinoid, and that extradural anterior clinoid resection relieved the optic nerve. And intradurally, the first step is always the sylvian opening. Then we devascularize the tumor from the planum sphenoidale, and we are always protecting the veins. Carefully, we have to be very careful using CUSA, because if you are not sure what is behind the tumor, you should avoid using CUSA or bipolar, especially if you are dealing with anterior clinoid and tuberculum cell meningiomas. So next, we paid our attention to the temporal side of the tumor, and we are trying to find the middle cerebral artery branches. We are following them. We are trying to stay intraarachnoidal. There is always a nice layer, but sometimes it is invaded by the tumor, but there's always a nice layer between tumor and the vessels. And while removing the temporal part of the tumor, we should not coagulate the cavernous wall, because sixth nerve and the third nerve are very delicate structures and they are very sensitive to the thermal injury. After removing the temporal part of the tumor, we draw our attention to the frontal side. Next, we are gonna, after removing the main bulk of the tumor from the temporal side, we are dissecting the olfactory nerve. Most of the cases, olfactory nerve can be nicely preserved, and we are seeing the optic nerve posteriorly, and here near to the optic canal, we are dissecting the tumor out from the optic nerve, and we try to stay intraarachnoid while dissecting from the optic nerve. And I'm sorry about that. I'm sorry. And then I apologize for this delay. And then we are trying to remove the tumor from optic canal, and we are trying to dissect the internal carotid artery and set it free from the tumor. And that is really the epicenter of the tumor, originating from the anterior clinoid, entering to the optic canal. And it is widening the fissure between optic and the carotid artery. And here we are removing the tumor with sharp dissection from the cavernous sinus wall, lateral superior orbital fissure, and we are removing the tumor. Next, we are dissecting the tumor from the carotid artery. In my experience, the tumor mostly do not invade the adventitia of the internal carotid artery, but they are really invading the bifurcation of the internal carotid artery, especially proximal part of the anterior cerebral and the middle cerebral arteries. So with the sharp dissection, being very careful about around the internal carotid artery, we are dissecting out the tumor and remove the tumor from there. And it is the very last piece of the tumor that is really the epicenter of the tumor, devascularizing and decompressing progressively. As you can see, optic nerve is almost flat, which was invisible in the preoperative MRI. And even in the end of the surgery, you can appreciate that the optic nerve is coming back to the nice ovoid shape, even before your dural closure. So after removing that, we are seeing the pituitary stalk right here, and we have to be very careful about the superior hypophyseal artery. The next step, which is very dangerous, is the anterior cerebral artery. We dissect it out, and at the end of the case, we have this nice view. So that is the early postoperative MRI delineating the total resection of the tumor, preserved structures. And patient vision returned back to normal less than 3 months. And the next case is a tuberculum cellular meningioma. This is a 47-year-old female presented with bilateral visual deficits. The right is worse than the left. As you may see here, the right internal carotid artery is encased more than 180 degrees. And you can really not see the optic nerve at the entrance of the optic canal. The left optic nerve is compressed also. Tumor extended to the planum sphenoidale, entering to the cella and compressing the chiasm and the pituitary gland. And the anterior cerebral complex is pushed upwards and embedded into the tumor capsule. So according to McDormand classification, our tumor is, in terms of tumor score, more than 17 millimeters. In terms of canal score, it is invading unilateral to the right optic canal, more than 3 millimeters, and artery score encases more than 180 degrees of the right carotid artery. So it is 212, and according to this paper, many surgeons prefer transcranial approach for this kind of tumors. So again, in this case, we didn't remove the anterior clinoid. We always start with the very careful, wide and deep dissection of the sylvian cisterns and the carotid cistern and optic. We have to expose optic nerve, carotid artery, and every structure. We are starting to see the tentorial edge and the third nerve here. And when we remove all the arachnoid bands, we can see the tumor encasing carotid artery above and below. And this arachnoid opening really gives a wide exposure and decrease the brain retraction. So next step, we have to decompress the optic nerve. Since we didn't take the anterior clinoid in this patient, we have to do the internal or intradural optic decompression. with the opening of the dural fold. There are two techniques I have been using to open the dural fold. Since the optic nerve was very compressed here, I was unable to put the arachnoid blade into the above the optic nerve. I dissected the dural fold with sharp micro scissors and knife and released the dural fold around the optic nerve. And I would like to show another patient who was a craniopharyngioma. The optic nerve was not so compressed, so you can use directly the arachnoid blade to cut the dural fold. The next step is the vascularization and dissecting the tumor free from the optic nerve inferiorly, and we are trying to see the arachnoid layer always. And I feel always nervous to use bipolar around the optic nerve, so I take a little bit of bleeding, but always trying to do this sharp dissection around the optic nerve. And as we decompress the tumor with internal debulking and devascularization, we turn around the tumor, see the contralateral optic nerve chiasm, and dissect the tumor out from the carotid artery, optic nerve progressively with sharp dissection as much as possible. Especially, please do not use CUSA if you don't see the contralateral carotid artery here, because it is your blind spot. And after taking the main bulk of the tumor, the very last part, which is the very most dangerous part of the tumor, which is underneath the optic nerve and attached to the below the optic nerve and the carotid artery. So at this point, we have to be very careful about dissecting the tumor. We are seeing the contralateral left carotid artery here. The next step is to devascularize the tumor underneath the optic nerve. So always protect the optic nerve with cottonoid or paddies, and with lots of irrigation we devascularize and remove the tumor. Here we catch the arachnoid plane and we are removing the tumor between arachnoid, intra-arachnoidally. So here we have to always use Doppler, microdoppler, to assess how close we are to the internal carotid artery while dissecting the tumor from internal carotid artery. And that is the last piece of the tumor we are removing. And after the resection, we control every angle. But we can use endoscope as exoscope here to see the edges of the cavity if there is any residual tumor. Here, internal carotid artery is cleaned from the tumor, posterior communicating artery, bifurcation of the internal carotid artery, optic nerve is released and returned back to the round shape here. And here we see the left carotid artery, left optic nerve. And here you are seeing the superior hypophyseal artery and third nerve, left third nerve. And you are seeing the left, probably posterior communicating artery. So in conclusion, that is the early postoperative MRI of the patient, showing that the optic nerves return back to the normal shape and place, and her vision recovered again in less than 3 months. So in conclusion, preoperative imaging should be carefully, meticulously evaluated and assessed for the invasion, distortion, or displacement of the neurovascular structures. Best approach is determined according to the epicenter of the tumor as well as the surgeon's experience and preference. Use gravity as our friend, and it's always important for positioning. And extra or intradural optic nerve decompression is very important in the early stages of the surgery. And most of the tumors, meningiomas and other tumors originating from anterior skull base, they are intraarachnoidal tumors. So we can always use arachnoid as our friend for intraarachnoidal dissection to preserve the neurovascular structures. And after devascularizing the tumor from the skull base, we should not use coagulation or ultrasonic aspirator where possible. So I thank you again, Dr. Hassan, for giving this opportunity in this prestigious meeting. Thank you very much.
Thanks a lot, Professor Malik, for this excellent presentation. Is there any questions from panelists?
Hello. Hello,
Okay,
Dr.
go
Malik.
ahead.
Yeah, this is Dr. Harshad Parekh again.
Hello, hello, sir.
Excellent presentation as a beautiful dissection. Now, I just wondered in your cases what you were showing, is the orbital rim removal helps you more to have a space? Even if you avoid doing the orbital removal, can you remove the tumor without much problem?
Actually, the second case was a terional approach. And if you notice that, but I had to use a little bit of retraction to see the posterior part of the tumor embedded to the frontal part. So it is possible to use, classical terional approach. But the key in this terional approach is to cut the orbitomeningeal fold. It really relieves the pressure around the tumor and gives a wide angle. So it's not necessary to remove or do mini or OZ or standard OZ for all these kind of tumors. Standard terional approach may suffice.
Yes, thank you. And I 100% agree with you. Okay, do not use the bipolar coagulation near the optic nerve because you might cause a thermal injury to that. And regarding the drilling of ACP, it becomes sometimes very difficult if you do intradural ACP drilling, and the drilling itself generates a lot of heat. And we have found that it is better to drill extradurally as much as we can and open the superior orbital fissure there.
Yes, I agree with that too, because especially in anterior clinoidal meningioma, the bone could be hypertrophic and could be very difficult to drill out. So I agree with you, sir. I mean, where possible, extradural anterior clinoid excision should be done.
Thank you. Wonderful.
Thank you. And now we'll shift to next speaker, Professor Kenan. Please start sharing your screen.
Excuse me, Sam. Let me just make an announcement to Dr. Mute. We invite you to the Zoom lounge where it's a private chat with some students. They'd like to meet you. I sent you the link in your chat box. Okay, Doc?
Okay, thank you, sir. Thank you.
You have to leave this Zoom and go to that, okay?
Okay.
Thank you. Okay, Sam.
Good morning. Can you hear me, Dr. Hassan?
Yes, it's okay.
Yeah, thank you so much for your kind invitation. I will talk today about some of the things that I've been interested lately and doing some activity on that, which is post-surgical visual presentation and improvement in cellular and paracellular lesions. I have just to send you some greetings from Memphis, where there is sunny day today. This is my university, our medical school, and also my city of Memphis, which is called City of Three Kings, Martin Luther King, Elvis the King, and B.B. King. I have no commercial disclosures, and I would like to talk about visual outcomes after cellular and paracellular tumor surgery. So I've been looking into this, and what is the state of the art? How much we can expect our patient? What should we tell our patients preoperatively? What's the expectation of the visual preservation or improvement. So I've stumbled across many articles talking a little bit about it, but we don't know much actually. Vision improvement ranges very widely between 28 and 86% with a mean of about 59%. In meta-analysis of Jamatei, it's 48%. But what does it depend on? Does it depend on preoperative visual function, length of preoperative deficit, size of tumor, type of tumor? Is it clinodal, tuberculum cell meningioma, superior orbital fissure? Is it craniopharyngioma, pituitary tumor? What type of surgery? Is it going through the cranioorbital zygomatic, going through the nose? How to quantify it? So these are all open questions that demand answers. So we hypothesized some years ago that doing cranioorbital pretemporal skull base approach and releasing and mobilizing optic nerve, enabling safer dissection and resection of the tumor. And these are the steps, including one of the most important, of course, is removing the posterior part of the roof and lateral wall of the orbit, opening of superior orbital fissure, opening of the lateral wall of the cavernous sinus, extradural removal of the anterior clinoid, and I'll talk a little bit later about it, and then releasing arachnoid cisterns and opening of falciform ligament to mobilize the nerve. So I'm not going to dwell about craniotomy. Previous speakers beautifully described it. I just want to tell you that Ali Krishna advocated using TUSIL for hemostasis around the cavernous sinus, venous bleeding. I told Ali that in my hands, I have much better experience with gel foam powder. And this is really one of the wonderful ways to stop bleeding, gel foam powder balls. The other thing is, of course, Dr. Al-Mefti taught us how to do extradural removal of the anterior clinoid in almost all cases, and I employ that. And of course, Professor Yashargil taught us how to open the cisterns and how to release the CSF and create additional space. And finally, opening of the falciform ligament is almost condition sine qua non in doing these surgeries, because without the opening of the falciform ligament, I don't think there is a safe surgery around, in my mind, around the optic nerves and chiasm. So these are our preliminary data, which we are still putting together. And I'll go and show you some of the cases and show out some technical elements. Each of the presenting videos will have some interesting, I hope, interesting points. So this is a case that we published, breast cancer and prostate cancer in a man, which is very rare. And this is basically, as you can see here, drilling of the lateral wall and superior wall of the orbit. Here is gel foam powder utilization. Here is coagulation and division of meningorbital artery, getting into the lateral wall of the sinus. Here you can see now the elements of the sinus. You can see the bleeding, again, controlled by gel foam powder. Very, very nice and simple technique. Here you can see now coming to the anterior clinic. Note this internal retraction by stitches that we put into the dura, and then here displaying the V1 and V2. You can see here how we place those little stitches to retract the dura, and you can see now anterior clinoid comes into visualization. And here is removal of the anterior clinoid infested by the tumor. We can use, obviously, 0.5 millimeter kerrison. We can use, you can see optic nerve comes into view. We can use a micro rongeur and, of course, drill with irrigation. So here, the tumor, you can see very well, the optic nerve being decompressed. Here is using of the optic canal with drilling and constant irrigation. Here is removing the inferior aspect, the inferior strut below the optic nerve. Here is the tumor. And then at the end, this is the final view of anatomy, genome of internal carotid artery. By the way, this is a great place to do proximal control. You can see all the elements, tumor is cleaned, and here is the postoperative picture. Another case which we also published, this is a lady that presented with previous history of renal cell cancer, declining vision in the right eye. You can see here the visual fields, and you can see here how there is almost significant or complete loss in the right eye. You can see the tumor involving superior orbital fissure going into the optic canal. You can see here depressing the optic cone and the optic nerve. And then again, just showing here some of the elements of the involvement of the tumor. Here is again dividing a meningorbital artery after coagulating it. Again, hemostasis with gel foam powder. Here is now starting to remove the tumor and decompress the optic nerve. You see this bone heavily infested by the tumor, and you can see tumor now here starting to appear after the removal of the bone infested. Extremely vascular tumor, renal cell cancer. Here is now drilling. You see constant irrigation with water, removing of the remnants of the anterior clinoid and unroofing the optic canal. You can see nice decompression of the optic nerve now. And then you can see now fully exposure of the optic nerve, and then final and the removal of the anterior clinoid extradurally with the removal of the anterior clinoid tip as well. Again, gel foam powder to secure the hemostasis. Here is a final part, removing the dura of the periorbita and complete resection of the tumor. And then here checking with the stealth neuronavigation, the intradural part of the tumor, and then opening the dura to complete the quote unquote gross total resection. Here you see the usage of pot scissors, and then patching the graft of the dura. You can see here how the postoperative picture, of course, look, and you can see here how the resolution of visual field deficit from almost complete blindness to vision, acceptable vision looks like. Another case, 36-year-old woman with left proptosis, left eye pain, and significant visual field defect. You can see here severe hyperestosis, meningioma, and almost complete blindness in the left temporal part of the optic field, and some depression also on the nasal optic field on the left nerve. And then just showing the intraoperative part, as Professor Caldwell said once, this is archaeology, you know, there is so much to drill and remove here, like uncaving some Middle Ages sarcophag. It's huge undertaking, as it's 2 or 3 times larger than normal roof lateral wall of the orbit and anterior arterial clinoid. Here you can see slowly coming to the optic nerve. Again, drilling and constant irrigation. Very hard bone, unusually hard bone as well. And then slowly coming from proximal and from distal side. You can see now optic nerve coming into the view. And here, final part of removal of the clinoid and decompressing of the optic nerve. Then we moved on to remove the tumor around the lateral wall after we finalized this decompression. You can see the optic nerve now much happier here, very, very healthy looking with no elements of compression anymore, but we want to achieve gross total resection here and of the bone and completely decompress the nerve. Here is final part of it, and then resection of the dura involved by the tumor to achieve gross total resection. Here is the outcome of the nerve. Please note here how from blindness we go to almost normal vision, and you can see here the postoperative pictures. Let's move on to clinoid meningiomas, one of my favorite tumors. This is a gentleman with right hemiparesis and ipsilateral internal carotid occlusion. You can see here giant clinoidal meningioma, most of the tumor in the middle fossa, but also significant part of the tumor going right to the midline, almost completely 270, 300 degrees encircling carotid artery and occlusion of the carotid artery. And you can see here gross total resection and improvement of the vision. Another case on the left side here, you can see completely involved bifurcation in the tumor. You can see middle cerebral artery at the posterior superior aspect of the tumor. And then here, everything was easy to remove except the small piece that was sitting on the pituitary stalk. And I was thinking intraoperatively at the 10th hour, should I remove the stalk and cause the DI, or should I just preserve it by leaving a little bit of tumor right on the stalk? And I decided for the latter, and it proved well because she didn't have DI, and also this small part remains stable. This is another case. This is one of the stunning cases. That patient was completely blind for about 2 or 3 weeks before surgery. You can see here complete blindness on the visual field on the right side, and then you can see postoperatively here the 3/4 of the visual field improved after resection of the tumor. And again, you know, we extremely diligently do preoperative evaluation by our neuro-ophthalmologist. We do it postoperatively and then on regular basis. So all my cases in the series are very well documented, and I think we need to dig more about this. Another case with a clinoidal meningioma, you can see the patient postoperatively, significant visual field defect and improvement. Tuberculous cell meningiomas, this is the case of 35-year-old with field defect. You can see here incision and position of the patient, the surgery, the sliding to the cisterns here, as Professor Yashargil taught us, releasing of CSF. You cannot see at the beginning anything. The brain is bulging, no retraction. And then we open the arachnoid membrane here. We find the optic nerve, we open arachnoid membrane. We find the carotid artery, we find A1. Here is the tumor coming in the view, and then slowly start dissecting. And as we release CSF, beautiful view of A1, of the tumor, optic nerve. And then we move along the A1 to ACOM and contralateral side, start to debulk the tumor, of course, away from the optic nerve. We don't want any transmission. You see here nice ACOM and A1, A2 on the other side, shrinking of the tumor a little bit. and then slowly dissecting and coagulating at least 3, 4, 5 millimeters away from the optic nerve, and eventually removing the tumor. Here is delivering and slowly shrinking the last remnants of it. And the beauty of this approach and this strategy is the fact that not only you resect the tumor, improve the vision, but also you have a beautiful preservation of arachnoid membrane. And obviously here is just to show the pituitary stalk. This is patient postoperatively. Again, that visual field defect resolved. This is another gentleman with visual field loss. In the right side, you can see here tuberculous cell meningioma wrapping around the right and a little bit on the left carotid artery. And then here is just some of the intraoperative elements. You can see here starting to work on the tumor between. Here is opening of the optic canal. You can see here, we can do it with a sickle cell knife. The other option is to open it with the hook. The sickle cell knife, in my opinion, has a little bit less control. And as you can see here, opening with the hook and then number 15 blade or 11 blade works well. You can see here working on two sides of the medial side of the left optic nerve and the medial side of the right optic nerve. Here is looking for the contralateral carotid artery, and then looking for the anterior communicating artery. And then this tumor fairly vascular, as you can see here. And then finally, resection. Here is working between the carotid artery and the optic nerve. And you can see by releasing the optic nerve how much it's relaxed and how much it is able to dissect the tumor. Here I'm protecting with a small patty the carotid artery, and here working on the last remnants of the tumor. And then finally, after removing the last part of the tumor, here we will see the whole picture. You can see here now the membrane preserved. You can see pituitary stalk, Lilliquist membrane, and you can see here that the brain is undisturbed. We are really working below the brain, optic nerves. And then, of course, you can see here optic deficit, visual field deficit remained unchanged. This lady, again, you can see here bilateral blindness before surgery, resolution of the blindness on the postoperative visual fields, tuberculous cell meningioma. You can see here removal of the clinoid, the compression of the optic nerve, and the patient postoperatively. Another case, bilateral blindness for 3 weeks, and this is her visual fields, visual fundus. You can see here meningioma, tuberculous cell meningioma going and between all the elements of the circle of Willis. And same, you can see here retraction of the dura. Very, very nice trick that I learned from Ali Krisht. Here is drilling of the clinoid. You can see here opening of the optic canal, nice dissection and slow but steady. I call it 360 degrees of the optic, the compression of the optic canal, where optic canal is completely decompressed. Here is, you see here release of the carotid cistern CSF. You can see carotid artery in the optic nerve here. And after this release, beautiful relaxation of the brain. Here is, we are coming on the top. Now note that anterior clinoid has been opened And you see here opening of the optic canal with the blunt hook. And once we do this maneuver, optic nerve is very friendly. It's released. There is no way of tethering of the optic nerve. And now we go on to debulk the tumor and slowly dissecting it of the optic nerve. But note how optic nerve is relaxed. You could see in some previous presentation how optic nerve is tethered if you don't release the falciform ligament. And you know, of course, you can get away without it, but when the optic nerve is released, you can, or the patient can find gratification by improvement or preservation, at least, of the vision postoperatively. Now, moving on to further resection and looking into onto the other side, looking for another carotid artery, left-sided. Here you go, still decompression of the tumor, debulking from inside, working with the CUSA away. CUSA does produce the heat, so you gotta have a nice distance between the tip of the CUSA while debulking the tumor and optic nerve, because you cannot be within 4 or 5 millimeters from the tumor, as from the anatomic element, as this can coagulate or damage or, God forbid, open the carotid artery. So you have to be safe and keep appropriate distance. And then finally coming to the end with debulking. Here is the contralateral optic nerve, the left-sided. I'm now working below it and decompressing the tumor. Now, this tumor you can never predict. They can be more vascular, they can be less vascular, they can be very adherent to the optic nerve, especially around the optic canal. They can be less adherent here, opening on the contralateral falciform ligament, and then eventually removing the last parts of the tumor. And here you can see, you can see here, this is the genu of the carotid artery below the right optic nerve. This is one below the left optic nerve. You can see here pituitary stalk. And then at the end of surgery, you can see the final result, closure of the dura. And you can see this was stunning success, in my opinion, when 3 weeks, you know, some people say, well, what is the length of time where you can tell patients, there is no way to expect any improvement of the visual field after surgery. This one was 3 weeks of complete blindness. You can see here postoperative visual fields compared to the preoperative ones. You can see here, of course, always you have to preserve pituitary gland, pituitary stalk, and have normal hormones of the pituitary. And that's another thing that we need to look into. So Dr. El Morsi sending me the note that I have 5 more minutes, and I'll go quickly through the rest of those slides. This is a lady that came to me, operated by another surgeon, very, very respectable, very well published person, and you can see here he did the beautiful job removing the tumor in the terms of the difficult part. You see, all the elements are clean. The pituitary stalk, the Willis circle of Willis artery elements. But look here, the little vision. She's legally blind on the left. In the left eye has some visual light perception. On the right side, she's blind. And you can see here what was left. This was the tumor around the optic nerve bilaterally, and this was going into the optic canal. You can see here. And to me, it was easy that colleague didn't remove the clinoid. So I used that corridor from more anterior, remove the clinoid, as you can see here, and we were able to preserve a little bit, improve. Craniopharyngiomas, quickly, this is case I removed recently, policeman, You can see here bilateral blindness after the surgery. You can see significant improvement. I'll move quickly through those cases. I have video clips of all these craniopharyngiomas, but I will, in the interest of time, yield. You can see here removal of the clinoid and postoperative gross total resection, preservation of the pituitary stall, pituitary gland in this lady with craniopharyngioma. Pituitary adenomas as well, giant pituitary. Look at this bilateral blindness, left complete, some tunnel around the optic nerve on the right side, and you see a significant improvement of the vision. This lady works in school cafeteria. You can see here, we preserved the pituitary stall, pituitary gland, and there is a small piece of tumor again on the pituitary stalk. We left this because I didn't want to cause DI. Didn't want to put her on medication, and that proved to be a good decision. Finally, aneurysm. You can see here anterior ophthalmic artery aneurysm. You can see here fibromuscular dysplasia. Our endovascular people were not able to even consider coiling, so we did clinoidectomy, clipping of this aneurysm, and then good resolution of her visual field cut. So in conclusion, this pretemporal transcavernous microsurgical approach with opening of the superior orbital fissure, removal of the orbital posterior orbital roof and lateral wall, removal of the clinoid extradurally, and opening of the falciform ligament helps release the tension and relax optic nerve, chiasm, and orbital anatomic structures. So it enables easier tumor dissection, safer resection by improving maneuverability and decreasing dissection spaces. It helps to maintain and improve impaired vision and enables radical surgical resection. Because remember, one of the most important functions is vision, and that if you don't preserve and even improve the vision, patient remains with significant debilitation for the rest of his or her life. So thank you very much, Dr. Hassan. I congratulate you for the election of Vice Chair of Oncology Committee of World Federation of Neurosurgery, and I'll be very happy to answer any questions. And by the way, hello to Dr. Benesh.
Yes.
I can see Dr. Benesh, my friend.
Oh, good. Good, Kenan. I want to invite you to the Zoom lounge where maybe people can ask them questions, and you can interact with med students and residents in a private Zoom.
I would love to do it. The problem is I'm on call and there is a patient. My residents already positioning the patient. We have an
okay. Okay, it's
bleed.
optional. It's optional.
So
Realize
I'll be happy to answer question if somebody has from the audience question.
Okay.
And hi, Vlad.
Hi, Kenan. What is the percentage of vision improvement?
The percentage of vision improvement, I think we are getting north of 78, 80%. To be honest with you, I need a fellow who will spend some time and do very, very thorough evaluation because our residents are busy. So I don't want to come with the close response right now because the working is not, but it's higher than the average. You see that the range in the literature will anyway between 20% and 90%. We are very close to 90%, but the exact number I'm not going to give you today because we need to get. We have only preliminary numbers. We need to get exactly because sometimes when you calculate the visual field improvements and when you calculate the visual acuity improvements, that needs to be done very, very precisely and tested statistically.
Thank you.
Any more questions from the panel? Okay, Dr. Kenan, we'll do it next time. We'll do the Zoom lounge.
Thank you so much. Thank you. All the best. I hope to see you in person, everybody. I missed you all. Thanks.
Thank you. Okay, Sam, back to you.
Okay.
Thank you, Sam. We will shift to next speaker, Professor Venus. Please start sharing your screen.
Hello, everyone. Do you see my screen?
Yes, it's okay, and sound is clean.
Okay. Hello, everyone. Whatever time of the day it is in your place. I must thank very much for the invitation to this extraordinary meeting, which is really something to organize. I can imagine that you have spent lots of time. And I must also appreciate John's work. You know, we have two most frequently switched on TV channels at home. The one is CNN and the other is Neurosurgical TV. All right, let's go to the business at hand. Let's go to posterior fossa or more to the back. We have heard quite a lot about the anterior clinoid, so I believe that this will somehow change the location. I have nothing to declare about the beautiful country. This is the series of supra-infra cases over the past 15 years, and I today will talk only on those where we go laterally to the skull base, to skull base lesions, or the lesions which would otherwise necessitate some transpetrosal on some skull base. So predominantly, those are the clival meningiomas and C angle meningiomas, then brainstem cavernomas, some osteotomas, Pfiffner schwannomas, which are only in this series, and I guess one or two brainstem gliomas. So altogether, some 100 cases of these. I love the pineal region, and that is where we started in the pineal gland and this pineal cyst. You get this beautiful anatomy, which is exactly the same as in rotten books, and you enjoy it. We've spent quite a lot of time on pineal cyst. The last publication is from just recent, 2 months ago, when we started in 2016, and we still have some work to do on the pineal cyst. But this is not about the pineal region. This is about more or less petrous apex location. What we do is sitting or semi-sitting position. We are not afraid of semi-sitting or sitting positions. We have excellent anesthesiologists with lots of monitoring, and we check up the patients for foramen ovale prior to surgery, so we do not have problems with this position. CSF drainage is a must for the beginning of surgery. I love the lumbar drainage. I still consider the lumbar drain to be the best invention in neurosurgery over the past 100 years. And this is only for the beginning. Since with this approach, you do not get into the systems early on. At the beginning, you need just a bit to relax the cerebellum. And this can be achieved by simple draining of 20-30 cc of CSF from lumbar drain. Craniotomy should go well above the transverse sinus and some 15-20 millimeters along the sigmoid sinus downwards. I will explain why. Dura is opened U-shaped below the transverse sinus and only some 15-20 millimeters, not more. If the opening is going too low, then the cerebellum hemisphere tends to prolapse through the dura opening. So you keep the cerebellum within the posterior fossa by the dura. So very modest dura opening. Several stitches to lift the sinus, and this really any millimeter is very helpful. So any elevation of the transverse sinus by stitches is very helpful, and you can even put several stitches on the tentorium should you need to cut it, which is quite frequent in these lesions. So actually, this is the convexity approach for skull base lesion. You can use both microscope and exoscope. Microscope, you need a little longer hand or arms. Otherwise, you wouldn't reach the region because you need long instruments and it will be cumbersome. I do not have many problems with that. Or you can use exoscope, which is an excellent tool. The only problem is that you are out of the horizontal axis. So you might have the problem just to put the instrument into the wound. That is why the assistant is there to put your hands in a proper position. So this is the craniotomy, transverse sinus, dural opening. And sometimes this extra opening along the sigmoid sinus is needed, especially if the tumor is more posteriorly located and no more than several millimeters below the transverse sinus. Again, the craniotomy, transverse sinus, sigmoid sinus, and dural opening will be like here, like that, very modest. And you see, this is what cc of lumbar drain does that, immediately the cerebellum falls down and space is open for you to go wherever you want. We published this approach and what we use, and there are some anatomical remarks on that. We are looking from below. The skull base is softened and removed, and then the dura is opened. This is our arachnoid study. You see the 7th, 8th, 5th, 6th, and 3rd nerve, and you see the arachnoid folds, which really keep, especially in meningioma surgery, and the dangerous location is between the 6th and 5th, where the arachnoid membrane, outer arachnoid membrane, is not that thick as in the other places, like here below the 5th nerve. This is little enlarged, the same picture. This is the image of CP angle, more from the retrosigmoid, but you get the same approach from supra-infra. And you see that the arachnoid folds again are around the 5th and around the 5th, 7th, and 8th, and you might be able to use it for your dissection, because as Imad Kanat is saying, the arachnoid belongs to the patient and the arachnoid is a friend. This is just the technique how to soften the skull and remove it. So what I'm going to talk about today is this green arrow, getting to the petrous apex region, not to the pineal region per se. So we are talking about the lateral brainstem, lateral mesencephalon, and petrous apex region. These are the cisterns you will encounter there. So first is the cerebellopontine cistern, then ambient, scrural, and interpeduncular cistern. And actually, this is what the supra-infra approach allows, to go all along these cisterns, especially when the tumor provides the space for you. We have two main avenues or two main targets in this supra-infra approach, which is medial, and I shall skip this for today, and the lateral, where we have three possibilities, which is lateral anterior, going directly to the apex region, then lateral superior, when you cut the tentorium and go a little higher up, lateral inferior, when you want to target the pons or the pontine lesions, cavernomas predominantly, then you can go directly superior. It means to the medial temporal and occipital regions, which is an excellent approach because you do not need any brain retraction. And the thick is the tentorial section. So let's go through all these possible approaches. So lateral anterior, this is a cholesteatoma, which clearly shows how the tumor or mass region provides space for you. This is at end of the surgery. Here is the 3rd nerve. Here is the superior cerebral artery, which is running towards you. This is the posterior clinoid process on the right side. And here you see the Lillienquist membrane, which always is a wall which keeps the tumor. As of yet, I haven't seen a meningioma which would penetrate the Lillienquist membrane. It's by far the thickest and most mightiest arachnoid wall within the skull base. So this is a typical meningioma of the apex. It's not true petroclival meningioma. This is after surgery. The patient is a young lady who is 6 months pregnant. There was a long discussion whether we should do it like first the abortion or birth, or whether we should operate on a lady being pregnant, which we did because she decompensated. And here you see that we were, sorry, the video is not working. I'm sorry for this. Now it's working. All right, you see the advantage of this approach, that you very early on get to the plane between the brainstem and the tumor. Like in this case, we are very early on in surgery on this plane, and you can decide how you will go on, because some of the petroclival meningiomas, as I will show later, needs to be resected only partially, not all of them. And this is at the end of surgery. This is the 3rd nerve. This is the Lillienquist membrane. This is the tumor origin at the anterior superior petrosal sinus. And here is the 5th nerve. The tumor continued into the cavum mecali, which we didn't open because the obstetrician who was present there told us that shouldn't go there. We later on, when the remnant grew, treated it with the gamma knife. You see the whole approach, only supracerebellar. And this is the lady after the surgery, a few years, because this is the kid who spent several hours with us in the OR. The kid is doing well. Only the father started drinking. That was the only complication of the surgery. Another tumor like that, and what you see after the surgery, and what I'm talking about the system. So we are in the cerebellopontine system only. It didn't extend to any other system. And in cerebellopontine system, we've got the 7th, 8th, and the 5th nerve. So this is the 7th, 8th, still covered by its proper arachnoid, but we are working within the system, which one should know in advance because of the structures which are in respective systems. Another apex meningioma, after the surgery, you see that we only were in the ambient system. This is the prepontine system, this is the cerebellopontine system, still being unopened and being preserved by outer wall arachnoid, which means that as long as we didn't disrupt the arachnoid, we cannot harm the structures which are within these systems. And in ambient system, the only structure present is the 4th nerve, which sometimes, as I will show later, is pretty difficult to manage. Still an old patient with 5th nerve schwannoma, with this rather large cystic component. What we did, since the patient was old, we only resected the posterior fossa part of the tumor by the supra-infra approach. And this is the so the tumor left within the Meckel's cave, which we just follow and we didn't do anything. Let's go lateral and inferior to the pontine region. This is a carcinoma of the pons. And what one needs is this part of tentorium to be exposed. This is best exposed by supra-infra because it's completely extracerebral approach without any retraction. Coming there from lateral subtemporally, the tentorium probably would be a little more straightforward approach, but the necessity to retract the left temporal lobe would be definitely its negative factor. And this is the day after surgery MR, still with the cavity, but without any cavernoma. Another cavernoma like that within the pons, and the only part which needs to be retracted is this part of the cerebellum, which easily is approached via the supra-infracerebral approach, and here is the MR after the surgery. This is a little kid which came to us from abroad. We published all these cavernomas in several articles, as well as in a book print which was published by Springer. This is a male of 8 years. Elsewhere was done the biopsy. The tumor was established as pilocytic astrocyte. He was given some chemotherapy, which didn't do any good to the kid. And he had upper extremity tumor, so we went in. This is the tumor within the mesencephalon. This is the approach. Here is the tentorium, here is the cerebellum, this is the 4th nerve, this is the superior cerebral artery, and here is the tumor. This is during the resection. All the perforators which were running through the tumor were preserved, and tumor was resected. This is at the end of the resection, still the superior cerebral artery. This is the lateral aspect of mesencephalon where the tumor was resected. Surprisingly, we didn't need to cut the tentorium, and these are the MRs 4 months after surgery. There are some remnants of the tumor at the bottom of the cavity, but the kid is doing perfectly well, attending the normal school, and it's now like 4 years after surgery, and the kid is still in a perfectly healthy condition. Going down for meningioma, again at the region of the apex of the petrous bone extending into the internal meatus canal, and you see the video here. This is the posterior, later on. Yes, you see the posterior aspect of the tumor. As long as the tumor is surface is smooth and shiny, there is the arachnoid wall on the tumor, and that's not right. So the surface should be grainy and tough. This is the internal acoustic meatus. Here is the sixth nerve, which I always seek actively because the damage to the sixth nerve is terrible for the patient. It's visually and effectively loss of one eye. And this is the fifth nerve. So the tumor was within the cerebellopontine cister only, nowhere else. And you see that after the resection, you get all the structures perfectly clean. And we are going to lateral superior, where we need to put the tentorium. I shall start with this thalamic cavernoma. It's not really the skull base region, but some skull base approach would otherwise be needed, whatever direction you would like to come apart from supracerebral infratentorial with the cut of the tentorium. So let's see the surgery. Here is the transverse sinus. We are more to the middle. Here the craniotomy doesn't need to go as far as sigmoid sinus. This is the beginning of surgery. Again, just with the lumbar drain, you get your space. Tentorial section just to get to the posterior thalamus, which is directly then in front of you. Here we are on the thalamus. This is one of the branches of posterior cerebral artery, and this is the internal occipital vein. And already the yellowish tissue was seen, so nice place where to enter the thalamus. And here the resection of the cavernous malformation, which was rather well organized because the lady came to us quite long after the bleeding, being told by neurologist that this is inoperable lesion. To be quite honest, the lady after the surgery has had for half a year hemihypesthesia, which was rather disturbing to her, but ultimately the hemihypesthesia improved, and by now the lady is neurologically completely intact. Here is the entering opening of the thalamus, and here we have the post-op image, and you see where the resection cavity shrunk in the middle of the thalamus. Another cavernoma like that, we need to get to the fissure between the mesencephalon and the temporal lobe. Again, you can get there by cutting the tentorium and going supracerebrally, and this is where the cavernoma was, the patient being completely intact. Now the meningiomas in this region where one needs to cut the tentorium, this is the tentorial edge meningioma. In advance, one can say that the only cistern where the tumor is located is the ambient cistern, its lower half, not the upper half, which reaches the pineal region, but the lower one, decreasing the tumor. Actually, the tumor bulk was located exclusively in the posterior fossa, but the origin was the tentorium. So at the end, after the resection, you see again the grainy and rough surface of the tumor and preserving the arachnoid membranes. And now we are cutting the tentorium where the tumor origin was, just to achieve the Simpson 1 resection. And there were very tiny remnants of the tumor supratentorially. So this is going a little higher up. And this is the ambient cistern. You see that the cerebellopontine and all other cisterns like crural, which is over here, are still left unopened. This is the lateral mesencephalon. And this is the 7th and 8th, again covered by the membrane of the cerebellopontine cistern. Then this vein was preserved, as seen here. So this is the anatomy of the region. Here you see the tentorium edge, which is reflected by the stitch, the ambient cistern, and the only content of ambient cistern is the 4th nerve. It is difficult to preserve, but not in this case. This is similar case that ambient cistern is opened and completely undisturbed the rest of the arachnoid membranes. Another tumor of the tentorial edge before and after resection, again using only the simple supracerebral infratentorial approach. A little more complex meningioma, you see that there is a subtemporal part. It's between the petroclival ligaments. The tumor extends into the cavernous sinus and as far anteriorly as the chiasm. So let's see the steps of surgery. So what first is done is the resection of the tumor along the superior petrosal sinus in the posterior fossa. Then the tentorium is opened in this V-shape fashion. The lateral cut may end as far as the fourth nerve entry into the cavernous sinus. Then the subtemporal part of the tumor is resected. And lastly, the part of the tumor which is in the interpeduncular cistern is resected. And this is again, from our anatomical studies, you see that all those basal cisterns are not well defined. There are tubercules, those are not really the walls of arachnoid like we may imagine. Only the Lilienquist membrane and supratentorial cisterns are rather compact, but not the posterior fossa. The distinction between prepontine, premedullary, and interpeduncular is very, very shady. And you cannot depend on arachnoid wall in these regions. So how the resection of this tumor proceeds, this is the 7th and 8th, ICA, the 5th nerve. Then as the resection proceeds, we see the 5th and 6th nerve. Then later on, entering the ambient cistern, because this was the multicisternal tumor, obviously this is the 4th. And I can tell you that that's the nerve which is most difficult to preserve in this approach, going anteriorly, because there is main bulk of the tumor in front of the ambient cistern. Then there is the superior cerebral artery, which is running towards us, to the surface of the cerebellum. And this is at the end of surgery when interpeduncular fossa is free. You see the P2 on the opposite side, the optic tractus on the opposite side, the pituitary stalk, and the posterior clinoid process on the opposite side. This is just better seen, the pituitary stalk and the tractus opticus on the opposite side. And this is the ipsilateral side, which is identical. Again, the posterior cerebral artery, again, the posterior clinoid process, the third nerve, which is running between the posterior cerebral and superior cerebral, as they are leaving the basal. That's one of the anatomical musts, unavoidable. This is the basilar artery. This is the superior cerebral artery, posterior cerebral artery. Here will be the third nerve. And you see the shiny structure in front of the basilar artery. And this is the Lilienquist membrane, which composes the anterior wall of your resection. And this is the tentorial opening at the end of surgery. And this is the whole area we need to resect such a tumor with very simple, in fact, convexity craniotomy. This is after, obviously, the piece of the tumor left in the cavernous sinus, which I don't like to enter just because of meningioma, since we have all those radiation techniques. This is a more complex tumor, meningioma, which could be called a sphenopetroclival. You see that there is a large part in petroclival region. There is a large part of the tumor subtemporally. Again, the petroclival ligaments are interclinoidal and petroclinoidal ligaments are involved, and the tumor extends from superior petrosal sinus to the cavernous sinus and really to the temporal region. This was done with the exoscope, so that is why it's a little shifted to the side. So this is at the beginning surgery, and tumor was rather soft. And you see that very early on, you see the brain stem and the relation of the tumor to the brain stem, which in my mind is very, very helpful. This is the superior cerebral artery being released from the tumor. And then we are getting to the 5th nerve, which runs virtually through the tumor. So it's being stimulated. Then as the resection goes ahead, we are getting to the front. This is the uncus. And this is the 3rd nerve. And this is the most anterior piece of the tumor. is actually in front of the third nerve, is being resected over there. Then there is still the large chunk of the tumor being hidden underneath the temporal lobe. So this is the third nerve when it's dissected free. And now we shall turn our attention to the rest of the. This is the fourth nerve, which unfortunately was severe during surgery. And again, as I said, actively seeking for the sixth nerve, which is here, being stimulated. And at the end of surgery, we were able to release the fifth nerve and dissect the fifth nerve free of the tumor, but obviously quite a lot of the tumor remained behind within the cavernous sinus, which we did not attack. Let me show you the images. So this is the remnant of the tumor within the cavernous sinus, which we now follow, but I expect that soon we shall use the some radiosurgical treatment. These are the two cases of petroclival meningiomas where we had to leave the piece of the tumor behind attached to the brainstem. We do not use gamma knife up front. So in this case, the tumor didn't grow and the remnant is stable for several years. In this case, the remnant grew, so we irradiated it by gamma knife, and now the remnant is stable, and both patients are doing perfectly well without any deficit. We published petroclival meningiomas on several occasions, and now let me show you the superior going above the tentorium. It's very logical approach. You can come from posterior without any retraction. You get to all these regions of the middle fossa. It's rather easy, suitable for many tumors. The cholesteatoma before and after surgery. Here we have the cavernoma of the tentorium before and after surgery. Here is a young lady who decompensated and she already had partial aphasia when she came to us. So we didn't want to retract any of her very eloquent brain on the surface of the tumor. So we came supracerebral through the tentorium and resected the tumor. This is after resection, and the lady is completely neurologically intact by now since she improved her aphasia. It's not only the supra-infra, it's combination. Should you go medially, then there is the combination with falcotentorial roots for large meningiomas. But should you go laterally, then you can combine it with retrosic and with far lateral approach, or enough lateral, as I like to say. So this is the petroclival meningioma, which really has a long attachment to the clivus, and actually the attachment was between the 7th, 8th, and the 9th and 11th in front of them, both cerebropontine and prepontine cisterns. This is after surgery, the patient, and this is what it looks like. So we are starting, sorry for that, maybe it will start. Yes, we are starting with supra-infratentorial. This is the brainstem already, and we resect the upper part of the tumor. This is the retrosic phase with 7th, 8th, and this is at the end, this is the 9th and 11th. And only when we resect it and cut the attachment in this region, the whole tumor came into view, and we were able to resect it rather nicely, as you have seen on the image. So now the tumor finally comes into view here, and this is the last remnant of the tumor being resected. So what about the overall results of all the 100? Yes?
2 minutes, Steve.
Yeah, I'm done. The overall results, there was a good recovery in 94%, and now I'm talking also about the pineal region. It's all together. I didn't have the data yet divided into two groups. Minor and temporary deficits, especially the cranial nerves deficits, which clear was another 20%. So the serious morbidity mortality we have seen in 12 cases altogether. There were 5 PC meningiomas.
On the right side or left side?
severe complication, spinal tumors, ependymomas, which is not subject of this lecture. The complications were caused by technical errors in 3 cases, one venous infarction by thalamic bleeding, and then they were caused by the group of patients which I call too much too late, the decompensated patient who is 80, who is having his heart attack 3 years ago, who is hypertonic and who's got obstructive pulmonary disease. He comes to you being decompensated, so you cannot decline surgery, but you can expect that the post-surgical course will not be rather smooth. This was a very unhappy case of rather simple CP angle meningioma. The lady did well for 3 days, and on day 4, this bleeding in the opposite side thalamus appeared and the patient died. That was probably the most unfortunate case. So what we can reach with this supra-infralateral approach, we can reach lateral aspect of mesencephalon, lateral aspect of the pons, good for cavernomas mostly, up CPA petroclival posterior clinoid region, and going further to the front, we can reach as far as optic chiasm, and we can reach basal, medial, occipital, and temporal area. So it means that we can reach lots of space and lots of structures which are frequent target of surgery. In general, anything which is above the internal acoustic meatus and a little lower can be reached by the supracerebral infratemporal approach. We never ever can forget about the general management, about the options we have, radiosurgery, radiotherapy, oncological treatment, and of course observation, which is a very viable treatment option. So it's most rewarding surgery. However, it's dangerous surgery with rather a high number of temporary and minor deficits, and the patients are frequently coming asymptomatic. These are the lesions which do not cause symptoms that frequently, and morbidity may be serious. So we offer surgery only to those where we prove the growth or advancing of the symptoms. We quite frequently can only follow the patients. Of course, and it was said many times, remnant is better than deficit. Of course, we cannot forget the alternative treatment like radiosurgery. And of course, observation, as I said, is a legitimate treatment modality. Management complications are frequent or may be frequent, but you know about them only with hindsight. You never know that you made a management error before you did it. And the complications are with the cranial nerves, then vascular and neural. They are not that frequent as one would expect. But the problem are these patients who are coming too late with too much of the symptoms. There are 2 unavoidable conditions for supra-infra. Mentally, it's anatomy, and anatomy. Know where you are going and what you are going to meet there. And especially in meningiomas, it's the knowledge of systems. And then there is a physical. As long as you use the microscope, you must have long enough arms to reach the target of your treatment. Otherwise, you can use exoscope, which you can have as short arms as they come. So messages: be flexible and inventive, be dogmatic. CUD approach to the lesion. I like the supra-infra approach, but it's not good for all the lesions we are seeing. So you must not be dogmatic. Once you have mastered the supra-infra, don't use it for everything. On the other hand, in my mind, the supra-infra is something like a pterional of posterior fossa, of upper posterior fossa. Same may apply to dogs. You see the CP angle tumor in a dog. Here is another one. The approach is nearly the same, more like retrosig. This is the patient after. We even published these meningiomas in dogs, and it was fun for us. And we've published these 2 books, but I would like to draw your attention to cavernomas, where these options of supra-infra are described in detail. Thank you very much for your attention.
Thank you, Professor, for your excellent presentation. We will take just one question. If there any question from panelists.
Arshad, do you have a question?
Yeah. Hi, Professor Vladimir.
Hi,
Hi, how are you? Good.
good, thank you.
Thank you. Excellent, excellent. I have heard you again, the same topic, but this time different cases were presented. 2-3 things I wanted to clarify with you. One is when you open the dura and there are hanging cerebellar veins, supracerebellar veins, do you coagulate them or not?
This doesn't apply that much to lateral root. This applies more to the pineal region. There usually is one vein coming up. What I always check is the tentorium for the venous lakes, which are quite frequent. And with these veins, if there is one only, I coagulate it, because then you may tear it out of the tentorium, and that's much more troublesome. Otherwise, yeah. So I usually cut it if it's one only. If there are more of them or there are 6, I just wait. And as you may have seen, there was one venous infarction in a series.
Yes, yes. Second thing, what about do you always use a lumbar drain?
Yes, yes. Okay. I use it for everything. Going to stomatologist, I get my lumbar drain, you know. I really believe in it.
Right, right. And what is the direction of cutting the tentorium when you go to the thalamus from there?
It's a V shape. It's there is no rule for this, you know. I always, for thalamic lesions or for CP angle, I use this V shape incision as much as I need. For thalamic lesions, you do not need much. 1 centimeter, 1 arm of this V-shape incision is enough. It really opens the space very much. If you are going subtemporally or suboccipitally, then of course you must cut off the tentorium almost entirely. But it's really the custom cut.
Yeah, and one more thing I wanted to know. Post-operatively, when you handle these nerves, like 9/10 you have handled or 3rd nerve you have handled, does the patient develop some temporary paralysis post-operatively?
No. The problem with older patients is pneumocephalus. Since we are doing it in sitting positions and we drain all the CSF actually at the end of surgery, unavoidably. So pneumocephalus sometimes is a problem.
Handling of the nerves doesn't cause any paralysis.
Handling of what?
Nerves. Cranial nerves. Cranial nerves.
Cranial nerves. If there is some minor deficit, we do not take care about it because that will improve. If the deficit is complete, then it's of course problem. There were a few 6 nerve deficits, and it's very unpleasant. We didn't have 3rd nerve deficit as of yet. The 4th nerve deficit is just fine because not even the patient realizes that quite frequently. And of course, 7, 8, it's like in schwannomas or anything else.
Right. Thank you, Professor. Excellent. Thank you. Very much. Enjoyed.
Professor Marco,
thank you.
I have a question. I have a question.
Okay.
Congratulations, Dr. Vladimir. Very nice presentation. I have a question. In big meningioma spectroclival, it's important. The Dr. Menfi say all the time surgery, and the problem is the complication when the more surgery, mass complication. It's important to combine technique, microsurgery, radiosurgery, or what is your opinion in big meningiomas, petroclival?
In any petroclival meningiomas, I never ever offer the surgery on a third side to the patient as long as he's asymptomatic, and we see a lot of asymptomatic patients. So never ever. If it's a lady, 50-ish lady, I always ask her whether she is not treated by some hormonal treatment by obstetricians. You need for her to be more beautiful and more younger. So this must be stopped, any hormonal treatment. And I wait for half a year, and only if the tumor grows or if the deficit appears, then I offer the surgery. So there are many patients which we only follow.
Thank you. Another question. When do you have
I don't hear you. You have switched off your.
The second question, when do you have a meningioma petroclival, when you have many tumor more rostrally to the brain, what is your approach? Transtemporal anteriorly or combined supra-infra-tentorial?
Supra-infra. Even for that, because the tumor provides you with the space. So you really can get there. And you know, all these transpetrosal approaches, they take time. It's a long approach. This is 20 minutes approach. You are directly there. And you have a very good control of the tumor origin going along the superior petrosal sinus and to the clivus while resecting the tumor along this. And only then you go for the main bulk of the tumor. So I can tell you that I almost exclusively use this approach for any meningioma in petroclival region.
Thank you, dear Professor Benes, for excellent presentation. And we will shift to next speaker. Please join us.
Excuse me, Sam. I'm sorry to interrupt
I will announce just now. Professor Benes, please join us.
Great.
You don't just wait. Please join us in other Zoom room for more discussion. We have prepared other Zoom room, and we will send the link on chat box. You just click on it to get there and ask more questions and discussion. Thank you, Sage. Thank you again.
Okay,
please, Professor Sreen, start your lecture.
Hello, everyone.
To you.
Hello, everyone. Do you see my slides?
Yes.
Yes, it's okay.
Can you hear me? Okay, so good evening and to everyone.
A big screen? It's not big screen yet. Yeah.
Okay.
Full screen. I mean.
For me, it's full screen.
Yeah.
Okay. It's okay for you?
No, it's not full screen here.
Oh. What can I do?
Just click on F5.
F5.
Yep.
It's better?
No.
It's not working.
Not yet.
A small button beside 106.
Yeah, at the bottom right of the screen, one of those icons.
First button beside the zoom in this on the right side, the smallest button.
Sorry, I don't seem to find it. For me, I'm sharing completely.
Okay, can you unshare then share it again?
Okay, just a minute.
Okay, at the very bottom, it says 106% at the very bottom.
Yes.
At the bottom right.
Yes.
To the left of that 106%, there's one of the icons. Click one of those icons.
How about now?
Not quite. There you go. Okay, perfect.
Good. Okay.
Oh, fell off.
Okay. Thank you very much. And I'm very, yes?
Please,
fell off.
Please start to share it again.
Okay.
Please start sharing it again. Sorry.
Okay.
Perfect.
Okay. So once again, sorry for this. Thank you very much for this invitation. It's a privilege to participate in this reunion. So I will try to speak about the indications of the supraorbital eyebrow approach in cellular and paracellular pathology, and also to look into the indications of this approach. But first, I would like to start with a tribute to the late Professor Pernetsky, who coined this approach, and also to Professor Hopf and Reich, who initiated me to this technique. However, we are almost 20 years after the description of this technique, and it's far from being completely accepted. I can still hear people saying, well, you know, skull-base surgery, it's complicated, you need to see, you need space. But what one should understand is that skull-base surgery, it's not really a matter of space. It's essentially a problem of working corridors. When you lack space in surgery, it's usually that you lack a working corridor, otherwise you would be fine. So I also heard yesterday a distinguished panelist saying, don't try to be minimalist, be safe first. Well, I completely agree with the second part, but I think we should try to be minimalist, because whatever we can say, at equal neurological result, patients are better when they are operated through minimally invasive approaches. So you shouldn't consider minimally invasive techniques only for the sake of them. Certainly you should be safe first, but always considered something minimal. Let's look a little bit into the advantages and disadvantages. The optineural approach, it's our workhorse. Everyone knows it. It offers a very large access. It allows all working corridors, either possible extensions in subtemporal, subfrontal, interhemispheric, orbitozygomatic. But of course, it's more invasive. But anyway, when you have a huge clinoid meningioma like this, I wouldn't tackle this through a minimally invasive approach. So classically, you do it like this. The mini-pterional, it's a smaller variant, which gives essentially a transsylvian access. It allows you also to access the middle skull base, to access all the anterior part of the polygon of Willis, but it have fewer possibilities of extension, and you lose the subfrontal and the interhemispheric corridor. The eyebrow approach, it's a really minimally invasive approach. It gives you essentially a subfrontal access, but with this, you can sweep the entire anterior skull base. You can access all the anterior part of the polygon of Willis, but you have few extensions possible. You can extend a little bit lateral, you can remove the orbital ring, and you have a poor visibility of the olfactive gutter. You can compensate this certainly with an endoscope. And of course, you lose the transsylvian and the interhemispheric access. So that's why when you're considering the eyebrow approach, you have to do a very precise reasoning when choosing the lesion, when choosing the side of your approach, the position of the patient, how much bone you have to remove, how much arachnoid cisterns you have to open, and of course, the dynamic retraction of the brain. So we'll look into these points one after another. The choice of the lesion, this is essential, especially when you start. I think the eyebrow approach has a quite smooth learning curve, but you should start easy, you should start soft, and you should start avascular. And this example of suprasellar arachnoid cyst, it's a perfect example for a good case to start. You just need a small opening. You just put a hole in the anterior membrane, a second hole in the Liljeqvist membrane, and the operation is done. The choice of approach, I think it's probably the most important matter, especially for the suprasellar area. And you know, there are a lot of discussion for suprasellar lesions about ipsilateral approaches, contralateral approaches, and nasal approaches. And everyone has his arguments. We heard some of them this afternoon. So I think the problem with the ipsilateral approach in suprasellar lesions, especially when they are slightly lateralized, like this one, is that when we go ipsilateral, you always have the optic nerve in the center of the approach. So when removing the lesion, you will always need some kind of optic apparatus manipulation. And we all know that the optic nerves are not very tolerant to manipulation. So that's why the contralateral approach is very interesting, because it gives you an unimpeded view to the entire tumor. So you should always think about it. And the endonasal approach, of course, it's a very good option because you don't have to cross any nerves. In this case, we've chosen the contralateral approach, and you see that you can do a lot of things. You can even drill the medial part of the optic canal and remove the extension in the medial part of the tumor, through which through an ipsilateral approach would be very difficult to tackle. Why choosing the contralateral approach? Because we know that about 85% of tuberculum sella meningiomas are originating off midline, and in 70% of the cases, they invade the optic canal, and mainly they invade the medial part. So it's exactly the part that you don't see very well through an ipsilateral approach. The idea of contralateral approach is not new. It was already proposed through classic transcranial approaches 10 years ago, and it offered very good ophthalmological results. Positioning, it's essential in any skull-based surgery, but I think it's even more important in minimally invasive approaches because positioning already will create half of your corridor. So head elevation, neck extension will already create a slight inclination of the orbital roof, which will naturally retract the frontal lobe, combined with a slight lateral flexion. Lots of bone you need to drill. The orbital rim, you need to remove it as much as possible. All the preeminences of the orbital roof. And as a rule of thumb, I don't open the dura as long as I'm not able to turn my bipolars or my microscissors in extradural space in all directions I need it. Otherwise, your approach won't be safe. Opening of the upper arachnoid cisterns, like in any surgery, it's important. What people usually forget is that when you do an eyebrow approach, you are very close to the deeper part of the sylvian fissure. So just opening the proximal part of the sylvian fissure gives you more retraction of the frontal lobe and gives you access to a lot of CSF, and you can continue the surgery much more comfortably. And finally, dynamic retraction. Brain retractors are not so useful. Actually, I think in more than 90% of the surgeries, you don't really need brain retraction. And when doing an eyebrow approach, you already have a small opening. The brain retractor will take more space. And so you need to learn how to work without brain retraction, fixed brain retraction. Just using dynamic retraction, which was very good, very well described by Professor Spetzler 10 years ago. So let's look now at the indication of the supraorbital eyebrow approach. So obviously, as we've seen yesterday with our Taiwanese colleague, or anterior skull-based meningiomas are operable through this approach. Suprasellar meningiomas. Clinoidal meningiomas with the condition that they are not very developed into the temporal fossa. Suprasellar pre- and subchiasmatic lesions like pituitary adenomas with subfrontal extension, cranio, Radke, epidermoid or arachnoid cysts, aneurysm of the anterior part of the polygon of Willis, intraaxial frontovasal lesions, and even superior orbit lesions can be approached like this. We'll cycle back to the tuberculum sella meningioma because there is a lot of controversy about the right approach for these meningiomas. Transcranial approaches are the classical way of dealing with them. The last 15 years saw the endoscopic endonasal approach and the supraorbital eyebrow approach, and every technique is competing for the best results. And also you have the discussion of ipsilateral versus contralateral. Most of the literature, the recent literature, seems to favor the endoscopic endonasal approach, which has less visual deterioration but higher risk of CSF leakage. However, in most of the transcranial approaches with which the endoscopic endonasal approach was compared were done ipsilaterally. So I think we don't have a real comparison with the results when surgery is done through a contralateral approach. And sometimes we see in series up to 40% visual deterioration, which is quite surprising, but I think it's also related to the ipsilateral approaches. A very recent review looked into the visual improvement and showed that the endoscopic endonasal and the supraorbital approach have quite close results, and certainly much better than the classical transcranial approaches. We looked into our experience at Rothschild and Foch hospitals in the past 5 years with this approach. We have 21 patients which we operated, only one visual deterioration, one aseptic meningitis, one chronic subdural hematoma, and 4 anosmias. It's an approach which is quite easy to learn, because here you have the photos of 3 of my young colleagues whom I trained into this approach with very good results for them. So cosmetic results are excellent. We didn't have any patient complaining about the aspect of the incision. Let's look now into other indications. This is a recent case, 2 weeks ago, a young patient who came with a pituitary apoplexy with a subfrontal expansion and a very severe visual loss on the left side. As you can see, the optic nerve is crushed between the inferior expansion of the adenoma and the superior subfrontal expansion. So you can discuss an endoscopic endonasal approach, but I think it would be difficult to cross the nerve at this point. So we did it through a simple contralateral right side approach, and we could removed completely the suprasellar part. So in this rationale, you convert the tumor in 2 parts, 2 easy parts, a simple suprasellar part, and afterwards in 3-4 months, a simple endoscopic endonasal part. Craniopharyngiomas, we deal with them mostly through endoscopy. However, in rare case, when the tumor is cystic, subchiasmatic and small and lateralized, you can also deal it through a contralateral approach, like in this case, which was done by one of my younger colleagues. And you can remove the lesion completely while preserving the stalk. Aneurysm also are a good indication, providing that you select carefully the cases. You can do even multiple aneurysms, like in this case, where we clipped ACOM and an MCA aneurysm with good results. Finally, less common indication, the temporomedial lesions. You have to remember that just behind the ICA bifurcation, you have the ancus. So you just need to put a small incision into the ancus and you'll find any temporomedial lesion. And this is the case of a young patient who came with about 20 partial complex seizures per day, which we could cure through surgical removal. And of course, the superior orbital lesions I talked about. And more exceptional indication, a third ventriculostomy through the lamina terminalis. You can use it to wean patients of shunts when they have slit ventricle syndromes, and you cannot offer endoscopic ventriculostomy. So I have a problem with my videos, so I'll share my videos directly. So I don't know if you see them like this. Can you confirm this, Dr. Hassan?
It's okay.
It's okay. So this is a case. It's a case of suprasellar meningioma. So this is a classical subfrontal approach. The right optic nerve, the opening of the Sylvian fissure, lots of the CSF. You can see that while we don't use any fixed retractor, you already have a very good corridor. Sharply opening of the arachnoid over the optic nerve and the olfactory tract, and then coagulation of the tumor base. Quite often, these tumors may be very hemorrhagic, but as our previous speakers said, you have to tolerate some bleeding and avoid coagulating near the optic nerve. And while coagulating, you have to retract the tumor from the optic nerve. So we complete the disinsertion of the tumor, which was quite hemorrhagic. And now we can progressively mobilize it. And we identify the contralateral optic nerve. More debulking. And once debulking is sufficient, the dissection of the branches of the superior hypophyseal artery. This step is essential in order to preserve the vascular supply of the optic nerves and the chiasm. And then slowly mobilizing the tumor in the space created by the debulking, continuing the dissection into the arachnoid plane. And now you can see the arch of the superior hypophyseal artery. And of course, the arachnoid membrane you have to preserve. That's the end. The arachnoid dissection from the contralateral side. And now you see the left optic nerve, the junction with the chiasm. And that's the end. You can mobilize completely the tumor and remove it. Final step, coagulation with curved bipolars, always checking the medial optic canal for for tumor residues. And the final hemostasis. Okay, the final image, the contralateral carotid artery, the pituitary stalk, and the optic nerve. And the patient had a very good postoperative result with a good visual recovery and a complete resection. Quick second case. Which is a 75-year-old patient with metallic foreign body, so no MRI possible. Some headaches, some memory disturbances, and we see a left clinoid calcified mass. We did an angio CT scan to rule out calcified aneurysm, and it was classically a meningioma of the anterior clinoid with the M1 segment stuck at the posterior aspect. So same procedure. Left eyebrow approach, coagulation of the meningioma insertion. In this case, the meningioma was very fibrous, very calcified. So we used the ultrasonic aspirator at full power, knowing that the M1 segment will be adherent, so you don't need to mobilize the tumor until you debulk it sufficiently. So we identify the M1 segment, the ICA. Now that we know where the vascular elements are, we complete the debulking and we complete the disinsertion of the tumor. Now you have the complete ICA, A1, M1. We continue debulking because the tumor had no arachnoid plane, which explains why the patient had a lot of edema. But however, you can preserve the front orbital bands, front orbital vessels. And then by reducing the tumor, you find the adhesion to the M1, and you can see that the adventitia, it's a little bit invaded. So with sharp dissection, you can free the last segment, the posterior segment of the tumor. And with this, we completed the dissection of the dome of the tumor. This is the final view. Resection of the dura over the clinoid, over the distal dural ring, and the final view. Patient had a very good postoperative course and complete resection without complication on the postoperative CT scan. So I hope I convinced you that the eyebrow approach is not something impossible and not something acrobatic. I'm not saying that it's something you should try for any skull-based lesion, but you should consider minimally invasive approaches whenever it's possible. So thank you very much. And thank you, Dr. Hassan, Dr. Bennett, for this wonderful meeting.
Thanks a lot, dear friend Sabine, for this excellent presentation. Is there any questions from panelists?
I have a question. Dr. Alde, it's very didactic and it's step-by-step a great talk. Thank you. So my question is, so do you drill the sphenoid ridge from inside for greater angle of attack or not?
It happened for the suprasellar meningiomas, no, but I did it for temporomesial lesions. It happened. It happened to be necessary, but for the suprasellar meningiomas, I didn't need. I never needed to drill the sphenoid ridge. Actually, you need to drill the sphenoid ridge if you need more access in the temporal fossa. But as I said, if you have a clinoid meningioma with a lot of development into the temporal fossa, you can do it by using the endoscope. But I think this is a moment when the technique, you're starting to push the technique. When you push the technique over its natural limits, I think there you start not to be safe for the patient. So you should consider a mini-pterional or something.
Thank you. Another question, do you drill the orbital roof from inside? You remove the orbital roof from inside?
As I said, this is my rule of thumb. Before opening the dura, I'm detaching the dura for the orbital roof up to the sphenoid ridge. And I drill the orbital roof as much as possible, as humanly possible. Sometimes it may happen that you enter the orbit. It's not a problem. The patient may have a small bruise. But my criteria for going intradural, it's being able to turn my bipolar and my microscissors in any sense I want. Otherwise, I don't consider I'm safe for intradural work.
Thank you so much. It was a great talk.
Thank you very much again, and congratulations, Dr. Hassan, Dr. Bennett, for your wonderful work.
Well, you know, Soren, I'd like to explain what we're trying to do. We're trying to make the Zoom more human, and we want to get networking better. So what we're doing, we're offering the presenters the option of going into a separate Zoom. It's like a networking lounge. There are students there now waiting.
I have the link.
Yeah, waiting for you. After this, you leave this Zoom and then you go into the lounge. And then that applies to all the speakers after their talk. Because sometimes in a 15-minute format, you don't have time to answer the questions. Questioners may come in there and ask you. So, okay, we hope to see you in there. Okay, Sam, it's all yours.
Thank you very much.
Thank you.
Thank you. Okay, we will shift to our next speaker, Professor Mustafa Berker. Please start sharing your screen. Thank you.
Yes. Hi, good morning, good afternoon. Dear Chair and colleagues, I would like to thank especially Dr. Hassan, Dr. Yağmurlu, and Dr. Bennett for your kind invitation to share my knowledge and experience. Objective of this lecture are: how can you manage the nasosphenoidal and intrasupra paracellular complication, rhinologic, endocrinologic, vascular neural, and CSF ligand infections, and all of them is precautions and treatments. From 2006 until now, we performed 1,492 operations. As you see from the slide, great majority of them are pituitary adenoma. As you can see, hyposmia is the most common postoperative complication, followed by the CSF leakage and epistaxis. I have 3 neurovascular complications. The first and most common rhinologic complication, hyposmia, smell loss. Hyposmia generally resolves in 3 months' time. Complete smell loss is 1%. Olfactor, when you look at the anatomy, olfactor fibers spread over whole upper turbinate and upper part of the middle turbinate. So we have to keep away from these areas. How can we prevent the hyposmia? In extended approach, the upper part of the middle concha must be protected as much as possible. Bilateral inferior middle turbinectomy should be preferred. As it expected, we have no septal perforation on endoscopic transsphenoidal surgery. Sphenoidal sinusitis was not seen much, but as the patient do not return to neurosurgeon because of sinusitis, I think that its frequency must be higher. You see a nasal septal defect in this coronal CT session. The septal defect was from the patient's previous macroscopic transsphenoidal surgery. The endoscopic view, you can easily see the defect. Slides on the lower row shows sphenoid sinusitis after our surgery. These are preventive measures for sinusitis. I want to emphasize the last one, particularly to leave the floor of the sphenoid sinus open. After total tumor removal, cavity is partly packed with fibrillary surge cell. Then cellular floor is closed with gel form as a cover and a last layer povidone or rifocin embedded smaller gel form piece of the support to cover. The second complication, epistaxis. There were 21 cases of epistaxis that needed the treatment, mostly in postoperative first. Caused by the injury of the posterior septal defect, posterior septal branch of the sphenopalatine artery in the nasosphenoidal stage of the surgery. In the slide, distribution of the sphenopalatine artery branches in the sphenoethmoidal recess here and the sphenoid ostium here is seen in the right nostril. The surgery must be performed in the hypotensive anesthesia, but at the end of the surgery, hemostasis must be done in the normotensive state. Before finishing the intervention, be sure that there is no bleeding in the mucosal edges. That's why control mucosal hemorrhage before the closing. Patients with acromegaly more frequently have a carotid artery protrusion and dehiscence. This is very rare complication, but it's important. It's important that neurosurgeon must keep in mind this anatomic variation. In order to avoid the mortal complication, by the endoscopic panoramic view, you can detect the carotid dehiscence as you can see here. Is early and after complete peeling of the sphenoidal mucosa, then we can see the easy. This video presents a patient with carotid dehiscence. Carotid artery may easily be damaged if you don't notice this anatomic variation after peeling the mucosa. Some example of the carotid artery dehiscence, as you can see the CT on the upper slides, axial CT scan and coronal view, the same section, same level, and the endoscopic view, same patient. Bottom slides show clival dehiscence on CT and sagittal MRI sessions. When you look at the endocrinological complication, the most important diabetes insipidus and hypopituitarism are the major endocrinological complication of the pituitary surgery. Permanent diabetes insipidus occurred in 10 pituitary adenomas and 4 craniopharyngiomas. Hypopituitarism is mostly seen in the first 2 weeks. So you should check cortisol and thyroid hormone levels on the postoperative day 1, day 3, and day 10. How can you prevent the endocrinological complication? Determine the position of the normal pituitary gland in the perioperative MRI, where the stalk and where the pituitary gland are. And the second important point, use sharp dissection, and if it's possible, make extracapsular dissection. Also, avoid using bipolar around the stalk and the normal pituitary gland. This is normal pituitary gland. When you remove the tumor, we don't use the bipolar in this around the normal pituitary gland, also the normal stalk. Neurovascular complications are the most terrifying complication during the surgery. Bleeding blocks endoscopic vision that highly complicate the management. Number one, you must be calm and how to know to manage it. At the same time, you must have an experienced neuroradiologist who can treat it. I have 3 neurovascular perioperative complications. All of them were previous operated patients. 2 of them were also irradiated. Following slides demonstrate how terrible a carotid bleeding under endoscope is, and also they show how you can manage it. First example. This 41 years old female patient who was previously operated by microscopic transfemoral surgery for Cushing disease, our department. She was admitted to our department by recurrence. If you are not carefully and if you don't examine detail of MRI, you cannot see any vascular abnormality without tumor. There was no report about the intracavernous aneurysm preoperatively. I want to show the video. During the surgical intervention, please give attention. We are at the very beginning of the cellular opening. Please pay attention. I'm removing the mucosa, peeling the mucosa, and start to enlarge the previous bony opening. This is previous opening, and I want to enlarge the opening. We are in the limits of the standard cellular opening, but the aneurysm was under the normal cellular flow, and it bled. Bleeding was successfully completed, controlled by fibrillar surgical packing. Surgery was discontinued and patient was transferred to neuroradiology suite immediately and treated by the endovascularly. The slide showed the aneurysm, and when returned to the preoperative MRI slides, as you can see, preoperative MRI, retrospectively, we recognize the aneurysm, not the iatrogenic. The aneurysm was treated by the stent and coiled embolization. The patient was discharged without any neurological deficit, but with adenoma, published as a review in Pituitary 2010. Another example, 30 years old male who was previously operated by microscopic and endoscopic 2 times transfemoral surgery for Cushing disease, and radiotherapy plus temodal were given for increased mitotic index, atypical adenoma, admitted to our department by recurrence. And all right cavernous sinus invaded by the tumor. Before and after dural opening, I used the Doppler ultrasonography to be sure where the cavernous sinus internal carotid artery was. I thought the fibrotic tissue on the right side of the cella was tumor remnant, as you can see. Many times I checked the Doppler ultrasonography. I want to cut it out because the tumor was so hard. But radiotherapy and chemotherapy changed the vascular structure and distort the anatomy. I made a mistake. I should look at the structure by Doppler before using scalpel on the recurrent fibrotic in the cavernous wall. Now, the carotid wall is bleeding. I packed the bleeding carotid artery with fibrillar surcell and petties. I controlled the bleeding and directly transferred the patient to angiography suites where the vessel wall was repaired by standing by the angio suite. On the left slide, traumatic pseudoaneurysm is seen. And on the right slide, pseudoaneurysm was treated after the procedure. This is after the procedure. Vascular injury risk in the endoscopic pituitary surgery, invasive macroadenoma, revision transfemoral surgery, received radiotherapy, long-term dopa agonist therapy, cabergoline, for example, and the most important one is aggressive surgery in the tumor with cavernous sinus involvement. To determine this very important problem, T2 weighted MRI images should be interpreted carefully. Another example, as you see the upper slides, in the left cavernous sinus internal carotid artery is much larger than the usual. So I suspect, as you can see here, traumatic aneurysm, and I proceeded with CT angiography. Also, the patient operated before the admission, operated another center, microscopic transfemoral surgery. I proceed with CT angiography, and which is seen here on the left, internal carotid artery, anterior band aneurysm. I referred the patient to neuroradiology, to endovascular treatment. The patient was not operated because of the anticoagulant therapy after coil embolization. Unfortunately, she had experienced a brainstem hematoma and died when she was waiting surgery. Complication avoidance and prevention is preferable and easier than their treatment. To rule out any vascular lesion, one must carefully inspect the T2 weight MRI images, especially the coronal sections on MRI. Also, the more you learn, particularly patient's anatomy and radiology, the more you can avoid the complication. The slide shows our perioperative CSF leakage ratios. postoperative CSF leak that needed operation is 2%. A new dural reconstruction technique, dural flap technique of cellular floor was published in 2014 in our Nexus Larynx. Protecting the cellular diaphragm must not be the priority in functional pituitary adenoma surgery. Total excision must be the aim to protect the integrity of the diaphragm, but the active pituitary adenoma, as I mentioned before, not the priority. Firstly, plug the defect by adipose autograft, then reinforce the plug, adipose tissue, and fibrillar surgery. Prevention of the CSF leakage on the extended approach. It must be known the CSF leakage can happen, but it can be treated by using correct technique in the initial surgery. Any opening in the dura and arachnoid must be sealed perfectly by autograft. Then you can use the Haddad graft. If you anticipate a large diaphragmatic defect in the extended approach, you can easily utilize a nasoseptal Haddad flap, which is prepared in beginning of the surgery. First, the diaphragmatic defect is closed watertight. This most important part. It's the defect is closed watertight, and the cellular cavity is filled with autograft and Surgicel. Then the nasoseptal flap is laid on the base smoothly without folding, as you can see in the video. Prepare at the beginning of the surgery in the nasopharyngeal stage. Then we laid the cellular floor without any folding. And look at the infection. Infection after the transperineal surgery cannot be seen as much as expected, but it may be very fulminant and must be suspected and treated urgently. I have only one mortality due to the fulminant meningitis in a recurrent ACTH adenoma patients. In order to avoid infection, one must follow the steps. Surgical field should be washed with saline or antibiotic solution at every stage. Infection should be detected as early as possible and treated aggressively and quickly. If there's a CSF leak, do not insert a lumbar drainage catheter. Perform primarily repair with fat or muscle autogen graft. Don't use the allograft or synthetic graft. Neural complication. Neural complication. Optic nerve and oculomotor nerve are rare instances, but especially in recurrent and irradiated cases, the surgeon must be very careful in dissecting the fibrotic tumor in the boundaries, especially where the is cavernous sinus invasion. Take-home message are: principal surgical strategy is excellent preoperative evaluation and elimination of all risk and correct surgical planning. Staying away from the complications, you should not hesitate to ask for help from other departments, other disciplines, for example, ENT and neuroradiology. If you are ready, you can overcome this type of problems without despair. This deer is symbol of our university, which comes from the 4,000 years. The Hittites who lived and had a strong social and scientific impact on human history. They had the first written treaty, the Kadesh Treaty, with great Ramses in the ancient Egyptian pharaoh. Thank you very much for your attention.
Thanks a lot, dear Professor, for this excellent presentation. Is there any questions from
I have a
panelists?
question.
Okay,
I
please
don't
unmute
hear
yourself.
you, Dr. Hassan.
Professor Marco, please unmute yourself.
Okay. Congratulations, Dr. Mustafa. Very nice presentation. I have a question.
Yes.
What is your opinion to put an acceptor flap to fascia lata? Because you put mucosa, do you have any problem with the olfaction? What is your opinion, fascia lata or nasocseptal flap?
The most important one, the diaphragmatic defect completely closed as a watertight. If you don't it, your Haddad flap or your fascia lata graft doesn't work. The most important part, the diaphragmatic defect plugged with fat or muscle or a sandwich type fascia lata graft. Did you understand me?
Yes, thank you very much.
Okay. If your door is open, doesn't work another strategy or techniques.
Okay, John Bennett will explain the idea of our launch Zoom. Please start, John.
Yeah, thanks, Sam. Thanks, Mustafa. Yeah, I just want to basically, we're trying to improve the networking aspect of Zoom in neurosurgery, and we're also trying to make it more human.
Okay.
Therefore, after the speaker presents, we give them the option to go to be interviewed by med students at another Zoom. I wrote the channel in your chat box, Mustafa.
Sure.
He left there.
Thank you very much.
But yeah, I wrote the message in your chat box. You leave this and go into the Zoom room, and the med students are there waiting to meet you.
Okay. Again, thank you, Hassan and Dr. Bennett and Dr. Yamal.
Thank you. Okay, Sam, back to you.
Thank you. And I will introduce Professor William Cudwell. He is the next speaker. Please start sharing your screen.
Sure. Thank you, Dr. Hassan. Can you see this?
It's okay, and sound is clear.
There, can you see it now?
Yes. It's
Can you
okay.
hear me? Can you hear me okay?
Yeah, perfect.
Yep.
Okay, wonderful. So yeah, well, thank you very much, Dr. Hassan and Dr. Bennett. I wanted to just talk a little bit about something that I've given a lot of thought to and has been a real nemesis of mine over the years. And I don't have any significant disclosures. This is where I'm from, in the foothill of the Rocky Mountains, a beautiful area. But let's talk about transnasal surgery. It was interesting in America, Cushing didn't actually innovate much for the pituitary approach transnasally, but he used it in over 200 cases. He used Halstead's approach, the submucosal dissection, a bivalve speculum, is very similar to what we use up till just recently. And he published a very low morbidity and mortality for over 200 patients. It was really remarkable, but since he was trying to promulgate transcranial approaches at the time, he felt that the transcranial approaches from above gave him better view of the suprasellar cistern and control of the optic nerve decompression. And so he actually abandoned the approach, and Norman Dott in Edinburgh continued to do it during the time that Cushing had really abandoned the approach in America, and all the American neurosurgeons followed suit. He taught it to Guillot in Paris, who's a brilliant man, and then taught it to Jules Hardy from Montreal, who really, and Hardy and Guillot really repopularized the approach and brought it into the modern day with using the microscope and illumination. Also fluoroscopy to really verify where they were. Guillaume was a brilliant fellow. He worked with Tessier in Paris in craniofacial approaches. He did stereotaxis, and he was the first one to use an endoscope in a transfenoidal surgery in 1962. So predated probably by 2 decades, most people. The interesting thing is I grew up in Canada. I went to school at McGill, and Hardy was one of my mentors. And we wrote a historical vignette on Guillaume and Hardy. And then Hardy and I wrote a historical vignette on Guillaume with all the contributions that he made. He's really, I think, a hero in our specialty. And it's really been an honor. Hardy was in his heyday when I was a medical student and told me much of the history. And then also Marty Weiss, I wanted to acknowledge. So let's talk about giant tumors. The definition that we use is larger than 4 centimeters in diameter, and they account for 5 to 15% of pituitary adenomas. And that's pretty much what it is in my own series. I have over 3,000, about 3,500 cases now that I've done. The pituitary tumors are very common, but usually they're microadenomas and they're incidentalomas. They're very common in the general population, almost 17% in autopsy studies. But we don't really understand why, if the microadenomas are so prevalent in the general population, these giant pituitary tumors are not very frequent. This is the presentation of them: endocrine dysfunction and visual disturbance. And we treat all prolactin tumors medically, even regardless how big they are. Only occasionally will operate on an apoplectic prolactinoma. I think that really the issue with operating on these tumors is the delivery. And I use this analogy as suggested by Atul Goel. I think it's a good analogy. Most of the time we're able to finesse a lot of these large tumors down because they're soft, and we can use different techniques to try and get them to drop. And I'd like to talk about how I do that. It is remarkable to me that you can have a tumor that's this size and compress the pituitary stalk and the chiasm, and you have preservation of pituitary function, even though you have such an atrophic and wispy stalk here, and the pituitary gland is mostly atrophic as well, but they can retain pituitary function, which really indicates to me it's quite a resilient structure. So the few tricks that I use, this is from one of Hardy's original diagrams. I don't use the opening of the cross. I use an X, or I remove the dura itself from carotid to carotid on these giant tumors. So the way you get a roof to drop is you take out the floor of the house, and you take out the walls of the house, and then the roof will drop. And so that's the analogy that I use. And we have to open widely to be able to get them to come down. I have a series of 108 giant tumors that's just being published in the Journal of Neurosurgery right now. It's in press. And this is a diagram from that picture, or from that paper. But it shows you the technique that I use. And the ones that you're most likely to get to drop transphenoidally, whether it's an endoscope or microscope, you want to get the roof of the tumor to come down. And so what I do is I open up the dura widely, as I mentioned. And then once you do that, you start to work around the perimeter and you identify the arachnoid. And the whole idea is that you want the diaphragm and the arachnoid to maintain and be intact as long as possible, because the CSF pressure is going to allow you, is going to be your friend, and it's going to help push the tumor down. And so we concentrate on removing tumors in the gutters and on the back wall. And then you'll see the diaphragm start to herniate down into the field. Try to be careful. Don't break the diaphragm. Remove the tumor inferiorly, remove the tumor laterally, and it will start to come down and capitulate. And ultimately, then you're left with a completely everted diaphragm. It looks like an everted uterus, and a herniation of this diaphragm down into the field. And you can see where the pituitary stalk comes through the diaphragm at this level. So this is what you're trying to achieve. So try to maintain, be careful, try to be gentle with the diaphragm and not get a CSF leak, because we'll use some tricks from above to be able to help push it down. So as I said, remove the floor, remove the walls, leave the center for last. We'll use Valsalva very commonly with anesthesia. And then as something Ed Laws taught me is that if you bilaterally occlude the jugular veins, and you can just do it yourself or have your assistant do it, it actually is sort of an Uber of Valsalva, and it really increases the intracranial pressure, and you'll be able to see some consequences from that as well. So what are your surgical options for removing these big tumors? You can use a single transfenoidal approach, and I'll use that for tumors that I think that will drop. But if I don't think the tumor will drop, I'll tell you what we'll do. The advantages and disadvantages, you can use a transcranial approach as well, and these are listed here. And you can do a combined approach as well. I've done this a few times. In general, you'll see what my philosophy is by the end of this talk about these tumors. I always am concerned about contaminating a perfectly clean approach from above with a more contaminated approach from below, but I have had no problems with infection myself with that. So this is the historical view of the mortality and morbidity of these giant adenomas in the literature. And you can see they had very high mortality originally. It's improved, but it's still high. And why is that? The extent of resection is fairly low as well, and I'll show you why. If you look at the most recent review of the literature, you can see the near total tumor exceed was in 74%, and the mortality still remained high at 4.4%. This is a systematic review. Gross total resections were improved a little bit with the endoscope over the transfenoidal, of the microscopic transfenoidal. And these visual improvements were also better using the endoscope if possible. The endoscope enhances removal for obvious reasons. So let me just briefly give you the results of our series. We looked at tumors greater than 4 centimeters, and we found 108 patients over this period of time. And as I said, this is my career is about 3,500 cases I've done. And these are the baseline characteristics, the percentage. It's a little bit higher in men. And you can see the different visual acuity and field defects, which is high in these patients, and endocrine dysfunction as well. The real problem with this is the NOS grading system is that most of these tumors have invasion of the cavernous sinus. And just to remind you what NOS grade 3 and 4 are, it's when the tumor approaches the lateral aspect of the carotid or encases the carotid. So these tumors tend to be large and invasive, and they invade the carotid. And so you have, or invade the cavernous sinus. So you've got cavernous sinus invasion at the beginning, which limits your resection. So if you're completely honest with your resection, unless you're removing the tumor in the cavernous sinus, which I don't do in patients with binocular vision at the first operation, then your recurrence or your resection rate is lower. These are the approaches that we used, and I'll show you some of my philosophy using some illustrative cases and some of the complications that we've had. I will tell you that the outcomes have been fairly good. We're a little bit better. We've had 1% mortality in this series compared to 4.4% in the literature, but we still have complications, and I want to show you what I've learned from this. So this is an interesting case. This actually case was published previously, but this is a 30-year-old man who presented with bilateral 6 nerve palsies, and it was sent in to me as probably a cyst of the sellar and suprasellar region because there was absolutely no enhancement you can see in the lesion. And this I just show you as an example of how extensive apoplexy can be. Now remember, apoplexy is a continuum from necrosis to hemorrhage, and a lot of them have both necrosis and hemorrhage. But this is one end of the spectrum, which is unusual, where you've got this apoplectic tumor causing 6 nerve palsy. It's necrotic. The whole tumor is necrotic. And you can see that this is an indirect evidence of apoplexy. And we published this before. You get mucosal thickening with apoplexy. It was originally noted by Arita in Japan, and we looked at it. It correlates directly with the severity of apoplexy. I don't know why it occurs. I presume it's humoral factors released by the dying tumor. It's not pressure. But if you remove the tumor, this goes away in the next day or two. It's amazing. But it's a good indication of an acute apoplectic event, this thickening of the mucosa. And this is what he looks like 6 months postoperatively, and you can see the tumor's been removed and there's his pituitary stalk. So when is a craniotomy necessary? These are the classic indications for craniotomy as in the literature. And I would say another indication I would add is cranial neuropathy from cavernous sinus invasion, and I'll show you why in a case that I'll show you. Let me show you these cases to consider. Here's a 57-year-old woman with cognitive decline and visual loss. She's gained 100 pounds over the last 6 months. You can see the tumor. She's got hydrocephalus. The cell is enlarged. That's a good indication. It's a pituitary tumor. And then she's got this massive tumor extending up into the transcranial space here. So I came in, this was, the prolactin level was normal here. So we came in from below initially, and I wouldn't have done this this way now, but you can see that I tried everything to get this down with an endoscope, with all different curettes, but I couldn't get the roof to come down. It's just too large and it's too eccentric. And so what we did is we came in the next day and removed the remaining tumor transcranially. Let me show you this case. Here's another example, anterior extension of the suprasellar component, giant tumor, large cella, pituitary tumor, and he came in with cognitive decline. We did a transsphenoidal, and you can see what happened here. We got part of the tumor out. I couldn't get it to drop, and the remaining part of the tumor had an apoplexy, and I had to go back in the middle of the night and remove the rest of the tumor transcranially. And I just want to remind all the young people, this is a feared complication of partial resection of these large and giant tumors. It occurs in roughly 10%. And I really think that this is the most deadly complication that you're going to run into with these tumors, because you can have apoplexy, they're prone to apoplexy. And if you basically remove part of the tumor, you cause a shift in the remaining part of the tumor and you can cause apoplexy. And then the patient can get into trouble. So this has changed my thinking about this completely. And what I like to do is I like to control the mass of the tumor with the first surgery, whether you need to do it combined or whether you can do it through one approach. But if you don't think the tumor is going to come down, and this is a classic case, I would never think that this tumor would come down properly transnasally. Maybe you'll get this part out, but you certainly won't get this part out. So we'll come in transcranial on this pace. And if you follow the axis of the tumor, you can go right down to the cella. And so here's an example at large cella. You could do it in two approaches, but you can do this through one approach. And if you come down the tumor corridor that you're making, you can get down to the cella and remove the tumor in the cella as well. So this was one transcranial approach. So exposure of cella by transcranial route. So let me show you a few cases here as an example of difficulties that you can get into. Here's another one with a lot of subfrontal extension. And so this is an example of these tumors can be apoplectic to start with. So this is at the opening, and you can see this tumor has remote hemorrhage. And so when you remove this tumor, you want to be cognizant of where the pituitary is. And obviously, you're going to decompress the optic nerve. Here's the carotid bifurcation here, and I'm dissecting the tumor off the frontal lobe. And we'll go ahead and remove the tumor. We'll debulk it, decompress the optic nerves, decompress the vasculature. And then you want to be cognizant of when you approach the region of the residual pituitary tumor or the pituitary gland. And what you'll see here is you'll end up, the gland will be pushed posteriorly, and I'll end up exposing the gland, and I'll try to preserve the gland. If you come completely extracapsular all the time, you run a risk of devascularizing the gland and interfering with the stalk. And what you're looking for here is you're looking for now, I'm pushing the gland forward from the back. And what we'll do is you'll end up with a tumor that's coming out of the residual gland here. Now I've got the residual gland and I'm very careful to try and preserve that. It's like a catcher's mitt. The tumor grows from the gland and then it gets displaced by the tumor. And so at the end, we'll try to preserve the gland as much as we can. And so here's his post-op scan and good resection. Here's an interesting indication. And I think this, I think a lot of people would choose to come at this transnasally, but I chose to come at this transcranially for a single reason here. If you look, this woman's had radiation in the past. She's got primary recurrence in her cavernous sinus and in her sella. So you could make a case, well, do you come in from below or do you come in from above? And here's the tumor coronal imaging, and you can see she's got at least as much mass lateral to the carotid as she does medial to the carotid. So you can make a case either way. She's got diplopia already. So in this case, I'm much more aggressive and we'll go ahead and choose an approach to try and remove the tumor. It gives you a bit of a license here. When they've got diplopia, you can go ahead and be more aggressive with the tumor in the cavernous sinus. She's had radiation and our radiation therapist did not want to radiate her again. So we use an extended middle fossa, Dolink approach, peel up the lateral wall of the cavernous sinus as taught to us by Dolink and Hakuba many years ago, and we'll try to find a window into the tumor. And what you need to understand here is that the tumor is growing medially to laterally. So it's pushing all the nerves laterally. The only nerve that I'm concerned about here, obviously 5 is in the wall and I can see that, but I don't know where the 6th nerve is. So that's what I'm looking for. All through this case, I'm looking for the 6th nerve. And you'll see I find it. She had a 6th nerve palsy already. And I do find the 6th nerve, but you'll see it's completely divided when I find it. There's the 6th nerve. Okay, so what do you do? Well, we can go back to the region of Dorello's canal in this case. You're there, just take out the posterior part of the tumor and find the other end of the nerve as it exits Dorello's canal here. And freshen it up and then go ahead and reanastomosis. Remember that the 4th nerve and the 6th nerve, if I find them divided by the tumor or I can't leave them in continuity when I remove the tumor, I always try to repair them. Now, the reason I chose a transcranial approach for this is I think that this is much better done from a transcranial approach than an intranasal approach. And so that's the reason that I chose a transcranial approach on this case. And here's the post-op scan. And she's had a good resection of the tumor. And you can see a little bit of fat that we left in the cavernous sinus. Transcallosal approach. This is a case that Chandrasekhar Dubajara and I did in Bombay, India. This is a 36-year-old man who has a giant adenoma that they tried 2 different approaches on, an endonasal approach and a transcranial frontotemporal approach. And they said it was very, very firm and they couldn't get anything out. So he's got hydrocephalus, he's got a VP shunt in place, and we'll come again down the axis of the tumor. And so what we'll do here is come transcallosally. And so we're doing a transcallosal resection. You can see the callosum that we've opened here, and we'll go ahead and debulk the tumor and come right down the axis of the tumor. And then the important point I'd like to make is that this takes you right down into the sella. And so it actually is a perfect view to the sella. You don't need to augment a transnasal approach for this, but the tumor did go in to the region, and you'll see here, I'm removing, there's the enlarged sella already, and we're removing the floor of the sella, and we're moving the tumor right up to where the tumor extends into the cavernous sinus there. And so we'll stop there. It's a great approach. We plug up the opening to avoid a hygroma using some gel foam, a little bit of fibrin glue here. And here's his post-op scan with tumor in the cavernous sinus. And so here's the original tumor. And here's the post-op scan. The tumor was, this was actually true with gamma knife radiosurgery because it grew after surgery. So, but he's done well. So this is the approaches that I've used in this large series that's being published. And you can see standard transsphenoidal in the majority, frontotemporal, subfrontal. These are all your windows, transcortical and transcallosal. And again, the workhorse, transsphenoidal, and probably frontotemporal in most cases. Other tips in conclusion here, this is something that we've noted that you can see these cysts around these giant adenomas, and much more common than in meningiomas. You can see them in meningiomas, obviously, but they're quite common in these pituitary tumors. And Ann Osborne was the one that taught me this, is that this is trapped CSF, but the point being that it actually helps with your resection because, again, it dissects around the tumor. If you come in transcranially, it really helps with your resection. This is an important one. And this is when you get cavernous sinus invasion of the tumor enters the cavernous sinus and then it exits the cavernous sinus. It can exit through the oculomotor cistern, okay? And so what you see here is you see the oculomotor cistern on this T2 image, and you can see the third nerve going through the cistern before it goes into the primary, into the cavernous sinus directly. And then this here, the oculomotor cistern is obliterated with tumor. And so you can see this on the preoperative imaging. Here's another case here. So you see the oculomotor cistern in a coronal T2 or a Fiesta image. And on the right side, the oculomotor cistern is filled with tumor. Now, why is that important? It's important for this reason, because here's a cartoon showing this. So here you have tumor growing up through the diaphragm, in this case, into the cavernous sinus, and the path of least resistance is the growth through the oculomotor cistern. And so this is a common place where the tumor exits the oculomotor cistern. The point being that if you remove the tumor transnasally, you will never see this component unless you open up the diaphragm and look laterally. Case in point, here's a gentleman presented with this large tumor, visual loss. Here's his pituitary gland and stalk. I told him that I'd remove the tumor, but I'd leave this component because it's coming out the oculomotor cistern here. And lo and behold, I did that, and he developed apoplexy in the residual tumor. And I had to go back in transcranially and remove that. I don't know what I would have done differently in retrospect, but it is a risk, and it's good to counsel your patients this way. And finally, I will just tell you a little about a little trick that we use. So remember, most of these tumors are soft. So if you do have these tumors where the dura of the medial cavernous sinus wall is pushed out, but it's still contained by the dura, you can actually extrude some of that tumor through a transsphenoidal approach. And what we do here is we open up carefully the lateral wall of the cavernous sinus, and we work laterally to the internal carotid in this direction, and then also in the anterior loop of the carotid here. Now you've got to be careful because the sixth nerve runs right close to the carotid if you come in through this corridor, and you can injure it, so be careful with that. But we'll use the same tricks that we use to get the tumor to drop. If there's no CSF leak, you can use a Valsalva, or you can use bilateral jugular venous compression, and you can get tumor to extrude through this area. We call this the tooth-based extrusion technique, and you can see this case where we've pushed a lot of that tumor from the medial or lateral to the carotid here out of the cavernous sinus. So indirect removal is feasible. What are the unresolved issues? I think the issue with cavernous sinus invasion is a real important one. When we treat that, and we still struggle with this, and there's differences of opinion even in our own department about this. I like to wait and see the tumor grow in the cavernous sinus, or have the patient develop new symptoms before I treat them, because I've had such complications with radiation over time of lesions in the cavernous sinus. But this is yet to be resolved, the timing of when to treat this. So in conclusion, giant pituitary tumors are still a treacherous problem. Mortality has improved. Complete resection is not possible in most cases because of cavernous invasion. Large functional tumors, growth hormone screening especially, are really problematic. Control the mass to avoid apoplexy. This is a really important message for the young people. And multimodal treatment is necessary in most cases. And I thank you very much.
Thank you, dear Professor, for your excellent presentation. Is there any question from panelists? Okay, thank you, Sam. I'd like to invite you to the second room. It's Zoom lounge for more discussion and questions.
Yeah, I'd like to personally invite William. Yeah, William, we're trying to increase the interactivity and the networking. So
Sure.
we've created another room, a Zoom room for you to go to. I put the link in your chat. You leave this and go to that Zoom room. There are a couple of med students there, which just so you get to meet them and they get to meet you in the flesh. Not almost the flesh.
Wonderful. Thank you, Dr. Bennett. Thank you, Dr. Hassan. It's been an honor. I appreciate it.
Okay, Sam, back to you.
Thank you, Sam. And now we will shift to our next speaker. Professor going to please start sharing your screen. Professor Guento, are you there?
Hello, everyone. Thank you. First of all, I would like to thank my good friend and Professor Sameh and Dr. Bennett for this invitation. Believe me, it's a great honor for me to be here sharing this panel with such giants neurosurgeons from all around the world. My topic is going to be directed towards the analysis about the approaches and the anatomy of the infratemporal fossa and parapharyngeal space. But let's start with this some anatomical remarks. As you know, both areas are located below the skull base. I mean, below the greater wing of the sphenoid bone and the temporal bone. So these areas are medial to the jaw, to the ascending ramus of the mandible. Well, in detail, first of all, the infratemporal fossa is a triangular area that is limited by the maxillary tuberosity here and the pterygoid process here, and lateral for the ascending ramus of the mandible. If the neurovascular structures are considered, we can find here the V3 here, the maxillary, the internal meningeal artery, and the maxillary artery. And behind this area is the parapharyngeal space. The parapharyngeal space is a quadrangular area that is behind the infratemporal fossa and in front of the cervical spine. If neurovascular structures are considered, we can find here the carotid artery, the jugular vein, the lower cranial nerves, and the styloid process. That is very good reference to find mainly the carotid artery. Well, the mandible, as I was saying, also plays a good role in the anatomy of these areas because the ascending ramus conforms the lateral limit of infratemporal fossa mainly. And here I want to show you some specific anatomic points that it has to be very important to keep in mind when we are approaching these areas. There is the condyle, here is the coronoid process, the hole for the inferior alveolar nerve enters into the mandible. It's very important to keep in mind when we have to mobilize these areas. This is a posterior perspective of the osseous reference of this area. Here we can see the pterygoid process, the middle cranial fossa, the condylary fossa, the condyle of the mandibular, and if the muscles are put there, we can find here the most important two muscles in this region that are the superior, the lateral pterygoid muscle and the medial pterygoid muscle. The lateral pterygoid muscle has two branches, two parts. The sphenoid is the upper part, and the pterygoid part is the inferior part. And if we put the infratemporal fossa in this schematic representation, we can find that it corresponds to a triangular pyramid, which its base is directed towards the skull base and the apex is directed towards the cervical spine. And is lateral of the medial pterygoid muscle. It's very important to remember that. And the parapharyngeal space is a quadrangular prism that is located behind the infratemporal fossa, and of course, behind and medial, the lateral pterygoid muscle. If we make the description plane by plane, I'm going to show this the dissection of these areas using these cartoons. In the first place, when the skin is removed, we can find the parotid gland and the facial nerve that is crossing the parotid gland. If we remove these areas, these structures, we can find here the temporal muscle and the masseter muscle here. And if we make this specific and these particular cuts, including the base of the temporal muscle, the zygomatic arch, and a part of the masseter muscle, it's possible to get into the infratemporal fossa. As you can see here, we can find the lateral pterygoid muscle with its two branches, the two bellies, the superior or sphenoidal and the inferior or pterional. And behind this, we can find here the medial pterygoid muscle. This is a magnification of this area just to be able to identify all the references. You see here the maxillary tuberosity, the lateral pterygoid muscle here with its two components, the medial pterygoid muscle here, the ascending ramus of the mandible that has been cut. Of course, the zygomatic arch has been removed, and the representation of the infratemporal fossa is like this. You see, it's a pyramidal triangle with the base directed toward the skull base and the apex to the cervical spine. And behind this area is the parapharyngeal space behind the medial pterygoid muscle, and including in that space the styloid process. I'm going to show you the same dissection, but in cadaveric specimens, in the same way, I mean plane by plane. If we make an incision here in the frontotemporal area, continue in the preauricular area and in the cervical area, we can mobilize all the cutaneous flap just to expose the temporal area, the pterional area of the cranium. Then a craniotomy is performed, that it has to be according to the lesion that we are going to deal with. And this is the detachment of the temporal muscle. Then we are looking for the facial nerve. This is the facial nerve that is exiting from the styloid mastoid foramen and is going into the parotid gland, where it bifurcates or trifurcates inside the parotid gland. Then we make a cut in the base of the coronoid process. The condyle, sorry, in the base of the condyle of the mandible, we are going to make a transversal cut. Then we are moving in front just to find the coronoid process, and we are going to make another cut in the base of the coronal process. And now we are going to make a V-shaped cut in the junction between the ascending ramus of the mandible and the body of the mandible, like this. With these three cuts, it's possible to elevate the ascending ramus of the mandible and to show the inferior alveolar nerve here and the artery that is growing inside the ascending ramus of the mandible. So we have to unroof it to free it from its osseous portion, and this is the inferior alveolar nerve and the artery, and we are now able to remove completely the whole ascending ramus of the mandible. So we can elevate the parotid gland and we can see the infratemporal fossa. We track the parotid gland in front, we can see the infratemporal fossa medial to the parotid gland. You can see here the facial nerve. So to get into the infratemporal fossa, it is necessary to cut the facial nerve and to remove the parotid gland. When all those areas are removed, we can see the zygomatic arc here, the condylar fossa, the condyle with the base with cut, and the coronoid process. And we start to see all the elements that conforms the infratemporal fossa, which are the lateral tibial muscle. You can see here both parts of this muscle, the sphenoid and the pterional, and the medial pterygon muscle that is here. And the vascular elements that we can identify here is the internal maxillary artery going to the pterygomaxillar fissure, and the inferior artery, alveolar artery, and the inferior alveolar nerve. If we remove the zygomatic arch and the condyle, it's possible to see the condyle is here. It's possible to see the lateral pterygoid muscle with its two components very clear. Well, here's a deeper dissection. We can see the inferior alveolar nerve here, the inferior alveolar artery, the internal maxillary artery, the middle meningeal artery going to the spinosum foramen spinosum, to the middle fossa. And if we mobilize all these structures upwards, we can find here the parapharyngeal space. You see here the styloid process, the three muscles that are inserted in the styloid process, and there is a membrane here, and through the membrane we can see the carotid artery here. If we cut in the base of the styloid process and mobilize with all this muscle downwards, it's possible to enter to the retrostyloid parapharyngeal space, where the carotid artery is clearly seen here, the jugular vein, and the lower cranial nerves. These are all the bony cuts that we have to make to get into the infratemporal fossa and parapharyngeal space. And if we put these pieces of bone in the specimen, we can see all the cuts that is necessary to perform to get a wide approach to these areas. But of course, we cannot do this in the patients. We have to to plan strategically the approach just to avoid the damage of the facial nerve, the damage on the chewing because of the removal of all those structures. So this is the next part of my talk. And one of the most important approaches that can allow an ample exposure of the infratemporal fossa mainly is the orbitozygomatic. I mean, by the removal the zygomatic arch, as you can see here, it's very easy to get into the base of the infratemporal fossa. So in most of the cases, it's not necessary to make an ample approach. Just by an orbitozygomatic approach, it is possible to expose from about this area, mainly the infratemporal fossa. How? Well, I'm not going to take a long time just discussing this the techniques of the orbitozygomatic. Everybody knows how to know it, a pterional approach, but I'm going to show you how we do this orbitozygomatic osteotomy. It can be done in 2 or 3 phases. We use to make it in just one piece, the craniotomy, well, 2 pieces, the craniotomy 1 piece, and the orbitozygomatic bar in another piece. We started cutting the orbitozygomatic, the orbital rim in the first part, and then the cut is going lateral towards the roof of the orbit, surrounding the superior orbital fissure and going into the inferior orbital fissure. Then a V-shape or inverted V-shape is made in the malar bone, just to be able to remove this the roof and the lateral wall of the orbit. And then another cut is made including the condylar fossa if we need a more ample approach, because if it is necessary to expose the petrous carotid artery, but if it is not necessary, we can make this cut in front of this condylar area. Let's say I'm going to share this some cases just to give some examples of the approach. This is the first example. This is a lady, 68-year-old lady who had some chewing problems. And we see this axial CT. It is possible to see this tumor growing in the infratemporal fossa. It's not in the parapharyngeal space. You can see here the styloid process. You see the limit, which is the ascending ramus of the mandible. In the coronal cut, it's very easy to see how this tumor is growing in the infratemporal fossa almost exclusively, medial to the condyle of the jaw, medial to the condylary area of the jaw. So in this case, you see here the MRI. This is the tumor growing in the infratemporal fossa almost exclusively, but is hidden between the muscles in this area. In this case, it's very easy to expose this tumor just from above. As I said, in orbitozygomatic craniotomy, it's possible to expose completely this lesion and to remove the tumor as I'm going to show you now. We did an terional and orbitozygomatic approach just to expose the tumor, but including the condylary fossa, but because if you remember, the tumor was medial to the mandibular condyle, so it's very important to get an ample exposure in these regions. So the patient was placed in a supine position with the head rotated, slightly rotated, and the skin incision was a curvilinear, continued with a preauricular region, and the exposure is schematically represented like here, and this is the surgery. You can see here, this is the middle fossa, this is the bone of the middle fossa. Surgery begins with the drilling of this bone of the middle fossa, and then find, first of all, the middle meningeal artery to coagulate and cut, just to make a peeling of the middle fossa. It's important to make this coagulation. Now here I'm exposing V2 in the foramen of V2, and then we are continuing with the peeling behind. This is V3. I'm going behind just to find all the structures. The tumor was below V3. This is the greater superficial petrosal nerve, or the greater petrosal nerve, the famous GSPN. As a reference, it's very important to remember that below this nerve, the petrous carotid artery is located, and this is the end of the exposure. We are going below B3 because the tumor was growing from the foramen ovale to the infratemporal fossa. This is a tumor. This was a classic epidermoid tumor. You can see here the keratin component of the tumor, that is the core of the tumor. It's very easy to remove it with an ultrasonic aspiration. It's relatively easy because it's a tumor that is not vascularized and is very soft. So this central part of the tumor can be removed very easily. You can see here the condyle, but the most important part of this surgery is to remove the epithelium. This capsule or epithelium of the tumor is who produces the keratin, so it has to be removed completely. So to avoid the regrowing of this tumor, I'm working now medial to the condyle. You see how easy it is to get this area just by the removal of the zygomatic arch. And this is the final steps of the surgery and the final exposure. You can see here V2, V3, the condyle, the petrous carotid artery below the greater superficial petrosal nerve. And this is the end of the surgery where the tumor has been completely removed just from the craniotomy. It's not necessary to mobilize any of the structures of the mandible to get into this area. This is the B3 extracranially going into the infratemporal fossa. The B3 is going to change to the inferior alveolar nerve. And this is the end of the surgery and the control MRI. In the left side, you can see the tumor here and the abscess of tumor in the immediate CT scan. In the coronal view, it's possible to see here pre and post-operative how we can get into this area very easily just from the craniotomy. And the MRI in the upper line, you can see the tumor here, and in the same cuts, you can see the post-operative MRI with is very easy to see that there is no evidence of residual tumor, and the patient that didn't have any problems, and she was able to return to their previous activity. But these areas are sometimes clinically silent. So it's not very rare that some cases the tumor can get huge dimensions because the patient does not have any symptoms. So when they go to the clinic, the tumor has reached huge dimension like this case. You see, this is a patient, another woman, I don't remember the age, maybe 44, 42 years old. who had this big tumor growing completely into the infratemporal fossa. But you can see here how the tumor is getting downwards, deeper than the other one. So I think in those cases is a little bit limited, just making the approach just for the cranium. So it is necessary to combine with another route, with another procedure to be able to expose the tumor. Needle biopsy was performed, but was inconclusive. So we were prepared to make a big exposure just to be able to remove the lesion completely. In that cases, we planned a combined approach. We did an orbitozygomatic approach just to expose the tumor from above. And in the same surgical stage, another surgical team, the ENT guys, make an approach towards the face, the lateral part of the face, making a vertical osteotomy and the ascending ramus of the mandible. Be sure that this could be made behind the inferior alveolar nerve to avoid the damages of this nerve. So the posterior part of the ascending ramus, once the craniotomy is performed, is elevated as a hinge. And now both surgical teams were working together. The neurosurgical teams by detaching the tumor from all the structures of the middle fossa, and the oncology team by removing the tumors from below. So this is the surgery. That's the skin incision. Is an old case. So and the frontotemporal craniotomy is performed as usual. This is the skin incision. This is the temporalis muscle here. The cutting of the superficial temporal aponeurosis to preserve the facial nerve. This is the zygomatic arch, the orbit, and the detachment of the temporalis muscle is made as usual. The detachment is as in any other craniotomy. And this is the exposure of the frontotemporal area, a tyrional area. A craniotomy is already performed. Now the clue of the craniotomy is now being performing by the cutting of the orbital rim, cutting in the condylary area, and a third cut that is not going to be shown in the video is made in the malar bone. So the orbitozygomatic arch, the orbitozygomatic bar is removed, and now the temporalis muscle can be displaced downwards and can be the infratemporal fossa is exposed. This is the condyle and the upper part of the tumor. Now, under the scope, it's very easy to detach the tumor from the elements of the middle fossa, from the carotid artery, from B3. Actually, the tumor was growing from B3. It was a trigeminal schwannoma. And the other surgical team continues the surgery in the face. This is the ascending ramus of the mandible, where a vertical osteotomy is performed behind the inferior alveolar nerve. And then this posterior part of the ascending ramus is elevated as a hinge. So both surgical teams are working together now, neurosurgeons by dissecting the tumor from the middle fossa, and the oncologists by resecting en bloc the tumor completely from below. These are the mini plates that were placed for the reconstruction and the closure. And that's the patient 3 months later that did a little deformity in the mandible, but it's nothing to be concerned about it, but the patient could return to the normal activity with no problems with chewing. And that's the result. This is the CAT scan in coronal view, pre and postoperative, and the MRI pre and postoperative. Is possible to see that the whole tumor was removed totally. This is another case. You see how this tumor can grow and even invade the intracranial portion. This is a giant case of clivoscordoma. The patient was already operated on 3 times before, was submitted to radiotherapy, and the tumor was still there. So we made this combination of the approach, the frontotemporal orbitozygomatic and transmandibular approach to remove the tumor of the middle fossa and the infratemporal fossa. And this is the result. This is the pre and postoperative result. Of course, in chordomas, in this size of chordomas, it's almost impossible to talk about total removal. Of course, there might be tumor remaining here, but we could improve the clinical conditions of the patient. The patient finally died 5 years later, but we could offer some more time for and with very good quality of life. This is another example. You see, this is a highly vascularized tumor. is a young man, it's a 17-year-old man who had this tumor that has completely vascular components of the tumor, and angiography was performed that corroborates the vascular component of the tumor. This was a case of nasoangiofibroma. It's a complex case. In these cases, we use the same approach, orbitozygomatic transmandibular, and this was the result. This is the preoperative study and in the axial cut, and you see how the tumor could be totally removed, and the coronal and sagittal view pre and post-operative. You see the result was very acceptable. That's the patient before he left the hospital with no any other neurological deficit. This is one more case. You see, this is another young patient who had this growing mass in the mandible. This was a typical case of an ameloblastoma. As you know, this tumor, ameloblastoma, grows in the teeth, in the enamel of the teeth. Is not very malignant histologically speaking, but the behavior of this tumor is very aggressive. So the removal of this tumor has to follow the oncologic principles. In that case, we made also a frontotemporal orbitozygomatic craniotomy, and we had to remove the tumor joined together with the ascending ramus of the mandible, because all of this was completely invaded. This is the operative exposure. You see here the mandible and the tumor here, and the exposure in the infratemporal fossa. The tumor is being removed here in block. This is the surgical piece with the ascending ramus of the mandible with all the tumor destroying this area, and the post-operative control here in the axial and sagittal view. You see here pre-operative and post-operative. It is possible to see that there is no evidence of residual tumor. And the patient with the reconstruction, the patient was submitted to reconstruction of the jaw 3 months later, and you see here the bone used to reconstruct the middle half of the mandible on the site of the tumor, and this is the long-term result. Another similar case, this is another case of an ameloblastoma, is a patient who had this huge mass in the right part and the right parts of his face. You see this tumor that has multiple lobes. This tumor has to be removed following the oncologic principles, because it's very aggressive, it's clinically aggressive. And these are the details of the surgery in the same surgical position, and skin incision is in the frontotemporal area and in the cervical area. This is the exposure of the area and the removal of the surgical piece like this. Of course, the parotid gland and the facial nerve had to be removed with the tumor because of the aggressiveness demonstrated by this tumor. And this is the surgical piece and the surgical area once the tumor has been taken out. And that's the result. In the left side, you can see the preoperative MRI, and in the right side, the postoperative MRI. And the patient who has this aggressive surgery, and reconstruction was proposed, but the patient refused to be submitted to another surgery. And that's the patient 2 or 3 years later with no evidence of the residual tumor, and with a good healing of the process of, on the surgical area. This is the last case I'm going to show you. You see how the tumor can grow. This is a malignancy also. This was a case of a dermatofibrosarcoma, a rare case, a rare tumor in this area. But you see how the tumor can grow, invading the anterior fossa, invading the infratemporal fossa, but the cavernous sinus was not invaded. So that's why we decided to operate that patient. And this was the exposure. It's, of course, a craniofacial resection. This is the exposure from the cranium and the exposure of the tumor. The eye was completely invaded by the tumor, so the eye had to be included in the surgical piece. And this is the exposure of the tumor from the face by the head and neck surgeons. And this is the specimen at the end of the surgery, and the initial reconstruction, and the patient that did not have any neurological problems, of course, with the cosmetic problems, but she was submitted to a reconstruction 2 months later. And this is the result. You see here the preoperative and the CT scan and the MRI, and the control where there is no evidence of residual tumor. As a conclusion, we can say that infratemporal fossa are clinically silent lesions, so sometimes tumors can grow, can reach large dimensions when at the moment of the diagnosis. And sometimes to expose these large tumors, it is necessary to combine maybe 2 or 3 approaches just to be able to get an ample exposure, a safe exposure of these lesions. And reconstruction, of course, is as important as tumor resection, because when the tumor is resected, it creates ample dead spaces that has to be reconstructed just to avoid long-term complications. It's mandatory, a multidisciplinary approach, and of course, the same conclusion as almost everyone. Anatomical knowledge of these regions are mandatory, and they have to be a part of the surgical armamentarium of the current skull-based surgery. Thank you very much again for the invitation, and thank you very much to everyone for listening to me.
Thanks a lot, dear friend, for your excellent presentation. Is there any question from panelists?
I have a question, Sameh.
Okay.
Hi, it's Sanjeev Jarana from Oxford. Thank you. It was a fantastic talk. I'm very, very impressed.
Thank you.
Very nice talk. I just have a question. When I do these infratemporal fossa lesions, I've moved away from a full OZ, and we sort of just tailored to the zygomatic cuts to get low. What are your thoughts on that? Do you feel that orbital component is needed, or?
No, totally agree with you. It depends on the size of the lesion. Of course, if it's not a huge lesion, just with the zygomatic removal is enough. You cannot, it is not necessary to include the orbital rim. I include the orbital rim when I'm not sure to get enough exposure, but I totally agree with you. Just by removing the zygomatic arch is enough to expose most of the lesions. Thank you.
Thank you.
Thank you, my dear friend, Professor Guento, for this excellent presentation. An announcement from John.
Yeah, hi, I'm John Bennett, administrator of the site. I'd like to invite you, Gerardo, to come to the Zoom lounge where we have some, actualmente tenemos estudiantes de Latinoamérica esperando para hablar contigo.
Gracias.
Okay,
Thank you very much.
I leave the link in your chat.
Thank you. I will.
And so you leave this chat and you go to that one. Okay.
Thank you. Thank you, Professor.
Gracias. Nos vemos. Okay,
Gracias.
Sam, back to you.
And now we will shift to next speaker, Professor Sanjeev Jayaratna. My close friend, please start sharing your screen. Thank you.
Thank you very much, Sameh. Thank you for the invitation. It's been a fantastic. I caught some of the talks, and I'm going to catch the rest on. I know John is here recording everything, so I'm going to catch the rest of the talks later. So thank you very much for this kind invitation. Looks like a fantastic conference, and well done, John. You've been ubiquitous, haven't you, during the pandemic with all the recordings, which we all really enjoy watching. So thank you very much for this invitation. I'm going to take a slightly different approach and just talk about a similar area to that fantastic last presentation we had. But I'm going to go a little bit deeper into the pterygopalatine fossa and talk about using the endoscopic approach for that. I won't cover a lot of the open stuff because I think I've just been explaining in great detail in the last talk. But I'm going to use some of the Roton pictures and then some of the sort of stylized drawings we've made to understand this area, and then show a case at the end, just explain the sort of technique and principles. So you have to understand the pterygopalatine fossa, both shown on the CT scan here. It's enlarged by the case. I'm going to show a tumor in this location. This is the normal sort of very narrow, deep space. And here in the anatomical Roton dissection, you have to understand it is an inverted pyramid, just like we were hearing with infratemporal fossa. Pterygopalatine fossa is the same. It's an inverted pyramid. The apex is inferior. And I love these Roton pictures, you know, whether I'm going translab or whatever I'm doing. I love using these pictures to think about what we're going to do and explain it. And it's just absolutely fantastic for understanding the anatomy of this pterygopalatine fossa. And I'm going to show a few pictures, but you have to understand the bones around it. And here, to start off with, you can see how the sphenoid is above and behind. The maxilla is in front, the back wall of the maxilla forms the anterior border. The lateral border of pterygopalatine fossa is a little bit harder to understand. It's probably best shown in imaging. This is the pterygomaxillary fissure, that's the lateral border. And medially, of course, I'll show another picture, is the palatine bone. Okay, so we're going to talk about the small space, but an important space where you can have schwannomas typically, but meningiomas, sinonasal tumors, juvenile angiofibromas, all of these sorts of things that a skull-based surgeon you'll be asked to take on and operate on. So small but deep, important space, this pterygopalatine fossa, this inverted pyramid. Okay, so this is just a zoomed up of this roton picture here on the left. And of course, and I'll show some stylized pictures here, but the important key nerve to understand, of course, is rotundum, foramen rotundum V2, going through that into the pterygopalatine fossa, its relationship to the branches of the maxillary artery in there, and again, the borders, and particularly its relationship to the maxillary sinus. If you want to come endoscopically, of course, the approach is transmaxillary. So just this important anatomy again, understanding the anterior wall being the maxillary sinus in this inverted pyramid. And I'll show some of the branches of V2 that are important in some of the drawings that we've made. I think the big advantage we have, of course, over maxillofacial surgeons and ENT surgeons, and I work routinely with them, particularly in the endoscopic approach, I always do with my ENT colleagues, is that, of course, we occasionally get views into this area, even laterally. I think coming laterally is now no longer in favor, but you could extend the approach my colleague, the last talk just showed, and go slightly deeper from infratemporal fossa into pterygopalatine fossa. And of course, that was the sort of old invasive, quite invasive way to get to it. But the big advantage we have, and this is a view from above, you've got the orbit here, you've got infratemporal fossa here, cavernous sinus exposed, and you have to understand how even coming laterally, you could get into it. And the other big approach, which maybe is better shown in this diagram, sorry, on the CT scan, is, of course, ENT and maxillofacial surgeons will do a Cardwell Luck incision and try and come transmaxillary and anterior. And these are all very reasonable approaches, but for reasons I'll show, I think the endoscopic approach is now the favored approach for a lot of lesions in this area. Okay, so we have to understand the other options, Cardwell Luck coming anteriorly, used by our ENT and MaxFax colleagues. And there are open approaches. If you get huge tumors, as we saw in the last talk, then actually open approaches are very reasonable, but we have to understand much more invasive into this location. Now, just a coronal view to show that actually, for a lot of us, particularly people who are doing a lot of endoscopic pituitaries and things, you're actually very close to this area, and understanding some of the approaches to it are important when you want to extend your corridors. So this is a coronal view. Of course, you've got the optic nerves here, pituitary gland and carotids are there. Sphenoid floor has been removed, and we are interested in this lateral area here, the pterygopalatine fossa. This is a lovely view. My colleague previously showed the maxillary artery coming in the infratemporal fossa, and you can see how its branches, which we'll look at in detail, are critical when inside the pterygopalatine fossa. The next slide just starts to highlight the medial borders of it. I talked about the palatine bone, but if you're going to come endoscopically, the approach is medial. So the next key bit of anatomy to understand, of course, are the middle turbinates and inferior turbinates, usually just with displacement of the middle turbinate sufficient to enter into a transmaxillary approach, as I'll show in the video, into this area here. And this is pterygopalatine fossa with the nervous and vascular structure shown here. But occasionally, as I'll show in this video, you also have to displace the inferior turbinate to give a wide enough access in the endoscopic approach, is the approach we are discussing here. So let's move on to some of these sort of diagrams that we've developed to help train people to explaining the endoscopic anatomy in various areas. And here it's the right pterygopalatine fossa. So you have to understand, in total there are 7 openings, and we've already talked about this lateral opening, the pterygomaxillary fissure, and that's what allows the maxillary artery to enter in. And then you have to start to understand the others, rotundum, the other big important one, inferior orbital fissure superiorly. Sphenopalatine is very important as we start talking about these vessels. You see that's critical vessels that we understand well from our nasoseptal flaps. and maybe some less important things like the pharyngeal canal and greater palatine foramen. So if we start to break it down, again, through the pterygomaxillary fissure, it's the maxillary artery that's the important vessel to understand. And for each of these openings, you have to slowly build up your anatomy. You'll see in the video I show how the sphenopalatine ones are important for that tumor, but you have to slowly build up your anatomy for understanding the various nerves and arteries of this area, which can be complex. And the other important thing to understand here, which I think is not well explained sometimes, is how the vasculature is actually anterior to the nervous structure. And some of the older texts that sort of predated good dissections had it the other way around, which is wrong. And as you, of course, once you start operating this, you quickly understand how the vasculature is anterior here. Okay, so that's just starting to build up picture. I'll show an operative video on why this is important. The case I'll show is actually a tumor arising from the V2 nerve and building up your view of the various foramen and how they enter is critical when you come to operating this area and on the ganglion. The medial structures we're very familiar with, particularly the sphenopalatine artery. It's a bit of anatomy we understand well now from the flaps. We usually pick it up more medially, but understanding what happens laterally in its origin in the tracheopalatine fossa and coming off as a branch of the maxillary is very important. You may think these are less important, but actually I've had patients complain due to numbness and things like that when you don't preserve. You can't always preserve, but if you start injuring some sensory nerves coming off here, it can be a concern for patients. Of course, sometimes it's unavoidable. Okay, so now that we've got a sort of an idea of the anatomy, I just want to run through one case, which I think sort of highlights some of the principles when you're operating this area and how an endoscopic approach is very elegant and quite minimally invasive. So it's actually a patient who was a retired nurse, recovered very well from previous Hodgkin's lymphoma, but had a tracheopalatine fossa tumor that we thought initially was a schwannoma. So we were just keeping an eye on it, but it was starting to grow on surveillance scans. And here are the MR pictures. It's not a big tumor, so actually very nice for an endoscopic approach. So you'll see the maxillary sinus there. You can see how it's dorsal to that, expanding that inverted pyramid space. Again, it's better seen, on the CT scan. So there's a scan you saw at the beginning when I was trying to show the anatomy. This is what the normal tracheopalatine fossa should look like, and you can see how it's largely expanded there by the tumor. Not a large tumor, considered a relatively straightforward case, particularly if you're starting out and wanting to do one of these, which is why I'm showing this one. Okay, I talked about some of the other approaches. I think most people have ruled out a terional coming all the way through. That'd be too much. But Cadwell Luck, I think, is an option. We feel that maybe some downsides to it. People who do it a lot may disagree, but I think our feelings endoscopic is much more elegant for this. You have to understand there is still risks associated even with the endoscopic approach, and that's important to explain, of course, to patients. Very, very standard approach. Really, we prepare the nose as we would for any of our transnasal cases, obviously all done under general anesthetic. Okay. So this is what it, you're on the right-hand side. Important anatomy to quickly familiarize yourself with, of course, is the middle turbinate. That's the key. In this operation, we're also going to be working on the inferior turbinate. Now, I think being able to do an uncinectomy and decompressing or removing the bulla is useful, not just for these transmaxillary approaches, but even if you want to go single nostril pituitary. For example, it allows you to keep the middle turbinate intact, which is very helpful. So we've taken backbiting, taken the uncinate, and now we're working on the bulla. I do this jointly with my ENT colleagues. I think that's very helpful. Of course, you have to understand the orbit is above and slightly lateral to us. So now we're inside the maxillary sinus. I might just pause this. So middle turbinate is still intact. That's important in terms of long-term olfaction, not having a lot of nasal mucosal complications. We've mobilized the inferior turbinate down. We've opened the uncinate. We've opened the bulla. We're now inside the maxillary sinus. This is the back wall of the maxillary sinus. There's a thin bit of bone there is being bulged. It's bulging forward because of the tumor. Okay, we don't normally mobilize inferior turbinate. We just thought we needed a bit more access here, and you'll see us reattaching it at the end there. So this is a very standard transmaxillary approach, relatively quick and easy to do. I recommend doing this jointly with the ENT surgeons. They're of course very familiar with this from their FES operations. So the next step now, of course, is to start to mobilize the bone away from this. Here we go. So we're taking away the posterior wall of the maxillary sinus, very paper thin from being expanded out, very straightforward. And you're starting to see the tumor being exposed here. And initially, it's of a lot of this really, it's a sort of blunt dissection around this tumor. You can use whatever technique you prefer here. We're using some patties. We don't always do that, but I think it seemed to work quite well for this case. We know from the imaging is related to V2. So this is the bit about the vessels. It's really important to understand not just the maxillary artery, but the branches. And we had a bit of bleeding here from sphenopalatine branches. So we've cauterized them. You can see one branch there. You can have multiple SPA branches, as you know. And of course, we understand this anatomy very well from the septal flaps. So handling bleeding is straightforward, and we're just working, and you can work around the tumor. Starting to see a bit of the lateral pterygoid there. And you'll see once the tumor is removed, you get a nice view of the anatomy. And we're just working it off. You missed it, so I didn't point out there. We got a glimpse of the maxillary artery. You'll see it at the end. And you can work the tumor off quite nicely. As I was saying in this video, it's piecemeal. The histology actually returned as a somewhat unexpected case for us. We were expecting this to be a benign schwannoma, so actually we had no issues with taking this piecemeal. We're using the ENT microdebrider there. You can use a sonopet or just debulk with your rongeurs. And you can see these tumors tend to have a very nice capsule. The anatomy is all very nicely preserved through this endoscopic approach. You get this very, very nice panoramic view. As you'll see in a minute, as we sort of really inspect the cavity, the endoscope gives you a fantastic view. Okay. So we're just looking around. There's a small piece left. Nice view, beautiful view there, infraorbital nerve. Fat pad's important if you want to go more lateral to infratemporal fossa. Maxillary artery has been preserved. And I pointed out the lateral pterygoid earlier. To the left of screen, of course, is your view if you're going towards infratemporal fossa, which would be an alternative way, but probably not for some of the large tumors we saw earlier.
Can you hear? Okay, Sam, the link works. I clicked on it, it went right in.
So we're just getting some hemostasis here. Sorry, John, I think...
The Zoom room is open. You can always come into an open Zoom room and the link doesn't change.
John, would you mind just muting yourself? We're just putting the inferior turbinate back. I mean, it's sort of standard hemostasis. And there's actually, very little nasal mobility.
It doesn't matter, Sam. The room is open and the link works. It doesn't matter what the time says. It's open. I would understand if the room was closed. It's different, but it's open. It's open on Zoom. It's open on Zoom.
John, would you mind muting? I think we can hear your conversation with Sam. Anyway, patient did very well. Turned out to be a malignant peripheral nerve sheath tumor, and she's had post-op
really
on beam, and she's done very well.
But why does the link work for me and doesn't work for them? Huh?
Thank you.
Okay, have you tried the link? Screenshot that I sent to you is mine. Okay, that's your screen. So you tried it and that's the screen you got?
Thanks a lot,
Yeah, you
Professor.
sent me. Yeah,
Right
you
now
sent
for
me, right?
you,
I remember. Yeah,
start
yeah.
the presentation. Is there any questions from panelists?
Beautiful presentation. Thanks very much.
Thank you, Say. And now we will shift to the next speaker, my dear brother, Professor Hisham Basyouni. Please start sharing your screen. Thank you.
Yeah.
John, I should just tell you, I think we can hear you and Sam talking before Hisham starts speaking, just so you know.
Can you see my screen?
We can, yeah, we can.
And hear my voice again? So it should be full screen now. Thank you very much for your invitation, Dr. Sam and Dr. John, and you're actually pioneers of spreading neurosurgical knowledge around the world. And thank you very much for your great effort and your actual success. So my topic today is management of tentorial and falcotentorial meningiomas. Historically speaking, these tumors were first described in 1833 by Antral as an autopsy finding in a shoemaker, incidental autopsy finding. And these tumors are actually rare. They make up to 6% of all intracranial meningiomas and up to 30% of all posterior fossa meningiomas. So they are mainly located in posterior fossa. And falcotentorial meningiomas as a subgroup of these tumors, they constitute only around 1% or even less of all intracranial meningiomas and up to 8% of all pineal region tumors. There is, of course, as in all intracranial meningiomas, a female gender predominance. So if you see the anatomy, can you hear me? I don't know if you can hear me. Can you hear me?
Yeah, you hear you very clearly.
Okay, very good. So this is as many speakers, we are always returning to Rotun's great images, and this is one of his books which show you the tentorium, which is a dural duplication which is covering the cerebellum and supporting the occipital lobe. And you can see here clearly that it has got an oval or triangular opening, which is central and which transmits the midbrain. And the midbrain divides this space, this oval centrally located space of the tentorial incisura in an anterior incissural space, anterior to the midbrain, the middle incissural space lateral to the midbrain, and the posterior incissural space, which is the quadrigeminal area, the cistern, posterior to the midbrain. And you can also see the important structures like the oculomotor nerve, the posterior cerebral artery, and the many vessels, and particularly the venous structures in the posterior incissural space. So this is an endoscopic anatomy after resection of a chiasmal glioma. You can see both optic nerves. This is the anterior incissural space. You can see the pituitary stalk here. And moving further posterior, you can see the oculomotor nerve, the posterior clinoid process, the basilar artery, the posterior cerebral artery. And in further close up, you can see the tiny trochlear nerve underneath the medial incissural edge, the superior cerebellar artery. Now looking to the contralateral side, you can see the contralateral oculomotor nerve, posterior cerebral artery, superior cerebellar artery, basilar artery, and its bifurcation, and the posterior clinoid processes. If you enter the window between the internal carotid artery and the optic nerve, you can see the pituitary stalk and both the posterior clinoid process and the dorsum cellular. If you look from the retromastoid retrosigmoid approach, this is after resection of an epidermoid, You can see the oculomotor nerve, the superior cerebellar artery, the posterior cerebral artery, the basilar artery. This is the clivus and retroclival space. And you can see the pituitary stalk upwards there and the hypothalamus. As also very nicely depicted in Roton's book, the third, fourth, the oculomotor and trochlear nerve, and the fifth cranial nerve, they're taking, during entering into the dural duplication, they're taking the arachnoid sleeve with them. So there's actually a CSF pocket or a cistern surrounding them. You can see this nicely here. In the oculomotor cistern, the trochlear cistern, and also the cistern of the trigeminal nerve in the proximal part of Meckel's cave. So during surgery, you can have nice and clear vision, like in this case, this is the oculomotor nerve, this is posterior clinoid process, this is the superior cerebellar artery. But you have got other situations, like in this patient who had a recurrent atypical meningioma, where the oculomotor cistern is completely occluded. This is the oculomotor nerve, and it is heavily loaded with tumor, and which is, of course, very sticky in this recurrent case. So the classification, the most common classification of these tumors is the one presented by Yazhagil in his book in 1996. But actually we have to give credit to Sujita, who has already described this classification more than 10 years before Yazhagil's classification. And they have divided the tentorial meningiomas into a medial ring group and a lateral ring group and an intermediate group. The medial ring group is further classified into anterior, a middle and posterior group, T1, T2, and T3, a group which is lined along the tentorial incisura. And the lateral group is also classified into a T5, T6, and T7 group along the lateral border of the tentorium in its attachment to the occipital bone. And the intermediate group, the T4, which is is the free leaflet of the tentorium. You can see this also in the sagittal view, and there's another group which is a T8 group, which is at the junction of the falx, or the posterior third of the falx cerebri with the tentorium. And the T3 is the classic falcotentorial meningioma. These meningiomas can be supratentorial, they can be infratentorial, or they can be both supra and infratentorial. And you can see here an example of a supra and infratentorial meningioma. And you can see another example of these tumors, and you can see how it might be difficult to classify these tumors according to the one proposed by Yazhagil in the T1, T2, T3, T6, and T7. So in our publication, we have proposed to combine some of these groups, which is, I think, more practical and more adapted to the real situation you find during surgery. And we have combined the T1 and T2, that's to say the incisural group. We have combined the falcotentorial groups, T3 and T8, and we have combined the T6 and T7 groups, which was the most common one presented in our patients group. The T4 is the same, and T5, the peritorcal group, is also the same, which are actually rare tumors in our experience. This classification has also been presented in El-Mefti's meningioma book. Now we had 108 patients. The main symptoms were headache, dizziness, and gait unsteadiness. And the main presenting signs were gait attacks and cranial nerve deficits. And gait unsteadiness and ataxia is attributed to the fact that the posterior, the T6 and T7 group was the most common one, which was compressing the cerebellum in the brainstem. So coming now to the individual groups, the T1 and T2, that's to say the tentorial notch or the medial incissural group, they can be approached via usually the pteronal, transylvian, pretemporal approach. If they are more posterior, you can think about a subtemporal approach, but you have to take care about the vein of Labé and the subtemporal veins. And if they are infratentorial, you can approach them via the retrosigmoid approach. And these are the structures which are endangered in these approaches and these tumors, which is particularly as I have shown you in the rodents image, the third and the fourth cranial nerve. Of course, the midbrain, which is transmitted through the tentorial incisura, the optic tract. The optic nerve, not that much because it's more anteriorly. The same, the internal carotid artery, but its branches, the posterior communicating artery and the anterior choroidal artery, which are endangered, that might be endangered in these tumors, the PCA and the superior cerebellar artery also, and the basal vein of Rosenthal. So this is one example in a 66-year-old man complaining of headache, and he had an epileptic fit, so it was a symptomatic tumor, and in this case it was also, as shown on the preoperative CT scan, it was also calcified. And you can see the MRI images, and you can also see the difficulty in classification. So this is actually predominantly T1, but also T2 tumor in this group. This is the coronal MRI image. This is the postoperative CT, and the tumor was resected by a pteronal, a classic pteronal approach, transylvian, and pretemporal approach. So this is the postoperative MRI showing complete tumor removal, and the patient had two early postoperative focal epileptic fits, but what was otherwise normal and had no epileptic fits more after release during follow-up. So this is the T6 and T7 meningiomas, which are usually infratentorial. They occupy the cerebellopontine ankle, and so they can be removed via the retrosigmoid approach, the classic retrosigmoid approach. And if they are supratentorial, then you can use the subtemporal approach. If they have a minor supratentorial component, you can use the retrosigmoid and transtentorial approach. You have to take care about the nerves already mentioned, but also in addition during the retrosigmoid approach to the 7th and 8th nerve group. Of course, the other structures already mentioned, the brainstem, and particularly also the veins, which is the superior petrosal, the vein of Tandy, and the vein of Labé, and subtemporal veins during a subtemporal approach, and of course during your approach and during craniotomy, you have to take care not to open the transverse and the sigmoid sinuses. This is an example, a 35-year-old woman who had headache and visual blurring and bilateral papilla edema, and this probably is attributed to this tumor, which was also closing the transverse sinus on the dominant side, as you can see here in this coronal section, this axial. So this is a complete occlusion of the transverse sinus, and you can see this also on MR venography. You have to take care in these images because there are variants, and these images are flow dependent. So although it is closed on these images, the sinus might be patent, But if you get all images together, you see that the sinus is closed. So this is the approach, which was mainly retrosigmoid, retromastoid, presigmoid, and transtentorial. And this is the surgical video. You can see here the attachment of the tumor to the tentorium. This is removing the cerebellar rim or small rim of nervous tissue from the tumor, and then detaching the tumor from underneath the tentorium. This is the tumor consistency is hard, which is often the case. So you have to use not only micro scissors but also macro scissors to internally decompress this tumor, as you can see here. Then opening the transverse sinus, which is occluded and which is occupied by tumor, as you can see here. So getting the tumor off the sinus and occluding the sinus which was already occluded by the tumor. So there's no risk in occlusion of this sinus and taking away all the involved part of the sinus, which include in this case the transverse sinus and also part of the sigmoid sinus, as you can see here. So this is a complete resection and also occlusion of the distal part or proximal part of the sigmoid sinus. Then you have a look in the cerebellopontine angle. You see the 7 8 nerve, the trochlear nerve, which is covered by the arachnoid, and this is closing the operative cetus after tumor resection. So this is the MRI after surgery, showing complete tumor removal in the coronal and axial view. And this is the patient who had no headache anymore after surgery and normal vision. And also the papilledema regressed, and she is now tumor-free 8 years after surgery. So this is the peritorcular group, which is the T5 group of Jaeger-Gill's classification. And these tumors are usually both supra- and infratentorial. So they should be approached by a bioccipital and by suboccipital approach, the so-called 4-quadrant approach. You have to take care about particular features in this approach because you can damage the calcarine area, which is the medial cortical area of the occipital lobe, causing cortical blindness. And you have to take care about the veins, of course, the confluence sinus, which, if patent, should not be damaged and opened, which leads often to a subtotal resection of this tumor group. And of course, the same applies to the structures or the sinus which are draining into the confluence, like the superior sagittal sinus, the straight sinus, the transverse sinus, and of course the tentorial sinuses, which are actually not imaged very well on preoperative images. So this is an example, a 78-year-old woman who had a recurrent atypical meningioma, a great tumor, and she had already a bilateral incomplete hemianopia and decreased vision. And you can see this tumor here, which is from the image looking aggressive, and which was an aggressive tumor, already also infiltrating the occipital bone. And you can see here a classic peritorcular meningioma. She had other tumors along the falx, which were removed in the second stage. And this was the operative cetus before tumor removal. And this is the typical aspect of this grayish and soft aspect of an atypical meningioma or malignant meningioma. which was occupying both the supra and infraterritorial spaces, as you could see on the pre-op MRI images. And this is after removing the tumor along with the infiltrated and completely occluded transverse sinuses on both sides and part of the straight sinus also. So this is the MRI after tumor removal. The bone also was removed as it was infiltrated and replaced by Palakos. And these are the images, and also the tumors along the falx were resected in the second stage. And this is the patient after surgery. She did not deteriorate, and even her vision after a temporary deterioration became better than the pre-op condition. So the last group, which is the falcotentorial meningioma group, the T3 and T8 group, there are two classic approaches, which are the occipital and the supratentorial infratentorial approach. The occipital approach can be extended using a transtentorial and also a transfalcine extension, which gives you the opportunity to go contralaterally. And in these approaches, beside the complication I already showed you in the previous group, which is calcarine area, which you have to take care of, the main issue in this group are the veins, which is the vein of Galen and its entrance into the straight sinus, the internal cerebral veins, the basal vein of Rosenthal, and of course the tentorial sinuses during cutting the tentorium in a transtentorial extension. So this is one example. It's a small tumor, but nonetheless it was symptomatic in a 71-year-old woman complaining of dizziness, which is unspecific, but she had also visual disturbance and mental slowing. In this group, it is interesting that mental slowing is a quite common symptom. And you can see that the vein of Galen is actually depressed by the tumor. So in this case, normally I would recommend an occipital approach, but as the tumor is under the line of the straight sinus, and also the tentorium is not steep in this patient, so this is the supracerebellar infratentorial approach is a nice approach in this tumor. So this approach, the infratentorial supracerebellar approach, was originally described by Fedor Krause in 1908, a German neurosurgical pioneer. And this is the approach, this typical aspect. This is before resection of the tumor. You can see the venous structures here and the tumor in front. You have to take care not to injure them. This is after resection of the tumor, leaving these veins intact. And this is an endoscopic control, which can beautifully show you also the angled 30-degree. You can see the upper part at the junction of the vein of Galen with the straight sinus if there are any tumor remnants, which was not the case in this patient. So this is the MRI after surgery showing a complete tumor removal. And this is the patient after surgery. Of course, you can use the same approach also in larger tumors. It takes a longer time. So what were the surgical results? Usually a complete tumor removal as a Simpson grade 1 and 2 could be achieved in most of the patients. There was an 18% surgical morbidity, especially in the T1 and T2 groups. And the surgical morbidity mortality of 2%. The follow-up in this group was an average of 7.4 years up to 18 years, and the patient had usually a good outcome with an almost 90% Karnofsky performance score of 80 to 100. And the recurrence rate during this quite long observation time was 11%, and 7 patients had to be reoperated. So the conclusion is that you have to carefully study the preoperative images, particularly taking care about the venous structures and all the approaches, and also keeping anatomic variations in mind. For example, the entrance and the course of the vein of Labé when planning, for example, is a subtemporal approach. And of course, as is well known, the first surgery in meningiomas should be as accurate and as complete as possible, because you have the chance that the arachnoid is protecting the important structures. But of course, there should be no aggressive removal of tumors from the critical neurovascular structures. And as I've shown you, a patent venous sinus should not be usually opened like the transverse sigmoid sinus for resection of these tumors, only if it is completely occluded. So that's my final image. Thank you very much for your invitation and for listening.
Thanks, dear Bo, for your excellent presentation. Is there any questions from panelists? Okay, we have prepared other Zoom link to launch.
Yeah, please, Hirsham, I think you know what it is. It's another Zoom room. I'm going to send you a link. And you go to that Zoom room to be with the students.
Okay. Thank you very much.
You have to leave this Zoom room and you go to that one.
I will.
Okay, Sam.
Sorry for that.
Back to you, Sam. Okay, Sam.
Okay, Professor Foolish is our next speaker. Please start sharing your screen.
Can you hear me? Okay.
Yes, it's okay, sir.
Thank you very much. I had an issue with the Zoom link. I'm sorry for that, but you find the solution. So I changed my name. I took your name now. So
it's okay. Yeah,
that's perfect. That's perfect. Let me share my screen. That was a very clever move. Okay, so thank you very much for bringing me to this webinar. I will talk about the treatment strategies for skull base and craniocervical junction chordoma and what we have been changing in the way to treat those tumors in the last few years. So our experience is based on a significant number of chordoma, mainly skull base and craniocervical junction. As you know, extent of resection is an extremely important factor for chordoma. In fact, it's still the most important prognosis factor. Radiation therapy is also extremely important. It's a quite radio-resistant tumor, and proton beam therapy is definitely the best option. We have the chance to have proton beam therapy, so we offer it to the vast majority of our patients if they had never had radiation therapy before. Extended endonasal approach is a great technique for chordoma. It's a midline tumor, so it makes a lot of sense to come from the front. It's probably the most direct way, easiest way to get to the clivus. So it really took an important space in the treatment options of chordoma in the last 10-15 years. However, even if it looks like a minimally invasive approach, when it comes to treat a chordoma, you need significant work into the nasal cavity, a lot of resection of normal tissue, the use of a nasoseptal flap to close, resection of pharyngeal tissue if you are working at the level of the craniocervical junction. And all this has a cost for the patient. Endonasal morbidity, velopharyngeal insufficiency at the level of craniocervical junction, mastication difficulties if you go into the infratemporal fossa working around the pterygoid muscles, and hearing issue if you work next to the Eustachian tube. And still for chordoma patient, the issue of closure is not solved. We have much better results for pituitary adenoma, obviously, tuberculum sellae meningioma, craniopharyngioma, but at the level of the clivus, it's still a challenge to close the clivus or to close the dura of the craniocervical junction. This is our series in 2016, and you see that we had 18% CSF leakage, which is significant. And considering chordoma patient, you should not forget that after surgery, patient will have a significant amount dose of radiation, 74 gray, and all this make radiation make all the symptoms much worse for the patient. So with endoscopic technique, it's like for any approach, whenever you push the limit, you increase the morbidity of the surgery. It's the same either for open or for endoscopic endonasal. So what we are trying to do is to have better results, to reduce the morbidity of the treatment. And the ways to adjust, to reduce the morbidity is first to adjust the strategy according to the tumor behavior. We know that there is different types of chordoma. Some are quite slow growing tumors, some are very aggressive, and probably we should not offer the same treatment to all patients. Secondly, less aggressive approach going through the nose is fine, but we have to try to reduce the aggressiveness of the endoscopic endonasal approach and to really come back to the true meaning of endoscopy, which is to go in a deep cavity without disturbing the way to get into this deep cavity and using angle scopes. We also have to improve dural closure, finding new ways to improve the closure, and maybe to better select the approach. Chordoma is a midline tumor, but endoscopy is not always the best option. So about prognosis factors before treatment, because this is what it would be the best for surgeon, is to know before the surgery if you have to be aggressive or not. And we have looked and published recently this study on growth rate before surgery. We were following the patient for 2-3 months, looking at the volume and looking at the growth rate of those tumors. And there is a correlation between the growth rate before surgery and the prognosis of those patients. It's a very simple way to have an idea of how aggressive is the tumor before to decide for the surgery. It was not done on a big number of patients. As you can see, we still have to validate this on a higher number of patients, but this is what I do now to adjust my treatment strategy before any kind of surgical decision. We participated to this study with the Toronto group of Gelare Sade, looking at the methylation profile in the plasma of those patients. And this also gives some indication on the type of chordoma you are facing before making your surgical decision, which is definitely something important for the patient and for the risk for the patient. So this is another way to look at the methylation profile of the plasma to have an idea before making a decision. Once you have done the surgery, obviously you have the molecular biology. You can look at a lot of parameters into the tumor to adjust also the next step of the treatment, radiation or not. And we had this beautiful study from the Pittsburgh group that distinguish different groups according to 1p36, 9p21 profile and adjusting the treatment. So we are now looking on some other markers in my group, but definitely in the future, we will have options, we will have criteria to adjust before surgery, after the surgery, the treatment according to the biology of the tumors. Minimally invasive approach, what could we do to get better results for those patients? Well, I have been using in the last 15 years, I would say, these techniques where I hold the suction, I hold the endoscope in the same hand, and I hold my working instruments with the right arm. The goal of this technique is to preserve the anatomy of the nose, and the smallest is the cavity I am working in, the easiest it is for me. I use a very specific suction, malleable and rotative suction, and this is absolutely key for this technique. You need this specific suction. And as I said, the endonasal structures serve as a buttress for my endoscope. I don't grab, I don't put any strength holding the endoscope. I just support it, just like middle turbinate, inferior turbinate support the endoscope. It can only go in one direction, and it is the same for my suction. So again, with this technique, the smallest is the corridor, the easiest it is. This is an example of what you can do. You can see that you can have quite precise movements because in fact, I am not holding my instruments. I am just guiding my instruments. They are supported by the endonasal structures. So what I lose because I don't have two hands in terms of dexterity, I gain it because my instruments are already supported by endonasal structures. This is definitely a technique that requires to use angle scope. I always use 30-degree scope, sometimes 45 and sometimes 70-degree scope. There is those new scopes where you can change the angle also, but the definition of the image quality is not great enough, I believe. But still, you can see here that I'm really turning around the paraclival ICA, looking above the petrous segment of the ICA. So using this technique, you need angle, malleable instruments, and angle scope. Second step in our effort to reduce the morbidity of the approach is to consider that the rostral mucosa is in fact like the skin in open approach. It's a skin that you incise and that you close when you finish the surgery. It's your door to get into the sphenoid sinus. Once you are into the sphenoid sinus, you remove the mucosa, you remove your tumor, you take advantage of the space of the sphenoid sinus, the space given by the tumor resection. And at the end, once you have removed the mucosa of the sphenoid sinus, you have cranialized it, you put some fat into it, and you suture the skin of the rostrum, the mucosa of the rostrum. I believe it's definitely the best way to fight against CSF leakage, and the morbidity for the patient is very limited because we don't do anything into the nasal cavity. We just push laterally the middle turbinate. This is a drawing, a cartoon showing this on a cartoon. You see here that we have cranialized the sphenoid sinus, we put some fat, and at the end, we suture the mucosa. This was a case of a patient, 51 years old. He had a biopsy before. He had a nasal perforation. This was the first case where I did this technique. And in fact, I had no option as a flap in this patient. So I had to find another way to close at the end. So this was how it looks with this nasal perforation. I was not sure I could have a patent septal artery. So I just did this incision of the rostrum, rostral mucosa, and then I drill the rostrum and I get into the tumor through the rostrum. So it takes a little bit of time and specific instrumentation, specific drill to take advantage of the bone volume without injuring the mucosa around. But once you are into the tumor, then you can also take advantage of the tumor cavity. Here, I am below the sphenoid sinus. I went below the mucosa of the sphenoid sinus because the tumor was in the mid and lower clivus. And once you reach the tumor, you can progressively take it away, find laterally the Vidian canal, using neuronavigation also to orient yourself. You have less landmarks than when you do a large open approach. So navigation is extremely important in those cases. And once you found Vidian canal and lacerum segment of the ICA, then you're quite safe to go directly into the tumor to resect it progressively with Ranger. So this is here the tumor. I'm going a little bit fast with the video. Progressively using angle scopes, angle instruments, my label section, I took away this tumor. I am still below the sphenoid sinus. The sphenoid sinus is not open. There is a little leakage here due to the tumor that was crossing the dura. Not so much, just a little bit. I peel the dura also to take the infiltrated layers of the dura out. And at the end, I put a piece of fat into this tiny hole and another bigger piece of fat into the surgical cavity. And how to close? Well, I use stitches. This was a technique I used before with this hangman node. I have to say that I have changed the technique now, but I progressively stitch this thick mucosa of the rostrum. The advantage of the mucosa of the rostrum is that it's quite thick and you can quite easily suture it with a resorbable stitch. It's much easier to stitch this mucosa than stitching the dura itself, which I have done in the past to avoid CSF leak, and it's much, much more challenging. So here we did a kind of watertight suture of this rostrum mucosa, and the outcome for this patient was great, not only because he didn't leak, but also because the mobility of the endonasal work was extremely limited. It's like we did nothing, in fact, into the nose. So we did a lot of patients like this. This is a cartoon of this specific patient. You see that we went below the sphenoid sinus. We did more patients. This was the post-operative scan of this patient. You can see that the nose is almost intact. This is another case of a lady, 32 years old. She had a 6. The tumor is more extensive, but in fact, with this technique, the bigger is the tumor, the best it is, because it gives me some space to work. Same principle than for some open approach. You use the tumor volume to work. So we did the same incision on one side of this mucosa that was bulging because of the tumor. The incision should be made not too far deep. It should be done just at the junction between the septum and the rostrum. Like this, you can push it on the side. And then progressively, we drill the rostrum, take all the mucosa out of the sphenoid, get into the tumor. Chordoma is a soft tumor in the vast majority of cases, so you can take it out quite easily with strong suction and Ranger. So progressively, we take the tumor out. We are here on the petrous apex with a 45-70 degree scope. You see the petrous ICA. We are looking down with a 45 degree scope to make sure that we took everything out. And at the end, a big piece of fat into this cavity. On the same, we stitch the mucosa that we have incised at the beginning. I am doing a running suture. The first node is quite easy because you bring it down just tracting on one side, and then you progressively stitch. And at the end, I was doing a node inside, and now I have to say I have changed my technique. I am doing the node outside, just at the level of the vestibule, which is much, much easier. So at the beginning, it took me maybe 20, 35 minutes to do it. And now in about 10 minutes, the suture is done. This is a post-operative MRI showing you the fat into the nasal cavity. It needs to be discussed with the radiologist, because the way you look at the post-operative images is a little bit different. This is the post-operative images of the nasal cavity in this patient. Another case here, still it's not a big chordoma. I would not say it's a big chordoma. It's not going intradurally. I think I'm going to skip this one, but exactly the same technique. Maybe I go just to the end for the suture. This was a cavity at the end. I quite significantly coagulate the margin of the tumor cavity, but the same way, we progressively stitch with resorbable suction with the fat inside to have a kind of watertight closure. And here I was blocking the node with this little titanium clip, which is also another technique to avoid the node that is quite difficult. This is a post-op images with the fat inside. This case is an interesting case because there was a big intradural extension in this patient. It was a big tumor, 45 years old, 6 nerve palsy. Surgery, same way, chopsticks technique. We are just pushing the middle turbinate on the side. Incision here along the rostrum on the posterior aspect of the septum. Yes, on one side, I am creating this opening. You have to be careful with the mucosa because you should not forget that you will have to close it at the end. So if you lose some mucosa, it will be more difficult to stitch. And again, using the chopsticks technique, I have really my endoscope next to the tip of my instrument. So I don't need space. Again, as I said at the beginning, the less space I have, the easiest it is. So I am progressively resecting this tumor with ronger, with suction, whatever you need to take it out. And progressively, I look on the corners with angle scope. You can enlarge the corridor at the level of the rostrum with a little bit more of drilling. Here are the dura, the carotid on the left side. I am getting down to the lower clivus. This is Vidian nerve on the right side, lacerum segment on the right side, going into the petrous apex on the right side also. Hemostasis with flow-seal, hemostatic agent, nothing special with this. And to go lower, I had to make a little bit more incision down because I could not reach the part of the tumor that was going down in front of anterior arch of C1. Even with a 45-degree scope or 70-degree scope, it was difficult to go down. Vidian nerve on the left side here. Drilling of the pathological bone, everything that looks pathologically infiltrated, you need to drill it. I am at the level of lacerum segment on the left side. You see the carotid artery here between C2 segment and paraclival segment. And at the end, a lot of coagulation of whatever tissue of the margin you can, not coagulation too close from the nerve. But on here, final steps is to peel the layers of the dura that seems to be infiltrated. I am not largely opening the dura if I feel that I have a thin layer remaining of a barrier. I don't think it's worth doing it to increase the risk of CSF leakage in those cases where you cannot do an en-bloc resection anyway. So at the end, I put a big piece of fat. On the same way, I am here stitching the mucosa the same than before. And this is a case where I did the final node, I believe, outside. So I cross the septum, and from the other side, I come to the front, and then I do the stitching just at the level of the vestibule anteriorly where it's much easier. So you have this stitch here going along the septum on the other side, and the node is here in the front. I had some other cases, but I think I will stop here. You see here the post-operative MRI of this patient. The endonasal cavity is absolutely the same. So I would not say it's perfect, but we are making progress in less morbidity for the patient post-op, and I strongly believe that this is what we should work on now. Approach selection is also very important for skull-base chordoma. As you can see, 2000, 2009, a lot of endonasal approach, 2010, 2017, an explosion. It was not good to say that you were not using endoscopy for skull-base chordoma, and one step behind in the latest period where I came back to some open approach, especially at the level of the craniocervical junction. For this case, definitely endoscopy is still the best technique. I will skip the video for the sake of time. I use now the 3F technique for closure. When I am not doing the stitching of the mucosa, I showed you, I am using the 3F technique. It's very clever. It's based on the positioning, upright position of the patient for 2 weeks after the surgery. I have to say, I think it works very well. Approach selection for this one. Endoscopy could have been a good option, but this lady was almost asymptomatic, slight diplopia. It's a big tumor, big part in the cavernous sinus and big part into the cistern. What I was worried of is the super extension with the third nerve completely laminated by the tumor. It was also going quite far on the right side, next to 7 and 8. So a high functional risk in this patient if you go through the nose. So what we did is first an endoscopic endonasal approach, same technique, chopsticks on one side, to take out everything that was extradural. Here we are drilling the rostrum same ways and before. Taking the tumor out, it was quite calcified for this part of the tumor, but not so difficult. The goal here was not to cross the clival dura. I didn't want it to have a CSF leakage in this patient. So you have to stop early enough before to have a CSF leakage. You can see here that I stopped at the level of the hole through the dura through which the chordoma is going intradurally. No leakage, closure is quite easy, same ways and before with fat and some stitching. And then I think it was 3 weeks, 1 month after, I went with an open approach, and it's a petroclival and clival tumor. So the best way for this is to use a combined petrosal approach with those multiple line of sight. We have a special technique now, especially for those cases. We call it mini combine because the skin incision is very limited. We just elevate a little bit of the temporalis muscle, cosmetic mastoidectomy. You see, compared to my fingers, that the bone flap is quite small. We drill here the mastoid process, posterior petrosal approach. The goal is to free the sinus, to push the sinus backward, and inferiorly, it's really a sinus transposition that we are looking for. Here is the anterior petrosal approach. We are coming a little bit more from behind. This is the difference with the classic combined petrosal. It's a more posterior direction for the drilling of the petrous apex, but we don't need the post-meatal triangle to be drilled in those cases. This is more for petroclival meningioma, but for a case like this, we just need this opening between temporal lobe and cerebellum, like you open the Sylvian fissure to widely expose this tumor. I was happy to be like this from a posterior direction with my micro instruments, being able to peel the arachnoid away from the tumor. I think I can achieve a better resection and better chance also to preserve the cranial nerve and the tiny perforators that you see were a little bit adherent to the tumor. There was also some calcification. So most likely through the nose, I may have been able to do it, but I'm not sure I could have achieved such a good functional result. It was not perfect. She had a force postoperatively with diplopia while reading, but it improved rapidly. In 3 months, she was fine without any sequelae of this surgery. I put a piece of pericranium over the clivus. Closure like classic, focusing on the middle ear. So I think I will stop here. I showed you some example of the strategy we are using now. I'm not going over the craniocervical junction because I am a little bit late, but I think that approach selection, minimizing the aggressiveness of approach, working on closure, on having prognosis factor to adjust the aggressiveness of the strategy is definitely what we should work on for those complex tumors. Thank you very much for inviting me.
Thanks a lot, Professor, for excellent presentation. Is there any question from panelists?
So I have to quit this room, that's right?
Not yet, not yet.
You can go for long for more questions and discussion.
Okay.
Hold on, Sam. Okay. What's going on, Sam?
Is it okay? You hear me?
Yes.
Yeah,
Okay.
Any questions from the panelists here now?
Okay, we will shift to next speaker.
Okay, Sam. I think Sebastian. Do you know how the Zoom Lounge works?
Yes.
I gave you a link to your account there, Sam's account. So just take that, leave this Zoom, and go to that Zoom. Okay.
Perfect. Perfect. Thank you, John.
Thank you. Okay,
Fantastic
Sam. Back
work.
to you.
Thank you. Thank you very much.
Back to you, Sam.
Okay, next speaker, Professor Matthias. Please start sharing your screen.
I'm trying. I am not able to share my screen. I don't know why, but
do you have the green button?
Yes.
Okay, we're waiting for you.
Sure, thanks.
Does it look different than normal?
Only 1 minute, please. I think that I need to unlock. Let me check now. Yes, perfect. Can you see my screen?
Yeah, we're starting to see it.
Excellent. Good morning, good afternoon, and good night to my friends. Hi, Sean. Hi, Smesh. Hi, Alvaro, Sebastian, and Sanjiva, and many friends from around the world. I will try to share with you in 15 minutes what I think that is that are the most important things when you need to approach and remove a cranial and a spinal meningioma. Thank you very much for the invitation. The evolution of microsurgical techniques were really incredible in the last 30 or 40 years, and we are really fortunate persons to be doing the microneurosurgery nowadays, because when we watch some books like Walter Dandy books, we can observe that the meningiomas in those dates were removed using the fingers of the surgeons, or with techniques with no microsurgical technique, and not respecting the arachnoidal plane between the tumor and the brain. And as we know, the meningiomas grow by the arachnoid cap cells, and then can grow displacing the brain in the convexity or in the skull base, in the anterior, middle, or posterior cranial base. And we can find meningiomas in other locations, like in the spinal, thoracic, cervical, or lumbar locations. We know through different histopathological studies that the meningiomas not every time are benign tumors, because we have this classification of the WHO grades between starting with the WHO grade 1 to the WHO grade 3. And when we need to approach a tumor that looks like a meningioma in the MRI, we should be aggressive, because sometimes we can remove meningothelial meningiomas, but sometimes we can afford tumors like rhabdoid meningioma or anaplastic meningiomas. And these patients, the good evolution of this patient is close related with the total removal of the tumor. We know that the meningiomas displace the cortical surface and the white matter tracts, as we can observe here in this meningothelial meningioma of the lateral surface of the left hemisphere. There are different locations of the meningiomas. We can observe meningiomas located in the skull base, in the anterior, middle, and posterior fossa, in meningiomas arising from the falx, meningiomas located in the lateral surface of the brain, and intraventricular meningiomas too. This is an anatomical representation that we can observe the different classification of the skull-based meningiomas. We can find supraorbital meningiomas, tuberculum cellular meningiomas, planonephrenoidal meningiomas, and olfactory group meningiomas, sphenoid meningiomas, clinoidal meningiomas. And as we know, the classification is in close relation of the points where the meningiomas grows. And we need to know, we need to remember when we are planning to approach to remove a meningioma, that the meningiomas grows from the arachnoid membrane, but are in close relation with the dura mater. And it is very, very, very important, because we need to know how is the vascularization of the point where the meningioma grows, and it is really important to take in mind in order to attack the meningioma in the points where is attached in the dura mater. In this way, we will remove the dural vascularization that in some cases, in some meningiomas, is really, really important. For example, here we have another kind of meningioma. This is an intraventricular meningioma that is located in the atrium, of the lateral ventricle. This is another rare case of meningioma located in the third ventricle. This is a young woman with headaches, vomiting, and some kind of disturbance with the movements. And here we have an endoscopical removal of a third ventricle meningioma. The first step is to communicate both lateral ventricles, performing a septostomy. In this way, we can communicate both ventricles in order to avoid or prevent the hydrocephalus in the postoperative period. Here we can observe the anterior septal vein, where it is a really important landmark when we perform intraventricular surgeries, because it's in close contact with the thalamocaudate vein that is important to preserve. Here we can observe the lateral surface of the meningioma. We try to coagulate the surface of the meningioma and to detach a small portion of the meningioma that it's in close relation with the choroid plexus. It is important to remember that the intraventricular meningiomas grows from the choroid plexus, and we need to try to preserve intact the choroid plexus in order to avoid intraventricular bleeding that is really, really complex to remove the tumors when we need to approach the tumoral resection through the through the endoscopic vision. Sometimes we can approach this intraventricular meningioma using the endoscope, or sometimes using microsurgery directly. This is the postoperative view. And this is some of the lessons learned in the last years, being in contact with some neurosurgeons, with my own experience, and observing professional methods, how he think when he need to operate a meningioma. The first suggestion is to remove as much bone as you can. If it is possible, attack extradurally the tumor. If you have, for example, an sphenoid wing meningioma, as Alvaro will talk in the next talk, it is important to think that if you can attack the tumor using an extradural corridor, it will be you will be able to devascularize the tumor, and the intradural step, it will be easiest. If it is possible, decompress the nerve first. For example, in cases of tuberculum cellular meningiomas, if you can decompress the optic nerve first to mobilize the tumor, it will be better for the optic nerve recovery in case of some deficit in the visual prior to the surgery. Preserve the arachnoid plane. It is very important to preserve the arachnoid plane. This is a law when you need to operate meningiomas. Surround the tumor in all the borders, in the lateral, medial, superior, inferior border, by coagulating the surface, and debulk the tumor to easily mobilize the tumor itself. It is really important. This paper, I think that it's a landmark paper for approach, especially the skull-based meningiomas, because you need to know how is the vascularization of the dura mater when you need to remove a tumor. And it is really important to perform big craniotomies if you need to approach big meningiomas. It is really, really important. If you need to operate, for example, an olfactory groove meningioma, it is important to perform big craniotomies. It's important to remember the skull-based anatomy, the preoperative studies. You need to observe how the tumors grow inside the different foramens of the skull base in order to select the best approach, the best technique, the use of the endoscope or not, to support your microsurgical skills inside of the surgical room. For example, here we have an olfactory groove meningioma where we perform a huge bicoronal incision and bifrontal craniotomy for a complete removal of this meningioma. Here is a huge, an 8 centimeter for 8 centimeter lateral convexity meningioma, where we need to preserve the brain using cottons. When we separate the arachnoid plane from the surface of the meningioma, we try to put cotton in order to protect the normal surface of the brain that sometimes is not so normal, because in this sector the brain have edema or loss of the arachnoid membrane, in order to remove this huge tumor. preserve the arachnoid plane is one of the most important things that we need to remember. Try to plane your craniotomies, thinking where the vascularization is located, and try to think if your tumor could be resected through a transcranial approach or transnasal or endoscopic approach, or a combination between that. For example, if you have tuberculous-cellular meningioma, we can remove it using a supraorbital approach or transciliar or a pterional approach, and select your craniotomy. You can use a bicoronal approach too, and it is really important to think how we try to remove this using the different approaches in base of the preoperative studies. And we need to, if you need to remove this tumor, you need to think if it is possible to perform the tumor debulking. If it is necessary to treat the tuberculum cellular, it's important sometimes to remove as much bone as possible in order to avoid the recurrence of the tumor. Remove the tumor first, or after to remove the tumor first, or decompress the nerve first. This is another question that we need to do ourselves when we need to remove this, for example, this tuberculum cellular meningioma. The anatomy is the first that you need to have in mind. What structures of the skull base we will find during the tumoral resection? The optic nerve, in this case, the tuberculum cellular, and the clinode laterally, and of course the carotid artery. And sometimes these tumors grow inside of the optic canal, and we need to deal with some small pieces of the meningioma that could be located under the optic nerve and between the ophthalmic artery, of course. This is a case in order to show a tuberculum cellular meningioma resection, where we can observe that a lateral pterional approach was performed, and a transsylvian approach was performed in order to achieve the tumoral localization. In this tumor located in the tuberculum cellular meningioma, it is impossible to achieve the tumor extradurally using a transcranial approach, its localization. And the dura mater should be resected after the tumoral resection. We can observe that the tumor is compressed by the nerve is compressed by the tumor growing medially to the optic nerve, and it is important to think we should try to remove the tumor or to decompress the nerve and then work into the tumor. We selected, this case was operated with Alvaro some years ago here in Buenos Aires, and we selected to decompress the nerve before to work with the tumor, because the nerve was really compressed by the tumor located medially. In this case, we select this microsurgical technique in order to prevent more damage of the nerve prior to work with the debulking process and everything that you know. This is the postoperative MRI scan. This is another case of meningioma of the tentorium. This is the tumoral exposed, and we can observe a reddish surface. And we think when expose these tumors that this surface is really vascularized, and you need to coagulate the lateral surface, the inferior surface, prior to debulk the tumor. You need to coagulate the surface in order to avoid bleeding during the tumoral debulking. This tumor is really difficult to remove completely if you don't perform an intratumoral debulking. And after the coagulation, we can observe a surface really white without so much vascularization, and it looks like it don't look like a meningioma really. It looks like fat. It was a meningothelial meningioma. Here we can observe a bifrontal craniotomy performed for remove a huge olfactory group meningioma, Here we can observe the tumor. The frontal sinus, the sagittal sinus was cut in order to create and only one window between the both medial surfaces of the frontal lobes. And here we can observe the exposure of the anterior surface of the tumor. This tumor is really vascularized because the tumor received many arterial feeders from the anterior skull base, and we try to coagulate the surface. And we performed a hole with this 11 scalpel in the center of the tumor and started with the use of the ultrasonic aspiration, and the hole is first it is a small hole, and we perform a medium hole and a huge hole in the center of the tumor in order to collapse the walls in this hole, and it turns a tumor more easy to mobilize between the two frontal lobes. This is another case. We can observe another olfactory group meningiomas. We try to preserve the arachnoid membrane. Try to preserve the arachnoid membrane is very important in order to protect the normal surface of the brain with these small pieces of cotton. We surround the tumor. The places where the tumor is white or yellow, we know that in this part there are not so many arteries and veins, and in this case, in this medial surface, we have a reddish surface, and we try to coagulate prior to devascularize this tumor using a debulking. Here we are coagulating the arteries that are in close relation with the base of the tumors, and after to devascularize the tumor, it is easy to mobilize from one side and to the other side prior to remove the whole piece of this huge olfactory group meningioma. This is another case. The tumors, the meningiomas could be located not only into the cranial space. This is an C6, C7 spinal meningioma. We perform a lateral approach, a posterior, but a lateral approach only in the left side of the cervical spinal cord. We need to cut here the dentate ligament in this region. And here we have the C6 roots of the left C6 nerve. And this is the lateral surface of the tumor. Here is the medulla. We need to coagulate the tumor in low intensity bipolar forceps. This is very important because the temperature could be spread to the spinal medulla. And here we are coagulating the point where the tumor is attached in the anterior dura mater of the spinal cord. And this is the tumor removed in only one piece. Thank you very much. And I want to thank to Professor Almefti for the lesson learned during my time in Brigham in Boston. Thank you very much, Samet, for your kind invitation. It's a huge pleasure to be with you and to be with so many friends from so many countries.
Thanks a lot, dear Matthias, for your excellent presentation. Is there any question? Okay, we'll shift to next
Sam,
speaker.
let me make Matthias, I'd like to invite you to the Zoom lounge. I put a link in your chat. Okay?
Okay.
Just copy the link and leave this Zoom. In other words, you're changing Zooms.
Okay, can I change it now?
Yeah, no, you have to leave this room. So copy the link. You see the link there?
Yes.
Yeah, copy that and then leave this Zoom.
Perfect.
Okay, we'll see you in the lounge. Okay, back to you, Sam.
Yes, thank you, bye.
Thank you.
Professor Cambero, please start sharing your screen. Thank you.
Hello, is it okay, my screen?
Yes, perfect.
Okay. Hello, everyone. First of all, thank you very much, Professor Sameh Hassan, for the invitation. It is a big pleasure and honor to be here. And now I'm going to talk about why to perform mini peeling for sphenoid wind meningiomas. And we have different kinds of sphenoid wind meningiomas: lateral, medial, small, big, with a lot of hyperostosis, just tumor, bilateral with a big edema. But in general, when we are trying a meningioma, any kind of meningioma, we want to decrease the tumor vascularization, also to achieve a complete resection, symptom grade 1, and also we want to avoid vascular and nerve injuries. So I would like to talk a little bit about anatomy, and the dural wall of the cavernous sinus is important to understand some kinds of surgeries. And the lateral wall of the cavernous sinus has two dural layers: an external, it is meningeal dura, and an internal periosteal dura. And between both exists a cleavage plane between both. So this is the external dural layer and the internal dural layer, and a plane, a cleavage plane between both. So in anatomical dissection, this is the external layer, this is the internal layer, and if we remove the internal layer, we can see and watch in a very well fashion the nerve in the lateral wall of the cavernous sinus. So the cleavage plane is important to understand to perform the peeling of the lateral wall of the cavernous sinus in that way. So we can mobilize the external layer outer of the internal layer. And it is important to understand that we have the orbitomeningeal band that we have to coagulate and cut in order to perform the peeling or mini peeling. So the first idea is to decrease the tumor vascularization. In the majority of the case of the skull-based meningioma has two kinds of blood supply: the meningeal, that usually is the main, and also some kind of PL blood supply. So the idea is to cut the meningeal blood supply. And in that kind of tumor, the sphenoid wind meningioma, mainly the big one, has the meningeal vascularization for the middle meningeal artery and also the accessory meningeal artery. This is the foramen spinosum, and the anterior branch of the middle meningeal artery give the main blood supply of that kind of tumor. This is in an anatomical view, the foramen spinosum and the anterior branch of the middle meningeal artery. So we can see a big sphenoid wind meningioma. So we perform, in this case, a transzygomatic approach. First, we perform a mini peeling to expose B1, B2, and a little bit of B3. But another important thing is to coagulate this dura, that is the origin of the meningioma. And after that, we can see that we don't have almost any kind of bleeding, because we cut the external, the meningeal irrigation of the tumor, just the PL irrigation. And we can see the pre-op and post-op, pre-op and post-op, and so on. Second point is we want to perform or to achieve a complete resection, mainly in young patients. So I would like to show another case with the sphenoid wind meningioma with a little hyperostosis, and this is the origin of the tumor. So we have to cut and remove that portion of the dura. So in this case, we perform a pterional approach. We didn't cut, in this case, the zygomatic arch. It depends the temporal muscle, but we have to go until the base of the temporal fossa. We coagulate this dura, and then we start to perform the mini peeling, exposing the inner layer or internal layer of the lateral wall of the cavernous sinus. In this case, we are coagulating and cutting the middle meningeal artery. Then we go intradural with the tumor and to perform the bulking with the ultrasonic aspiration. We can see that almost nothing of bleeding. We can see here. But another important thing is to cut this part of the dura in order to achieve a Simpson grade 1 resection of the tumor. This is a final view. Of course, it is a little bit more difficult to close the dura. We have to put some piece of fat, but we can achieve a Simpson grade 1 resection. The pre-op and post-op, pre-op and post-op, and the same in the coronal cut. Another case, another meningioma, a lateral meningioma, but with the high hyperostosis. And first of all, we perform first extradural to drilling all the hyperostosis, but also to coagulate and cut the orbitomeningeal band and to perform a mini peeling and to coagulate that portion of the dura in order to devascularize and also to perform and achieve a grade 1 Simpson resection. Now we are going intradural, and now we are cutting this portion of the dura, so we have to separate from the bone and also in some cases to the inner layer of the lateral wall of the cavernous sinus in order to achieve a Simpson grade 1. And this is the post-op CT scan. The third important thing, that our philosophy is to avoid vascular and nerve injuries, especially and mainly in clinoid meningioma like this case, like I would like to show you, with the carotid artery inside the tumor, with the some problem with the eyes in that case. So first we go extradural in a pterional approach. We drill the sphenoid wing. We can see very well the lateral portion of the supraorbital fissure. That means the orbitomeningeal band. We coagulate and cut, and we perform the mini peeling. Why mini peeling and not peeling? Because we don't need to expose all the lateral wall of the cavernous sinus, just a little bit. Then we are going to remove extradural the anterior clinoid process. We are drilling and exposing the clinoid segment and so on. Then we cut the dura and go intradural. We can see the tumor. But the problem is if we go intradural, it is difficult to know where is the internal carotid artery and also the optic nerve. So now we start to work intra and extradural, sometimes intra, sometimes extra. So in the extradural view, we can follow the clinoid segment of the internal carotid artery and also the optic canal in order to recognize the internal carotid artery, this is the internal carotid artery, and the optic nerve open because the tumor is in the middle. So from the skull base, we can go from here to posterior and superior, following the internal carotid artery and the optic nerve in order to avoid some kind of injury. So here we can see the tumor medial to the internal carotid artery, and this is the optic nerve in a rare position. We are working with the ultrasonic aspiration. Now we are looking the posterior portion. This is the third cranial nerve, the last portion of the tumor, and the final view. This is internal carotid artery here. This is the optic nerve here. We remove the outer layer or external layer of the lateral wall of the cavernous sinus. So we have a Simpson grade 1 resection, and also we remove all the tumor without any consequence or any injuries. And this is the pre-op and post-op, the pre-op and post-op, and also in the parasagittal view, the pre-op and post-op. Finally, the conclusions. A craniotomy is so important because we have to achieve access the floor of the middle fossa in the majority of the cases just with the pterional approach, and in some cases with the big temporal muscle, we need to perform a transzygomatic approach. It is important the extradural step, a mini peeling of the cavernous sinus in order to perform a tumor devascularization and also to achieve a Simpson grade 1 resection. And also in clinoid meningiomas, we also perform an anterior extradural clinoidectomy in order to perform intra and extradural dissection and an early recognition of the internal carotid artery and also the optic nerve. Thank you very much for your attention.
Thanks a lot. Thanks a lot, dear Professor, for excellent presentation. Is there any question from panelists? Okay, Professor Pablo Aguilera, are you here?
Okay, did you tell them about the lounge, Sam? Alvaro, I'd like to invite you to the Zoom lounge. It's a separate lounge than this. I sent you the link in your chat. Okay, copy that link and leave this Zoom and go to the lounge. There are some Latin American students there waiting for you.
Okay, thank you.
Okay,
perfect. Thank you, John.
Thank you.
Bye-bye.
Bye. Okay, Sam, it's all yours.
Okay, give me
It
just
looks
a
like
minute
your
to
workaround
upgrade.
worked again, Sam.
To upgrade Professor Pablo Aguilera. Okay, Professor Leo, please start till we get Professor Aguilera on. Thank you.
Okay, are you able to change my screen name here?
You have to
Hold
do
on.
it, James.
Oh, I gotta do it. Okay.
Yeah.
Got it. Okay, great.
There you go.
Okay, can you see my screen? Can you see my screen? How's my volume?
Yeah, it's good. It's good.
Good.
Perfect.
Okay, great.
Perfect, James.
Okay. Well, thank you, Sameh, and thank you, John, for organizing this great event. It's truly an honor to be here. Today I'm going to share with you some technical aspects of facial nerve preservation during acoustic neuroma surgery. And, you know, one of the major treatment objectives when we decide to operate on acoustics is to try to get a gross total tumor removal if possible and try to save the facial nerve at all costs. And here's an example of a large tumor where we got a near total removal, leaving a small residue along the course of the nerve where it's adherent, and we were able to spare his facial nerve. In most recent years, there's been an increased interest in a different concept called adaptive hybrid surgery, where the surgeon has a pre-planned idea of a subtotal removal, leaving residual tumor behind intentionally, and then treating the rest with radiosurgery. And here's an example from one of those papers. And this has some criticisms in the sense that it's encouraging lesser experienced surgeons in non-specialty centers to attempt to remove these lesions using that method. Here's an example of one of my own cases, patient with a large tumor that was attempted debulking by another surgeon. You can see there's barely any tumor removed, and the patient was referred to radiation therapy. Patient became progressively worse, was spastic quadriparesis, and was counseled by a medical team for end-of-life care. Fortunately, the patient was referred to our center, and we recommended an attempted removal and debulking of the tumor, and that end-of-life care was not an option, and that we were able to improve her quality of life. And so we went ahead and did this through a translab approach and removed a good portion of it. I had to leave a residue that was adherent to the course of the facial nerve. And this is 9 years now, 10 years post-op. She became able to ambulate shortly after, and I've been following her for now 10 years now, and she's regained an excellent quality of life. So certainly not end-of-life care. So if you look at the literature of using this subtotal hybrid radiosurgery technique, the review of the literature calls it a nerve-centered approach. And if you critically analyze the techniques, the tumor removal is intracapsular, meaning they stay inside the tumor. And the follow-up is short, but the results look pretty good. An overall tumor control rate of 94% and a facial nerve preservation of 96%. And although the preliminary results look favorable, we have to ask ourselves, are we doing the best thing for these patients? Some of my own personal criticisms include that the subtotal removal is planned, meaning you're saying to yourself, I'm not going to even try to remove it. The debulking is primarily intracapsular, so it means that it's very difficult to estimate how much is left behind, and we tend to underestimate how much volume of tumor is actually left. So it's difficult to accurately assess the volume of the reduction. And this leaves a huge spectrum of different subtotals, and you will see that not all subtotals are created equal. This data is lacking long-term follow-up, so we don't know what's going to happen in the next 10 to 20 years, and we could be creating a new emerging disease. But we're also forgetting about how to teach our younger generation how to do very fine microsurgery, delicate facial nerve dissection, and this is becoming a lost art. And so if we as teachers in major academic centers are not performing high-level skull-based microneurosurgery, then how are we going to teach them to the younger trainees, and how will we be able to perform microsurgery for other complex posterior fossa lesions such as these? And so just like aneurysm surgery, facial nerve acoustic neuroma surgery is becoming a lost art. And so how can we preserve this craft? Let's discuss the subtotal. Does it really matter how much you leave behind? If you look at the literature, the tumor recurrence rate correlates to the volume that's left behind. So certainly the extent of resection does truly matter. And like I said before, not all subtotal resections are created equal. This is my own simplified classification of subtotal removal. Less than 95%, this is the chunk. Between 95 to 99%, this is a little thin carpet. And then if you're 99%, you leave just a linear enhancement that is barely visible, or sometimes not even visible radiographically, even though as a surgeon you know you left some residue. And so how can we still achieve a maximal tumor resection, leaving the least amount of residual, if any, but still achieve the best facial nerve outcome? What are some of the technical pearls? So my personal strategy and philosophy for acoustic neuroma, if we decide to do surgery, is that you have to have the intention of removing the tumor if safely possible. And if you're going to leave some tumor behind, it's based on your intraoperative findings and observations and intraoperative judgment. So the decision is not made before surgery, but rather during surgery. And if we do make the decision to leave some residual tumor, we have to leave the least amount of residue behind and still preserve the facial nerve. So in essence, the final result is a radical near total or a radical subtotal. And so one of the techniques that I think is important to learn is the subperineural dissection technique that was described by Sasaki. And if you look at this diagram, you see how the tumor stretches the vestibular nerve fibers on the periphery, and the perineurium of these vestibular nerves forms a thin membrane that protects the cochlear and the facial nerves on the other side of this membrane. You can see it here, this thin membrane wrapped around the tumor. It looks like arachnoidal membrane, but it's histologically not arachnoid, but it's an arachnoid looking like membrane. And it's like a veil. I call it the holy veil that protects and acts like a buffer to protect the facial nerve. You can see the thin veil of membrane protecting the vascularity of this facial nerve as we're dissecting this tumor. And it's like peeling an onion. So I tell the residents that when you're removing schwannomas, it's like removing a peripheral nerve schwannoma. It's like peeling an onion and undressing the tumor as you peel the layers off of the true tumor capsule. And I do not recommend dissecting into the subarachnoid space. Keep the subarachnoid space intact as much as possible, and this will help protect these nerves. So let's take a look at some examples. This is a retrosigmoid approach for this acoustic neuroma that you see. And here we are opening the IAC. We then begin the dissection distally. Then we start mobilizing the arachnoid membrane off the capsule medially. And you can see the lower cranial nerve down here.
Hey, I tell you, we're moving, man. You know, this Zoom Lounge is a big success.
Hey, John.
Man, oh man, yeah.
John,
it's
you're not
opening, like the networking is great because even the neurosurgery.
So we're now peeling the tumor off of this perineurium and dissecting it off the thin, clear membrane here. This is the perineurium that's going to protect the facial nerve. Now we pick up the vestibular nerve on the superior side of the tumor using a Roten 3 disc dissector to gently peel the perineurium off of the true tumor capsule. You see how this is like peeling an onion and peeling the tumor off of the layers off of the tumor. And then we'll slowly dissect it off of the last portion of the tumor here and get this last portion of the tumor removed. And now we stimulate the facial nerve, and it stimulates at 0.5 milliamps, which stimulates great. And we have a nice removal of the tumor, and we'll use an endoscope here to look inside the internal auditory canal. And this is a nice complete removal of the tumor. Here's the patient initially with a post-op Brachman 2 that improved to a Brachman 1. Now here's another case of a retrosigmoid, much larger tumor, cystic tumor. And we're peeling the tumor here. We pick up the perineurium off the inferior portion pole of the tumor. There's the 9th and 10th cranial nerves. We now dissect the tumor off of the inferior vestibular nerves. We're using the scissors technique to spread and find that fine layer of perineurium off of the tumor capsule. And then we could slowly peel this perineurium off of the tumor capsule using this disc dissector to carefully peel that layer off of the tumor capsule using sharp dissection and then a suction sweeping technique to keep that perineural layer intact. This really protects the facial nerve. Now we work on the superior pole of the tumor, and you can start to see the trigeminal nerve over the top of the tumor, and then we'll use a disc dissector to pick up the perineural layer off of the superior vestibular nerves, and you can see we're now keeping that veil intact. There is the facial nerve that's just beyond the other side of the veil. You can see how this thin veil protects that nerve, so you're not dissecting on the nerve directly. You have a thin layer of protection. And then we can start to follow this layer all the way around circumferentially, peeling this tumor off of the perineurium. Carefully using this disc dissector to push away. And as you get towards the distal portion of the porus acousticus, it tends to have some area of adherence. So this is where I use scissors and sharp dissection. And here you can see we make the decision to leave this tight adherent residue. This is along the course of the facial nerve. You could stimulate it with a stimulator and have faith that the facial nerve is there. It's hiding behind the veil. And this is post-op day 1. This is immediate House-Brackman grade 1 facial nerve function for a large tumor like this. This is a great result. And lastly, we'll show you an example of a translab approach. So this is a tumor that we removed through a translabyrinthine approach. I generally choose translabyrinthine approaches when the long axis of the tumor is indenting the brainstem, and this has the advantage of not using any brain retraction or cerebellar retraction to get to the tumor. And so here we're using the same concepts, the same techniques, using a gentle spreading technique, and then using sharp dissection to incise any adhesions of the tumor to separate it from the adhesive attachments to the brainstem. And so we're peeling the tumor away from the brainstem, incising the arachnoid membranes, and then we want to find that perineural layer here. So here's the facial nerve distally going into the distal end, and then we'll pick up the perineurium layer here on the inferior margin. We'll pick up the layer here on the superior. Here's the facial nerve in the translab approach on the top side of the tumor, and then we'll use this disc dissector and we'll incise these thin adhesions on the side of the tumor to release them. This keeps that thin membrane on the side of the facial nerve. And again, there's very little to no manipulation of the facial nerve. And then here you can see there's a small residue we're leaving right on the course of the facial nerve. It's very adherent. So we'll start to trim it, leaving a thin residue. It's important to use intermittent debulking of the tumor with an ultrasonic aspirator. This allows you to collapse the tumor and to work around it very carefully. And then using the disc dissector to come around the tumor circumferentially. So this is where there's some very tight adhesions to the tumor. This is how you leave a little residue behind while maximizing the extent of the tumor removal. So we're trimming it with scissors very carefully, using very sharp dissection, and working all the way around, leaving a thin remnant behind, and then a small vessel going into the tumor that we'll remove. Now, often you may get little bleeding from the perineural membrane in the resection bed. Try not to coagulate it with a bipolar. You can injure the nerve, so a little bit of gentle Surgicel pressure controls the bleeding. And in terms of repairing translab techniques, I like to use this fascia lata sling technique where I suture the fascia interruptedly. It creates a sling or a hammock, and then you could fill this area with fat graft, and it helps seal off the CSF defect. And then I put a MedPore plate over it for pressure to put fat up against the repair. And you can see this was a House-Brackman grade 1. I left a little residue like I showed you, but radiographically barely even visible. And he's done well. So here are some other examples of different tumors that we removed either through a near total or gross total. And you could see all very excellent facial nerve functions, House-Brackman grade 1. And then again, some examples of large Coos grade 3 and 4 tumors, near total removal, and excellent facial nerve function. So what we're seeing is that we're getting more and more of House-Brackman 1 and 2 facial nerve recoveries. And when we do have some facial weakness, they start to recover as early as 6 weeks. Here's another example. This is a patient with a large cystic tumor we did recently. You can see the immediate post-op day 1, very mild facial nerve weakness, a House-Brackman 2, but look at 6 weeks, already recovered to a House-Brackman grade 1. So excellent tumor removal. This is one where I left too much residual. This had recurred and she underwent gamma knife radiosurgery, but despite this, this continued to grow. So can we treat this even though it's already had radiation therapy? I took her back to remove it, and you could see she had an excellent facial nerve function. This is first post-op day. It's a very minimal, mild weakness, but you could see it recovered fully at 6 weeks. Very early recovery and very nice radiographic resection here, near total removal. This is an example of a Brachman 3. You can see it's not as favorable. There's definitely more asymmetry with a forced smile. And this is one I probably could have left a little bit more residue on the facial nerve to get a better result. So overall, we've had excellent facial nerve outcomes, 95% in the Brachman 1 and 2 category, 0% in the grade 5 and 6. Majority of the tumors we treated were these larger stage 3 and 4 Coos grades with brainstem compression. And you could see for the smaller tumors, we had 100% Brachman 1 and 2. In the larger tumors, it dropped to about 92%, but not by much. And what we also found was that with the increased tumor size, there was an increased rate of near total removal and a decreased rate of gross total. And what that shows is that there's just a lower threshold to leave a residue behind in order to get a better facial nerve result. And there was no impact on the facial nerve outcome whether you did a gross total or near total. Our recurrence rate was roughly 1.5%. Treated with radiotherapy, and the remainder of the patients got yearly MRI follow-up. We did have some complications related to cerebellar edema from retraction, some graft site issues, but no incisional CSF leaks, largely due to our repair technique, which I think is very effective, using a fat graft bolstered by a MedPore Titan implant for the retrosigmoid, and then the fascial sling technique that I described earlier for translab approaches. If we compare our results with the systematic review of the adaptive hybrid surgery, our facial nerve outcomes are similar, but we have very little patients who get radiation exposure. And I would argue that our approach is also a nerve-centered approach as well. So in conclusion, the facial nerve outcomes still can be achieved while attempting maximal resection of difficult, challenging acoustic neuromas. The technique I described of the subperineural plane of dissection is a helpful technique to protect the facial nerve, and the decision to leave tumor behind should be based on intraoperative findings and judgment. And I would argue that this is also a nerve-centered approach to spare the nerve, and we must continue to raise the bar of microsurgical techniques to improve our results. Thank you very much, Sameh, and it's an honor to be part of this excellent symposium.
Thanks a lot, dear Bro, for your excellent presentation. And thanks again for your great help and efforts for putting this congress together. Is there any question, Professor Leo? Okay, thank you.
Okay, Sam, excuse me, if there's no questions, James, I'd like to invite you to the Zoom lounge. I put the link in your chat.
Okay.
You leave this Zoom and go into that Zoom. So copy the link.
Okay. Thank you, John.
Okay. Thanks, James. See you there. Okay, Sam, back to you.
Okay, thank you. Next speaker is Professor Aguilar. Please, Sarah, start sharing your screen.
Hello. Thank you very much, Sameh, because of this invitation. It's really a great honor. I'm talking after James. He's a great neurosurgeon and a great human being. It's an honor for me. He talked about everything about vestibular schwannoma. So I don't know if I have a place to say something more, but I will try. Everybody see my screen?
Yes, perfect.
Okay. have no conflict of interest. So when we talk about acoustic neuromas, the evolution we see in James' presentation has evolved dramatically during the last decade. So now total removal and good quality of life has become the generally accepted treatment goals. So which are our objectives in this surgery? Total removal, no facial palsy if we can, and sometimes, especially in small tumors, preservation of audition. So to achieve this, we need time, we need a lot of time, and maybe sometimes a little talent, as Messi has. So the first thing that I want to say is that anatomic knowledge, as all skull-based neurosurgery, is extremely important. So we have to go to the lab and follow the principles of Professor Rotten to do all the surgeries we made. About the surgical technique for this type of tumors, you can use a subtemporal approach. Most ENT use this approach with small intracanalicular tumors, as you can see here. The transpetrosal, as James showed one case, we use it when we are not trying to achieve a good hearing result, but we mostly use the suboccipital retrosig approach. That's the approach we mostly use. And there's a lot of literature talking about this approach. In my point of view, it seems to be the most versatile corridor. And we don't see higher risk of postoperative pain or CSF fistula with the reconstruction of this approach as James talked. So this is the area, our area of interest, and we always use 7 and 8 nerve monitoring, sometimes also brainstem monitor if the tumor is big, and lower cranial nerves. This is the position we use, the park bench position, and how we make the incision. We made a linear incision, and this is the position we use. The lumbar drain, we never use it, but you can do it. You can use it if the tumor is big. And this is the exposure of the bone. It's very important to expose the asterium because it's a good point to locate the transverse and sigmoid sinus, as you can see in this photo after the craniectomy or craniotomy. This is the way we open the dura. And it is very important that when we open and we take all the tumor out, here you can see the 7 and 8 and the lower cranial nerves. And you can see some lines that stop there. And my friend that talked here today described this line as the Tübingen line. And it's very useful when we have a big tumor, so you can find perfect where to drill the posterior wall of the internal auditory canal in this way. So these are our results, and then I will show you some cases. Now we have a little bit more. And as most of the tumors were T3 in the Hanover classification, because we operate all the T3 and the T4 patients, and T1 and T2 if they grow. Here in preservation, we can see pre-op here. Most big tumors have poor hearing or anacusia, and these are the results. Mostly with the small tumors, it's more easy to preserve audition. Bigger tumors, it's more difficult, only 22%. And as you can see, the House-Bragman, again, as James told us a few minutes ago, small tumors is more easy to preserve the facial function in the post-op. So we get a total removal in 92.7% of our patients, with 7% with a small remnant over the facial nerve. When we cannot take it, we try not to damage the 7th nerve, so we stop. And 93 patients with an anatomic preservation of the 7th nerve. These are our complications: CSF fistulas, 2 post-op hematomas. I will show you one then, and one patient died because of a pulmonary embolism. We published, this is in Spanish, we published our series many years ago in the Latin American Federation of Neurosurgery journal. And I will show you some cases. This T2 tumor is it's very complete, and I will show you in this case everything we do. So look, this is a tumor that grow. This is two MRI with 1 year between one and the other one, and this is the position as we make the incision, as I told you. So we start with the scalpel and then with the monopolar. I will skip a little bit this. And you can see that we made the craniotomy or craniectomy, as what you want, and we open the dura in a C shape, transverse and sigmoid sinus here. The first thing we do is we take out a little bit of CSF, as you can see, to expose the tumor. And when we take out the CSF, we can put a retractor just to work more easy to enter and go in and out with the aspiration, the bipolar, with no damage to the cerebellum. We first stimulate over the tumor in order to check that the facial nerve is not there. Most of the cases it's not there, but there are some cases described with the posterior position of the facial nerve. So we open the tumor. In these small tumors, you can see here the lower cranial nerves, the trigeminal nerve here, and the petrosal vein here. And we start with the debulking. We make the debulking, and then we start mobilizing and cutting the arachnoid plane. Here you can see what James described very well. And you can see the seventh nerve we are stimulating now. We know that there is the seventh nerve, so we have to preserve. We continue with the debulking. And when we finish with all the debulking that we can do by this approach, we go to the internal auditory canal. We drill the posterior wall. Here we are continuing with the ultrasonic aspiration. You can see here the seventh nerve, and then we go and drill. We move the dura there. And after we drill the posterior wall, we remove the tumor that is inside the internal auditory canal. In this case, it was really a good case because you can see that all the tumor goes out. There we can see the seventh nerve here. We cut this big piece of tumor here. So then we left only small part of the tumor over the seventh nerve. And then in that moment, I use the microscope with more magnification, as you can see, to take that tumor out, trying not to coagulate, nothing. So we use, in this case, I'm using two pieces and then we take the tumor that is over the seventh nerve there. So we make, this is the final view. You can see the trigeminal nerve here, 7 and 8, and lower cranial nerves, and the post-op MRI. I will skip this because it's another T1, T2. This is a T3 tumor. Sorry, because this is in Spanish. But this is a 52-year-old girl with no hearing. This was the tumor. Again, the same as I show you in the other case, so I will accelerate a little bit. We take CSF out, we stimulate. This is superior part, inferior part here. We coagulate the tumor. We open the tumor and we start with the debulking. And we start the debulking, and when we think that we finish with the debulking, we try to continue with the debulking because it is very important to, when you mobilize the tumor must be totally shrink. So there you can see the petrosal vein. the trigeminal nerve here. And then we find here, this is the stimulation. Here you can see 7th nerve. It is very important for me when I operate these cases to use a lot of magnification to control bleeding, to see where is the 7th nerve. And here we are drilling, as I show you in the other case. And we take the tumor out from there, as you can see. Sometimes here you have some bleeding. I put the cottonoid, I wait, and then I continue anytime. We follow the plane of the 7th nerve there, maybe with a small arachnoid plane here. We use a lot the ultrasonic aspiration, trying not to pull from the tumor, because it's all that goes to the 7th nerve. I use a lot the probe of the stimulation to dissect. And here we are finishing tumor resection. With good preservation of the fascial nerve. Sometimes I put muscle inside the internal auditory canal. Sometimes I have problems in the post-op MRI with that. And this is the control MRI. You can see here that there's some contrast enhancement, and the patient immediately in the post-op status. This is another, but I skip because I have a lot of cases. And this is another girl with a T3 with a very good recovery of the fascial nerve. You can see that in the immediate post-op, it was not like 3 months post-op, but they recovered completely. Here is a T4, a huge tumor in a very young girl. The coronal and axial view with not too much tumor inside the internal auditory canal. You can see here there is CSF. This is good for the surgery. So here again.
How are you? What are you doing?
We open the tumor and we make the debulking with ultrasonic aspiration. Here you need a lot of time to make the debulking.
Cool. So how you
taking
feeling?
out.
You feeling?
I'm feeling good. We continue with
I just want to talk to you. I mean,
we continue with the debulking and mobilizing the tumor. You can see here this is the petrosal vein, and we try to find the trigeminal nerve there. And when CSF come, it's a good sensation in the surgery. And we try to dissect from above. Skip a little bit. Then we go, when we take all the tumor we can, we go to the internal auditory canal. As I show you in the pre-op MRI, this part of the tumor in this patient was easy. This probe was not the same like the other one. I cannot dissect with this. And this is the most important part when you dissect that plane over the 7th nerve in order to preserve. I use a lot of irrigation a warm irrigation in order not to damage the nerve. And you can see that the nerve is really open by the tumor. And we take all the tumor out. And this is the final view. Again, I don't know if the control is here. Again, muscle inside and this is the post-op. You can see here an enhancement, maybe 1% at same talk of the tumor, and the patient immediately in the post-op and 3 months post-op with no fascial palsy. Of course, these are not most of the cases. This is another huge tumor in another young girl with hydrocephalus. We treat the tumor, not the hydrocephalus. This is the pre-op. I won't show you the surgery, and this is the post-op, immediate post-op MRI. And the patient in the post-op with no fascial palsy again, or slightly fascial palsy, and you can see 3 months post-op with no deficit. These tumors, cystic tumors, are a little bit more difficult to preserve a facial nerve in my experience, of course. I will skip because of the time a little bit, but you can see we do the same, but we find the cyst, and in this case, you can see there the vestibular nerve that is where the tumor comes. So we stimulate the vestibular nerve, and then we cut it. We continue. We use a lot, as I told you, ultrasonic aspiration. What this surgery has that I like very much is that they're always the same. So you can make every time a better surgery. Some meningiomas are all different, so it's not always the same. And here we are trying to dissect from the facial nerve, and we do it, and the preservation was really good in this case. We take we do all the things we do always, but okay, skip that part of the video. This was the control MRI, very good control MRI, but the patient, as you can see, this is 3 months post-op, have a slightly paresia of the facial nerve. Difficult cases in these tumors. For example, ICA over the tumor. I have one case in this young girl with this huge tumor and a lot of tumor inside the internal auditory canal. And when we open, we find this. So I called my wife. I said, I need some extra time for this. I will be late. And I start dissecting the ICA over the tumor with the dura. This is because the subarachnoid artery that goes up, that it's an artery from the ICA. If it's short, the ICA is over the tumor, over the internal auditory canal. If it's long, no. We make a paper about that, then I will show you. So then we find space to start the debulking. And we make the debulking, preserving the artery. Here is the internal auditory canal. We're taking the tumor out there. This is the final view when we put the muscle inside there. So this case, you can find this. It's really difficult. We take a lot of time with this young girl. We put the muscle there. I have this image here inside the internal auditory canal. This image here, maybe tumor, but I have 5 years controlling this young patient with no recurrence or no growing of that. As I told you, this is because the subarachnoid artery. Another thing is that the air cells in the posterior wall of the internal auditory canal, that's what I use muscle. In this case, with the cystic tumor, you can see the CT scan with air cells in the posterior wall. So in this case, what I do is I take all the tumor out, and finally I use, I put the endoscope to try to control the tumor inside the internal auditory canal, so I do not open the internal auditory canal. I think I leave a small piece of tumor. You can see there the endoscope. I don't have the video, but this is the control MRI. You can see that perhaps there is a small part of tumor inside the internal auditory canal. Another thing is the high jugular valve. I have a case, but not here in the presentation. And complication, look at this small tumor. Patient do very well. This was the final view. You have to take care with post-op hypertension, most of these patients. You can see there the hematoma in the cerebropontine angle. We just put an external drainage in this patient, and this was the patient 6 months post-op. But it was very hard to get to this status 6 months post-op. It was like 1 month inside the ICU. It was a very difficult case. About 7 nerve preservation, Shane talked a lot about this, but many authors talk about the bulking and radiosurgery. I think, well, there's a lot of papers published. There's not sufficient papers to say that this technique is good or not. Quality of life of patient with tumor that had to make controls every 6 months or every year is not good. So I think we have to make our best effort to take all the tumor out. Of course, not damaging the seventh nerve because the morbidity with that is really high. This is important. What is the natural history? We never know. They said that with radiosurgery, tumors stop growing. Stop growing, or we don't know if they continue growing or not. We never know. So natural history, we don't know the natural history of these tumors. And there are some report cases of complications with radiosurgery in schwannomas. And this is the Cochrane label that said that there's no evidence that one stereotactic radiotherapy is better for vestibular schwannomas than surgery. So I think that I prefer to make it the bulking. I really think exactly what the same that James said. It's very difficult to control how many tumors you take. And many times you take not too much tumor and then the patient wake up with a seventh nerve. So I try to take all the tumor out. I only do this for old patients. And the best way to preserve the facial nerve is to see it and preserve it. You need time and magnification. So my conclusion is that the goal should be the total removal in one stage. We can do that with retro-sig approach, and the results demonstrate that if we carefully establish educational plans in skull base, excellent clinical and functional results can be achieved in the future. We need training. Thank you.
Okay, Sam.
Thanks a lot, Doi Professor, for excellent presentation. Is there any question from panelists?
Pablo? Hi, good to see you, Pablo. I have just one quick question. Yeah, I really enjoyed your lecture. Very nice videos and technique. I use a similar technique that you show with muscle, but I use fat in the IAC, and I usually at 3 to 6 months you see enhancement of the fat. I think it develops vascularity, maybe the same with muscle. But I found maybe Fiesta imaging can help me differentiate tumor recurrence versus the scar tissue from the fat.
It's a good idea. It's a good idea, really. Yeah, because fat you can use the Fiesta and know if it's fat or not. So I will do it. Thank you.
Sam, are there any other questions?
Thank you, Dr. Pablo. Okay, John, you can announce about.
Yeah, okay, Pablo. Like the other presenters, I'd like to invite you to another Zoom, which is separate from this. It has medical students, matter of fact, mostly from South America, that would like to talk to you in a private setting. So I sent you a Zoom link in your chat box. Just copy that link and leave this Zoom and go to that Zoom. Okay?
Thank you, Jean. Perfect.
Yeah, okay, great. We'll see you in the lounge. Okay,
Thank you.
Samuel, back to you, Sam.
And now, okay. Now we'll shift to the other speaker. Professor Ozito, please start sharing your screen. Thank you.
Hello, I couldn't hear well. It's my turn, right, Sammy?
Yes.
Okay. Thank you very much. I'm going to share my screen. All right. Well, thank you very much. Today we've had amazing lectures all day long and from analyzing different points of view. Today we're going to talk a little bit about management of complex skull-based meningiomas. It's just like some kind of insight analysis of a couple of cases. Thanks a lot for being part of this amazing group with such great lectures, and Dr. Same for the invitation, and also for John Bennett for organizing all this together with Dr. Same. And it's amazing all the what you guys been doing, sharing all the knowledge all around the world. Well, I was thinking about it and just asking myself, which is a complex meningioma or skull-based tumors. We are surrounded of so many difficult cases, and how in a way we can define what is complex. Is it large invasion? Is it sinus invasion? Is it posterior fossa tumors? Is it crazy tumors that go and explode in a way after radiosurgery or different cases? And so we have many different cases, but what is important for young generations? What is important about all this? Sorry, okay. And so one of all of these is the preoperative planning. Okay, whenever we have a trouble or we define it as a complex tumor, it has a lot to do with the operative planning or the inadequate sometimes preoperative planning. That's one of the points. What do? We have to study a lot. Obviously in our courses, what we do is that we study skull base from 3 different points of view, that it's defined in a way for open skull base surgery for the carotid sinus, posterior fossa, accesses like to the transpetrosal approaches and also endoscopic approaches. So what is it that we have to do? We have to have a complete, for young generations, I think that we have to have a complete study of the skull base, analyzing the different angles that we can have in the complete perspective of the skull base in a 360-degree fashion. This is part of our residents in our lab, doing some skull-based approaches, endoscopic approaches. So it's very important that they have to have the access to endoscopic and to microscopic techniques and continue their training always. I'm sorry for the noise. And this is something that we simulate in our lab, that it's like a live cadaver, we call it. In a way, this is our fellow working and dissecting the Sylvian fissure. But all of the sudden, you don't know if it's really in the lab or is it really in the OR because of the live cadaver that we do with the simulating the Abud model. And so it's very important to have all those techniques and share them with the young people. Also, all the complex anatomy, understand the different phases and the cranial and all the cranial points, which are going to be very important, not only in the skull base, not only in the surgery, but all the bony landmarks. It's very important to understand the landmarks in order to have the knowledge and the understanding of what is the best approach that we can do. Obviously, the skull base, we can study it without just in an anatomical fashion, but we have to understand the different relationships, and we have to get with the dissections. We have like a 3D GPS in ourselves that we have to know the anatomical landmarks and the position of all of these in order to, during surgery, have a better result. We have to know the knowledge of the skull base, as I've said previously, in a complete fashion from all around it, from extracranial, intracranial, different angles, and we have to understand it completely in order to be able to analyze each case thoroughly. I will never get tired of saying that we have to have the complete training, either with microscopic and also with endoscopic techniques. Nowadays, we have to dominate both techniques, and we have to be able to offer to the patient whatever of these techniques is needed for that patient, not what we can do. So it's very important. Always.
Excuse me, Diego. Diego, your
Yes.
screen is not full screen, and the slides are not moving.
Oh.
Okay, you need to put it on full screen at the bottom there. Yeah, try again. I didn't want to interrupt you, sorry.
Yeah, I'm sorry. Is this good right now?
This full screen now, is that the proper screen you want? Yeah, sure.
Okay. So as I was saying, we have to dominate both techniques, and we have to offer the patient what the patient needs, but always remembering that the basis of all of our practice, it has to be always the microneurosurgery. It doesn't matter what technique you are using, always the microsurgical techniques, utilizing the anatomical concepts, the microsurgical magnification, and the refined movements in order to have a complete dissection of each case. And sorry, what is going on here? Okay, so going again to the issue about, for example, preoperative planning that I was saying, and all the knowledge that we have to get. For example, in this case, it's a meningioma that doesn't seem to be as complicated or as complex. I'm sorry about this movement of the patient, but it is a meningioma with enough space. We have to know that there can be some relationship with the middle cerebral artery. What is it that we do? It's just like in the lab. We go, and in the OR we do the cadaveric, we do the dissection for the patient. We do a normal, regular terreonal craniotomy. It's very important in those cases, the tumor is already here, so the implant, and so it's kind of bloody. But once you get cleaned up and you devascularize it, you can start continuing the technique. For example, in this case that we are doing an extra dural dissection, in order to, we know that it's a sphenoid wing meningioma, and so what we do is we devascularize it. Always what we do is exposing the orbit as it is seen here. We can see the anterior clinar process and the lateral wall of the cavernous sinus. Doing this, I know that my tumor is going to be completely devascularized. And so in a way, I'm getting ahead of it and taking out that possible complication. Then after that, we go and we open the dura as we are doing here. And now that we can see that we have a devascularized tumor. In this tumor, I like that, even though it's not as complex as we would say, but it has different pearls for young people. It's, for example, the technique that we have to use in order to open the Sylvian fissure or to dissect the tissues. It is very important. And so the first thing was to devascularize the tumor, then opening the fissure. And as we can see here, at this point, it is very important to identify the middle cerebral artery in order, as we can see it there at that point. And that is very important because these tumors are going to be in very close relationship. Now I know where my middle cerebral artery is, and we can have, in a way, a vascular control that we know where it is. Then we can continue dissecting the tumor. We can continue dissecting the tumor as it is seen here. And at this point, I can identify that the tumor is starting to be kind of adherent with the cerebral artery. And so it's very important that we have to have good surgical technique, that we have to be careful in our moves in order not to lacerate or to have a vascular rupture. So at this moment, we put in a retractor, and we can see the bifurcation of the carotid, and we can see that the tumor, even though it didn't seem in the MRI, but it's part of the preoperative planning that I was talking. With our fellows, we have to, even though we have many cases, for example, but we have to be very careful with the preoperative planning and getting ahead of one of these possible problems. In this case, what we decided is to do a little bit of debulking, even though it seemed to be very accessible, but in order to have a better control of the artery. As we can see there, it is very, very adherent, and I'm sure that this could have been a tragic if we didn't have an adequate preparative planning. For example, in this case, we are trying to dissect it. We can see that it is really, really adherent, and we could leave a piece of the tumor, but in a way, we have to take advantage of the microsurgical techniques in order to just leave a very small thin wall attached to the artery, as we can see here. Sorry, I'm going to get a little bit ahead, but that is if you are wondering, no, we did not have a vascular rupture. We managed it in a way just to leave around the artery a little bit of a very thin wall, and then at the end we could remove the tumor and have a complete removal of the tumor. So it's very important to have the microsurgical techniques and the anatomical preoperative planning, and the patient did okay in the post-op. And so that was the preoperative planning. Also very important, sometimes we talk about such big cases, this and that, but we forget about the condition of the patient. These can also be something that is very, very important. For example, we received recently this lady, a 56-year-old lady with a terrible tumor, foramen magnum meningioma, with severe brainstem compression. And the thing is that when she arrived to the emergency room in our hospital, she had a severe quadriparesis and very bad management of liquids, and so they had to intubate her. And as you can see, this is just at her admission. She was intubated. She had severe quadriparesis, and it was she had some lung trouble with the liquids, and so that is a very bad condition for the patient. What is it that we did? She was sent to the ICU. But at the same time, we had the severe rush into operator to decompress the brainstem because she was in very bad shape. And so we do the same thing that we do in the lab. We go and dissect, do a far lateral approach, identify the vertebral artery or the posterior arch of C1 and remove it. And we do the same thing in the OR. In this case, we decided to put her in a sitting position, and we do the same type of incision, and we identify the vertebral artery as it is shown there. We do identify the condyle, and we do drilling of the condyle all the way enough in order to have enough space. And at this point, we are identifying, we are opening the dura. Very important to have enough wide dissection of the arachnoid, as we are starting to do it here. And at this point, we identify completely the tumor. We can see the 11th cranial nerve coming down, and we identify the tumor, and we can start doing some debulking of the tumor in order to work, to have a safer or easily move in order to identify the other cranial nerves. At this point, we are starting to debulk in small pieces as it is possible. As you can see, that the exposure is very important, and the retractor has to be in a direction from below to up, okay, in order to have a good, to have the amygdalas moved in order to have a wide exposure. At this point, we're identifying the dural ring from the vertebral artery, and we can see that the vertebral artery is in our way in order to identify well the origin of the tumor. And so what we do is that something that it's very important is that whenever it's needed, for example, it's important to mobilize the vertebral artery, as we are doing here, in order to be able to attack the origin of the tumor. For example, at this moment, we are mobilizing it, and then what we can do is that we put, I'm gonna go a little faster, that we put a retractor of the artery in order to have a wider exposure. We're identifying the lower cranial nerves there, doing the complete dissection. And as you can see here, with this mobilization, now I can see better this origin of the tumor. Now I have a complete view of the origin of the tumor, and that was my in a way something that it's really shown in this case, that mobilizing the artery can have and will give you a better exposure of the dural attachment, and so it's very important. And then we can continue. We mobilize it upward now, and at this point we can continue with the dissection of the tumor. At this point, we are starting to see on the other side the 12th cranial nerve, the contralateral 12th cranial nerve, and we can continue identifying, and we can see the hypoglossal nerve, the ipsilateral hypoglossal nerve, and we continue with the removal of the tumor, as it is shown here. And at this point, we continue the debulking. There's the 12th cranial nerve from the other side, from the contralateral side. And this is very, very important to keep a clear surgical field in order to identify the cranial nerves. And at this point, we can remove this part of the tumor, and we have a completely decompressed cranial-cervical junction, and we can just coagulate the residual implant. And so the patient at this moment, I'm sorry, she's doing well in the third day, and later on, I'm sorry for that, and later on, after a week, she completely improved her hands, her movements, and so it's very important. And the post-operative MRI with the gross total removal of the tumor, as we can see here, the pre-op and the post-op. And that was also for the condition of the patient. And what about the condition of the tumor is another point. It's very important. For example, in this case, the condition of the tumor, she's a patient that is intact. And so in this case, for example, it's a neurologically intact patient with this severe tumor. What do we do? It's also a complex situation. In this case, we had a pneumatized apex, and so we were concerned about drilling and doing the petrosal. What is it that we do? We go back to the lab, which is very important, and we plan in the lab what is it that we're going to do in order to have an adequate reconstruction of the approach. And we come with this pedicled flap that is going to be from the with the muscle, and is going to be attached to a sternocleidomastoid muscle. And so that we do in the same thing. We do it in the lab, and we go and do it completely in the OR later on. So it's very important to have this dual thing where we practice in the lab and then we do it with the patient. We do this kind of incision. We do a posterior petrosal approach initially, doing a supra and infra tentoric craniotomy. As we can see here, we have the semicircular canals, we have the sigmoid sinus, the Troutman's triangle. And at this point, what we do is that we is very important in this point to identify the middle meningeal artery as we are seeing there, and to coagulate it and cut it in order to have a little bit of dissection from posterior to anterior of the cavernous sinus, as we are seeing the V3, and right now exposing the posterior medial triangle of the middle fossa. At this point, we see what we were expecting, the pneumatized apex, and we know that that is going to be our limit. We're going to try not to make it so big, but it was something that it was planned in the pre-op. And we continue with the drilling of the anterior petrosal approach. As we can see here, we are exposing the anterior petrosal approach and the posterior petrosal. And this is the way that we like to open the dura, starting from the posterior fossa to have some CSF out, to coagulate and cut the superior petrosal sinus, and continue the opening of the dura all the way to the anterior petrosal approach. As we can see, here we are exposing the tentorium. It's very important to open it all the way back to the free edge of the tent. And it's also very important to identify the fourth cranial nerve there in order to have a complete opening of the tentorium. At this point, we're completing the opening in the anterior petrosal. We can see there the complete trigeminal nerve, which is very important that it has to be, I like to say it's unlocked in a way, because at that point we can work on either side of the trigeminal nerve. So at the end, this approach is more like going through the trigeminal and not, as you saw there, the 7 and 8 complex. And so that's going to allow us not to have a post-operative facial nerve dysfunction in the post-op. That's the 6th cranial nerve. After we have the removal of the tumor, we continue, as you can see, mobilize through the trigeminal nerve, removing the tumor, identifying the basilar artery. The 4th cranial nerve is intact there. And at this point, we complete the reconstruction. With some muscle, with some duragen, and with the pedicle flap that we practiced at the beginning of the surgery. And we can put some fibrin glue, and that's the reconstruction, and that's the post-operative, immediate post-op MRI with the gross total removal. The patient in the immediate post-op, as you can see, she had a 6th cranial nerve, which completely resolved in 3 months. And so at the end, the conclusions are a thorough analysis, a preparative analysis of each case is crucial. If you're not comfortable doing, if you're not comfortable with that case, it's very important that you get close to your mentors or to someone close to that has experience in order to have and offer the best thing for the patient, either open surgery or endoscopic surgery. That doesn't matter. It's the best. Then multidisciplinary work is very important. It's very important to create a good team. And also lab work we'll never get tired of that. It's very important to do a lot of lab work and to have a good team of fellows and friends in order to have some, this is part of our courses that we do here in Mexico City. And our next course is going to be on microsurgical technique. It's going to be on bypass. And so it's more to develop the microsurgical technique, and whenever we need bypass is very important. It's going to be in live cadaver, it's what we call it, with some bumps. And thank you very much, Dr. Same again, and John for the invitation. Thank you.
Thanks a lot, dear brother, for your excellent presentation. Is there any question from panelists? Okay, James, go ahead.
Hi,
Hey, James.
another excellent presentation from a good friend of mine from Latin America, Diego. Beautiful presentation and excellent demonstration of the videos. I just want to point out for the audience, you know, his technique showing how to leave a residue on the carotid arteries is very important, and it's important to have a good pair of sharp scissors in order to do that delicately and accurately. Can you comment on the instrumentation that you use, Diego?
Yes, thank you, James. It's an honor for me being you here, such a great friend. Yes, definitely. It's very, very important in many places. I guess Latin America is not it doesn't get away with it. That we have to get very good instruments for that. You know, I like always having very sharp scissors and refined instruments in order to have the complete dissection. Those pairs are some of the Takayama instruments, which I think they've worked really well. Also for the dural, it's not an advertisement for, but it works really well for the dural opening and as well to the arachnoidal segments. And so I think it's very important that every neurosurgeon has to have their own materials, because sometimes in their hospitals we don't have the complete or the correct set for this surgery.
You were using the serrated blade, like heavy serrated?
Yeah, serrated. Yes,
heavy
straight
blade?
The straight serrated blade. Yeah. Which
Very
ones do
nice.
you use, James?
I'm still trying to convince my administration to purchase. I may have to just purchase it myself, but yeah.
I had to do that myself. Yeah, I was using Esculap for all the arachnoidal dissection. The regular bayoneted Neurosurgical Esculap micro scissors, but for the dural opening of the tentorium and the things that are heavier, these serrated are awesome. Very, very good.
Very nice.
Okay, Sam, what do you
Okay.
want to do, Sam?
Thank you. I am very happy and glad, honored to have all these brothers, friends, and mentors for 2 long days. We have discussed a lot about skull-based surgeries. It was a great ceremony, and I was pleasured to have all these such faculty and eminent speakers who have learned us a lot. And we are intended to make it an annual meeting. I know it's time for holidays. We may shift it more earlier next year. And I hope all these speakers will join us to learn us more a lot. Is there anyone who wanted to add something before we finish it?
Yeah, Sam, I'd like to say, well, thanks to you for assembling such a great lineup. I mean, that took a lot of work. You know, introducing this Zoom lounge, I think, is nice. The doctors appreciate it, the students love it, because they get to interact with the neurosurgeon rather than just watching a straight Zoom and never being able to talk to them. So we're going to continue to do that. Okay, any more comments from anybody before we close? Okay, if not, Diego, we invite you to the Zoom lounge. I put the link. Did you get the link in your chat there, Diego?
Okay, lastly, I'd like.
Hold
No, I
on,
haven't
Sam. Did you
received
get the
it.
link, Diego?
No, I haven't received it, John.
Okay, let me give it to you. Oh, go ahead, Sam. Sorry to interrupt.
Okay, lastly, I'd like to thank dear brother, Professor Leo, Professor Diego, Professor Kenya Molo, and Professor Hesu for these efforts who helped me a lot to put this congress together. Thanks a lot, dear brother.
Okay, everybody.
Okay, John, you can finish.
Okay, you got the link, Diego?
Yes, I did. Thank you.
Okay, just copy this link and leave this Zoom first and then go to
All right.
that Zoom.
All right.
Okay, Takashi, thanks, everybody.
Thank you.
Thank you, John. And a very interesting seminar. And I'm in Japan. I'm Takashi, Tokyo, Japan. And now from 5 a.m. So I want to go to work now, but a very informative, very excellent lecture. We studied very much in the future. Thank you.
Thank you, Takashi. Okay, everybody,
Thank
we're
you.
going to close now. You can stick around.
See you. Thank you.
Okay, I'm just going to
Okay.
close.